and we will continue to look forward to a great new 2025 program series. As always, we pride ourselves in offering free and widely available high-quality content, and I'm, as a spine surgeon, always very intrigued in learning from this. In 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future. If you want to have CME credits, please do it through the all-access pass.
And we're live in 5,
4, 3,
2,
1.
Good morning, everyone. Welcome to our 11th annual Lateral course. We're live here in Seattle. And I want to thank all the faculty that continue to come every year. So really appreciate, we've got, again, another outstanding agenda with some amazing procedures that we're going to do today. And then I also want to thank our industry sponsors. So obviously we can't do this without industry support. So I want to thank Alphatech, Johnson & Johnson MedTech, Globus, Medtronic, and Mizuho OSI. And obviously the team here at SSF is vital to doing courses like this. And it's amazing, you know, we had this great dinner last night, and I was talking to Dr. Pimenta, who, you know, basically taught me how to do lateral. And it's amazing how far the procedures come, the technologies evolve. And, you know, we're now doing corpectomies, you know, robotic, navigation, and it's only getting better and better. So I think today will be a really awesome course, because you guys will be able to see all the latest and the greatest, and we have the best faculty. So we're going to go ahead and get started. Our first speaker is Dr. Nima Allen, who is actually a neurosurgeon who has done a lot of work in the lateral space, published a lot, and he's going to kick us off with an awesome talk, and he's going to talk about doing multi-level prone. So Nima, welcome.
Thank you so much, Ron. Let's see. Perfect. Thank you for the invitation again. I really appreciate the opportunity to talk about this. I was looking at my talk from last year, and the best part of that talk was when I stopped talking and when we started a dialogue. So I'm going to try to get to this as soon as possible so we can have a conversation about this. First, I'll talk about what MIS deformity is, and then when prone comes in, and then we'll show some cases. Hopefully, we can do this in like 10-15 minutes and do a Q&A. But the MIS technique for multi-level deformity is about the workhorse is to the anterior column. That's where you get your arthrodesis. You get your lengthening of the anterior column that gives you indirect decompression. Also your alignment, and you use the posterior column mainly for instrumentation, but also you have the option to add to that with small osteotomies, direct decompressions via a tube. That is opposed to open, which is, you know, it's all through the posterior column. You shorten the posterior column, your alignment, arthrodesis, everything comes from the posterior column.
We thank you for your interest.
There's a little bit of a difference between like how you pick the patients, more than a little bit, a big difference between how you pick the patients for MIS versus open. In open, because everything is done posteriorly, you have the option to almost call it audible as you're doing the surgery. That you may plan for a big osteotomy, but you can see that you didn't have to do it. You make it a little bit smaller. But with MIS, you kind of have to have an eye for it, which makes it a little bit difficult to select the patients appropriately.
pass will be
So we try to
differentiated
summarize
for residents
the
and
work of the
fellows.
MIS arm of the
And for
ISSG
attending level
in
or
that paper that I
faculty
showed.
surgeons.
This is an algorithm
So
on how
please
you pick
join
the
us,
patients. I'm not going to
in
get
the
into it
future
too
if
much,
you
but
want,
essentially the more
to have
complicated the
CME
deformity
credits,
is, the
please do
less the
through the
MIS
all
techniques
access
become
pass.
applicable, and you have to do it open. So class 1 is purely MIS, class 4 is purely open.
And we're live in 5.
You
Two,
can, again, like I
one.
said, you can add to the anterior column work. This is a ACR classification. You can mimic the effect of a big PSO by combining it with anterior column work. This is a inner body selection. How do you pick A-lift versus T-lift versus L-lift? Obviously, L-lift is the workhorse here, which I'm going to talk about. And this is Dr. Anand's work of surgical checklist, which I found it helpful to kind of have an idea of what kind of difficulty of a case are you getting yourself into. Okay, so that's the summary of MIS deformity. I didn't talk about the prone at all. But here I think where prone comes in. I think the biggest mistake about the prone, I think Dr. Pimentel, you might agree with me, is that people think that it's the same as lateral in a different position, and then you force everything you learn in a lateral trans-psoas into a prone trans-psoas, and it is a very unpleasant experience, and then you just like shut down and you don't want to do it again. Again, I'll finish up, but I want obviously the audience to think about, to comment on this. I was just at a conference in San Diego. Somebody told me, which one would you learn first, lateral or PTP? I said, that's like asking me, should I learn a PTP or a T-lift? There are two different surgeries. I think you should know both, and you should understand that the kind of tips and tricks of how to deal with each. And I think the reason PTP could be a little bit difficult of a transition from lateral to prone is the gravity. I think of gravity and prone as a double-edged sword. It helps you in positioning, but it hurts you in approach. If you don't know about this, and as the first papers came in, everything wants to go anterior, and you get crowded because despite the fact that abdominal content are pulled anteriorly, it crowds your retractor. And in the cases that I'll show, I'll talk about like why I went prone in these cases. Again, I'll leave the dialogue at the end. So this is a case of a 40-year-old male fisherman from 6 hours north of San Francisco, mostly back pain, can't work because of this, has some left leg numbness, and here is his standing x-ray. High PI patient, 73, pelvic tilt is 28. This, I think, is proportionate to the amount of pelvic incidence. Lumbar lordosis is 44, it's a mismatch of 26. A little bit of hypolordosis at L4 to S1 with essentially a normal SVA, no fractional curve. This is the MRI. You can see the degenerative disc disease at each level. I showed the axial images at each level that is affected. You can see the L2-3 disc is the first disc that's normal. L3-4, L4-5, L5-1 all disease. L4-5 has a slightly Mickey Mouse shape. The psoas is slightly anterior. This is a CT scan. I showed a scout view because one of the things that when I first started doing prone, I should step back. I learned lateral trans-psoas first, and then I transitioned to prone. That transition was a little bit hard. And truncal obesity is one of the things I look for. This patient doesn't have a high BMI. It's not a normal BMI. It's like 32, but it's a lot of truncal obesity. I used to shy away from these, but I don't anymore. There's a couple of ways that you can get around this. So degenerative disc disease at L3-4, L4-5, L5-1. Mismatch between high PI and the lumbar lordosis, especially at L4-S1. I started using these pre-planning because I want to get an idea of what correction I can get with these inner bodies without doing osteotomies. So this is what I plan, L4 to S1 ALIF. The reason for L4-5 ALIF, I really wanted to have a lot of lordosis from L4 to S1. This is a high PI patient. I need to have a lot of lordosis. The other thing was that L4-5, the Psoas, I think it's doable, but I have not done a anteriorly transposed psoas in a prone position at that degree, so I didn't want this to be the first. Those are two reasons I chose L4-5 ALIF and L3-4 prone. L3-4, I did a prone trans psoas and then perked the screws L3 to S1. Okay, now a few things about PTP. I talk about three different things I do here and then three different things for the next case that you have to adjust your technique. The positioning equipment is extremely helpful that you can see that you can actually get a huge bend that mimics the same breaking of the bed in the lateral. That's a picture from Dr. Park's case. So that's what I do as well. I basically put the positioners, I wrap the patient, and I really break those positioners to mimic what you do in a lateral. The other thing I do is I use navigation, and I use it for soft tissue navigation because I want to see, I basically use a navigated dilator. I use that after I put the screws in. I can tolerate some inaccuracy in the navigation because I'm only doing a soft tissue. I get through the psoas, I do the simulation, make sure I navigate around the plexus, and I get my K-wire in. If I'm doing multiple levels, I like to do soft tissue navigation at each level, have a K-wire in, and then go back and do my bony work. This was only one level, so get into L3-4 with soft tissue navigation. And this may be a little bit not CME, Dr. Pimenta. I love the two-blade retractor. Sorry. The two-blade retractor, Dr. Pimenta, you designed it, right? Amazing, amazing tool for this problem. The reason for that is when I open it, I know that I've opened it along the length of the disc, and I know that I have the opportunity to put in two shims, which makes it stiffer, and it will avoid all that problem there. When I say gravity can become your enemy, everything wants to go anterior, and I basically open it right on the disc. I know my orientation, I put the shims in, and then I work between the two shims. This is, the screws are in, the ALIFs are done. They didn't save all the images, but you can almost see the two different shims. This is the soft, the round shim, and then the more rigid one. And then the dilators are going in. And then the cage is in, rod is placed. And this is the video. So I wanted to get a lot of lordosis again at L4 to S1, which we did, and at L3-4 I wanted the separation with the foraminal height gain. How much time do I have? Do you have more? 10 more minutes? Okay, good.
Your time.
Okay, good. This is 6 months post-op. So we went from 30 degrees to 41 degrees, 11 degrees without any osteotomies. So this is a more proportionate L4 to S1 lordosis that I wanted to get. I don't have an EOS pre-op, but this is an EOS post-op at 6 months. Yeah, 6 months. All right, another case. This is a degenerative scoliosis without a sagittal plane deformity in a 46-year-old female with purely back pain that happens when she walks. She can't walk for more than 2 blocks. Obviously, she's young. Low PI, different problem without any sagittal plane deformity, a much easier problem to fix. On the MRI, looks like L3-4 is a primary problem, but on the CT, you can see there's degenerative disc disease at 4-5, 5-1, and 3-4. I assess the flexibility of the curve. on a scout view of a CT scan. It's a flexible degenerative scoliosis. All you have to do is put your interbodies in and lock it in place. No osteotomy is necessary. There's no sagittal plane deformity to correct. Again, I use this pre-planned rod. Same plan as the last one, 4-to-1 A-lift, 3-to-4 prone, and 3-to-1 perc screws. A few other considerations. I bring the bed up all the way and I sit for my soft tissue navigation. Once I get my K-wire in, and once my dilator, when my retractor is in and shims are employed, then I turn the bed about 15 degrees and I stand up and I look down the working channel, because otherwise you have to work in a very awkward position. And I use the shim to kind of define where I'm working at. This is one of the problems with the two-blade retractor and the prone position, that the peritoneal contents creep in. This is something I learned from Dr. Uribe. I put basically a barrier around the I-band between the two blades as a barrier to keep the peritoneal contents out. In this case, I didn't do it, so what I had to do is I used my suction. You don't know if that peritoneal content has bowels or loops in it, so you don't want to just plow through it. So I use a suction, pull it out of the way, work through, get my instrument out, and then repeat. With this barrier, you don't have to do that. And lastly, I made this mistake before, unfortunately, that if you don't unbrake the bed, your rod is not going to be right. The pre-planned rod almost helps you to realize that, because if you don't unbrake it, you realize one rod is shorter all of a sudden. That's because you didn't unbrake the bed. So unbrake the bed back to neutral before you put your rod in. 1 year post-op, this patient can walk 5 miles, from 2 blocks to 5 miles. This patient, I did not go prone. I'll explain why I didn't go prone. Mainly because it was first case I did. That was a multi-level MIS kind of deformity in about a month in my practice. So low PI patient with mostly 50% back pain, mostly left leg pain, hypolordosis L4 to S1, mild PI lateral mismatch, has a lumbosacral fractional curve. This is a little bit odd kind of numbers here. Do you guys see if the SVA is actually 112? It doesn't make sense the PT to be 8 degrees. So that made me think that there's something else going on here. So I worry about hip flexion contracture. I worry about the patient has a neuromuscular problem, or the patient is voluntarily leaning forward to release the stenosis posteriorly. Again, assess the flexibility, degenerative disc disease at 2, 3, 3, 4, 4, 5, 5, 1. So this is a patient standing up on an EOS. This is a patient on a scout view on the CT, totally different positions. So again, I think this is the patient just voluntarily leaning forward. So where that PT of 8 degrees come from. As a neurosurgeon, we don't learn some of these things. I like to teach it to my residents. You want to check for hip flexion contracture. You want to do the Thomas test. This patient doesn't have it, so I was not worried about hip flexion contracture. I also noticed that the fractional curve neutralizes without weight bearing. So I'm using the scout view in both AP and lateral to see how the curve behaves with and without weight bearing. So I do this 2-stage. Lateral first and then posterior. The reason I didn't do it prone is because I wasn't sure if I still wasn't sure if I will get the correct correction with the prone only. I didn't want to do any osteotomies, and I wanted to see if the leg pain will go away. So I staged it, stood the patient up, he's standing up straight, his leg pain is better, and then we just went in and locked it. So I gave him the lordosis down at L4 to S1, and this is 1 year post-op. I would say this about this case, that if I've done this now, I feel much more comfortable with prone. I would have probably done this prone as well, knowing that what I can and cannot kind of get away with. But that's actually perfect. 15 minutes, so 5 minutes of Q&A. Dr. Pimenta, I know you have a lot of comments, I can tell. Go ahead.
I have a couple things to comment.
Do you want to bring up one of the patients up, or do you want any of the patients' x-rays up?
Yeah, so in my experience, this mild degenerative scoliosis, in which the patients comes with a major complaint that's stenosis. Stenosis comes from all the levels, but not 5-1. You may say, oh, no, but has a foraminal stenosis. The diagnosis of foraminal stenosis is very hard.
Fair.
And in my experience, avoiding to reach 5-1, even if 5-1 is degenerated, helps in the recovery for the patient a lot. It's a very different procedure when you avoid, especially when you have not that bad sagittal malalignment. I would in several of these cases do just 4-5 and 3-4, maybe 2-3, but avoiding to 5-1, it's good. So another thing is in the first case that you show, when you the 4-5 level was collapsed. See the X-ray, standing X-ray.
First case or?
4-5 was really collapsed. When you place in prone, the 4-5 opens up quite a bit, which shows that the alignment could be corrected majorly from 4-5 and to 3 in the first case. See the two levels? 5-1 has air in the place, but is not the reason of the stenosis. And I'm saying this because we did a study in Brazil a long time ago with laterals, of course, but looking into survivorship of 5-1 when we don't add 5-1 to the construction on degenerative scoliosis with stenosis. And in 85% of the cases, after 14 years, I had to go back to 5-1 in 15%, which shows that I'm not totally wrong, not totally right, but
Sure, yeah.
I would, those patients, usually they are fragile, they are obese, they are old. If you make the procedure just good enough for the stenosis, it's a big win instead of adding the pelvis to the construction once you do 5-1, right?
Totally, yep.
That's one of the commentary that most of people don't think so, and probably Juan also don't think so. Can you comment on this, Juan?
Okay. Before Dr. Uribe comments, so I was trying some of these cases in San Diego, and the comments were, why don't you go to the pelvis? But there's a different crowd, right?
Yeah, exactly. So
why don't you go to the pelvis?
once you go to 5-1,
Oh, yeah.
you consider to go to the pelvis,
Yes,
right?
yeah.
And then starts going big, right?
Yes.
Why you don't go T10 to the pelvis then,
Yes.
right?
Dr. Taylor?
Yeah, I mean, can I just, I know Mark's going to disagree with me because he spent, a year with Linky going to, God knows where. But, what, if you add another level, then you're just increasing the risk of adjacent level disease and pseudoarthrosis. And so you have to go to 5-1 15% of the time. If you add another level, your chance of having a separate problem other than adjacent level disease or something also goes up. And I just think we forget about comparing risks to the patient. And I'm not convinced that the worst thing is adding another level 20% of the time, 5 years later, compared to the intraoperative and the postoperative complications from adding another level initially. I don't have the statistics, but it just seems to me, I think we're missing an opportunity.
Can you, Nima, can you go back to I think the hard thing for me, the MRI, is, I do agree with Dr. Pimenta. I mean, we see these patients a lot. I would say, and this is a question for you, Nima, is trying to figure out what level is the one that you want to go after. But to me, if you're going to do, the hardest thing is do you think that an indirect decompression for 3-4 and 4-5, or do you also open? Like, what's your strategy as far as, because I saw you did perk from the back, so you didn't do any decompression. So how do you fuse those levels? Are you just relying on the anterior column?
I use a navigated burr and get into the
You get into the joints that way?
Yeah.
Because my difficulty always is, how do you, when you have really severe stenosis, you have the facet joints are really arthritic. And then I'm sure if you looked at the sagittals on this, like at
Yes,
3,
there are
4,
sentences, yeah.
4, 5, I mean, you've got pretty severe foraminal stenosis.
Yeah.
It's always a challenge, how much do you rely on indirect decompression? And then what's your algorithm? Like, when do you do midline incision and then perk through the fascia? How do you manage the skin so you don't have 20 incisions?
Yeah, good point. I think for L3 to S1, this patient had, I can get in the L3 4 screws through one percutaneous incision and L5 S1 through another percutaneous incision. So they get kind of like 2 separate or 4 separate stab incisions, 2 up, 2 down. But the question that you had about, that's what I meant, that like with an open, you can always adjust to that. And maybe prone can also have that advantage that if you need to, you can do it direct decompression. But then I kind of like, are we doing MI surgery or why don't we just open it up? When I'm in doubt, I stage them, like I did that last one. That I don't know if I will get away with just indirect decompression. I do it, stand them up, see how the leg feels. If it feels okay, I just hold it in place.
And then how do you decide prone versus just a lateral? What's your algorithm?
Comfort level. Now I'm like more comfortable with prone. And also if I don't have to stage it, I think it's easier to just go prone. One thing I would say is, like I said, really high truncal obesity. And the longest blade that I had to work with was 180. I guess really hard to reach the psoas. And I've had surgeons say, well, it's okay if you don't go all the way through. I don't think you would agree with that. There's two incision idea that you can feel. You have to feel the psoas. I don't buy this that like there's a little bit of peritoneum that's okay. It's like that little bit of peritoneum could be the bowel. So the truncal obesity is one thing. The other thing is that if I have very severely rotated and you can't correct it on the table, that could be really hard because it forces you to go more and more anterior. I don't feel comfortable with those. But if I don't have those two problems, I like to go prone, and it's easier and just get it done and move on instead of staging it in 2 days.
And then one other thing,
Mark.
do you use neuromonitoring for
Yes.
both lateral and?
You mean for navigating through
Yeah.
this plexus? Yeah. EMG, yeah.
Every
Triggered
time.
EMG, yeah. Do you not?
No, yeah, I'm just curious how
Oh,
you
yeah,
set up
sorry,
works.
yeah.
Yeah,
I definitely use, I have to know where the
Yeah.
plexus is, yeah.
great.
Martin had a question.
Yeah, Nima, great talk. And it's so funny, right? You present this at two different sections, and people always go, why didn't you go longer? Why didn't you go
Why
shorter?
don't you do T10 to pelvis? I was like, okay, sure.
I actually had more of a technical question. I go back and forth. When you're doing the prone, do you put the post to your left or do you put it to your right? Because, naturally you can, initially when I learned prone, the reps would say to put it to the right, but then it gets in the way of all the instruments. And then if you put it to the left, like the arm board is there, like how have you decided where you put the actual post to hold your retractor?
I put it to my right side,
Okay.
or towards the pelvis. I think is that what you mean by?
Yeah.
Towards the
Well, I
pelvis.
guess I assume coming from the left side,
Yeah,
that's
yeah.
true. But I guess to the foot or to the arm.
Towards the foot, yeah.
Yeah. And is it just more to get things out of the way? Have you ever tried it to the arm and it's just too
I
close?
actually never
or-
tried it that way. I see your point, like, sometimes I think it get in the way. Dr. Taylor?
I know I promise I won't say anything else all day long. But I think it's a really important question, especially when you use navigation, because if you don't plan for that beforehand, you're going to get blocked. And so I would tell you absolutely 100% PSI is pinned, the eye is at the base, and the arm is up above. And if you're doing a T-lift, I put a retractor. If I'm doing an MIS T-lift, I put that retractor on the opposite side, and I put the PTP retractor on the same side superiorly. It's much easier to reach that way, and then you're not blocking your camera. So I just would plan ahead, way ahead, or you're going to be in trouble, because I know Martin does tons of navigation, so you really got to look ahead.
Yes,
So in the first case you showed,
this one.
you initially did an ALIF and then you turned the patient prone?
Yep.
So why not do, for example, a lateral approach and do both the ALIF and then the sort of the other levels?
You mean lateral position, do ALIF, and then do lateral LTP?
Yep, exactly, yeah.
You can do that. My vascular surgeon, she doesn't like to do it in lateral. To be honest with you, that's the main reason. But that's certainly an option. We good?
Great.
One
more question, yes.
one last question. Any rule of thumb, for example, regarding a male obesity versus female obesity? Because it seems to me that the female is more so pliable, easy to retract as opposed to.
So that first patient I showed, that's a male patient
Yeah.
with huge truncal obesity. That one was like, I was basically at my 180. The second patient had a higher BMI, female patient, but the weight was not in the belly. I could see on the scout view, it was actually in the thigh. Much easier to navigate. So it's not just the BMI number. You kind of have to look at the patient and look at the belly and things like that. I've been burned by that also, I should say. Video visits, they kill me. You do a video visit and they show up, it's like, oh, okay, that's gonna be different. Yeah.
Awesome.
I told you the best part is the dialogue. Thank you.
Yeah, thank you. So our next speaker is a good friend and colleague and one of the OGs for doing this course, Juan. So Juan is going to talk about doing retropleural approaches and getting in the chest, which is something that Juan and the rest of us have been doing for a long time. So I'll just unplug it. Sound good?
Okay, guys, great to be here, and yeah, this course is getting, every year we're just doing it, and I'm excited that the adoption of lateral is getting more and more every year. When this thing started, I remember Dr. Pimenta, we were trying to convince people that actually putting cages from the side works, and they say that, yeah, it works, but only for 3, 4, and above. And the chest was like a no-no. 4, 5 was like, I mean, there is a paper actually by, you guys want to read it, by Nancy Epstein up in New York. She made it, and in a peer review, it said that 4, 5 lateral should be a malpractice, which is impressive, no? And then nowadays, you can tell that, I mean, 4, 5 is like an everyday case for most of the people, you know. All the guys who does lateral in here, how many of you guys don't do 4, 5? Watch, not even a single hand. How many of you guys do 4, 5? There you go. Every day, yeah?
All the time.
Okay, so
Corpectomy.
it was supposedly a malpractice procedure. Well, same thing with the pedicle screws, remember?
Yeah.
I don't know, you were the older guys in here when Dr. Sontag and what is it? Yen, what's his name?
Oh, yeah, Hansen.
Hansen
Yeah.
Yuan. All these guys made a big fight, and
yeah.
then Can you imagine the day today without pedicle screws? That's incredible, yeah. So, and it's gonna keep happening, you know. So the story is like keep pushing, okay? So my talk is about the lateral retropleural approach. What is the C in here? So we're missing the C. Okay, so just keep holding because there is two talks, one about the retropleural approach and the other one about the corpectomy. So I'm gonna put them together. So I prefer to give one a little bit longer, and because at the end the approach is the same. What it changes is at the end is the corpectomy or the thoracic discectomy. Being the corpectomy like easier. So I'm gonna take over the thoracic disc that it's becoming my passion, this procedure, because you help people so much. And in a surgery that I would say, being a microsurgeon being a neurosurgeon and getting all these 7 years of neurosurgery training on the microscope and developing that microsurgical skills, and then you end up using a mallet and putting pedicle screws. And the most complicated one is like a microscope or an ACDF. You're kidding me. So on the thoracic disc, I found actually something that I can use all those aneurysm clippings, ABMs, dissections, all the cap valve, all these things that we were training for many years. And here one of the good participants is Omar. And Omar actually, when I was visitor in Miami, he was a resident there. He gave me, I owe him so much, Omar Jimenez. So I was visitor, barely speaking Spanish in Miami, English in Miami, and he helped me out. He put me in the lab on motomorcos. Oh my God, I owe you too much, Omar. So I learned from him a lot, actually, all the microsurgical techniques. So Omar, this is for you to see how far we're going with this, okay? So as you know, when you're going to take a thoracic disc, the classic approaches are posterior, which is very comfortable for every spine surgeon. They love it because this is, the first surgery that a spine surgeon learn is a laminectomy, yeah? So the posterior position is awesome for us, But the problem is if you're trying to take something from the front, and when you're taking something from the front, you work totally indirect, And most of us, all of us, we don't thoracic disc from the back. So you take the whole facet, you do a huge laminectomy, you take the pedicle down, and then sometimes actually you have to take a root out, and then you start putting a down-biting curette without knowing what you're pushing there. You start pushing things, You're crossing your fingers that spinal fluid is not gonna come out, And I can tell you, all of you guys have lived in that, yeah? And then at some point you're like, we're good, when you see the curette on the other side. And how do you know if this disc is out or not? Who knows, And it's so funny because recently, the case that I'm gonna show you today, that video that I have there, that's edited over this week, one of our partners, this is crazy, one of our partners get this patient, and he offered a posterior approach, and I was seeing how he's gonna do the procedure. He said, including 2-level fusions above and below, big osteotomies, facetectomies, pedicle subtraction, and ligation of a nerve root. Wow. It's amazing when you can just go from the side and, you can do a better job. But anyway, it's an option and it's valid. And the worst thing that can happen is you don't know how to go lateral or anterior, and then you do it. You know what? Keep doing it posterior. At least it's something that you master, At the end, don't forget, dealer's choice is a big deal. Do what you feel more comfortable with your patient. But I can tell you, you have to learn the lateral approach for this. It works amazing, Nowadays, we're using endoscopy also. In my hands, endoscopy, I use it more for soft paracentral lesions. Some central soft. Still the calcified, I'm having issues, I think, because my skills with the endoscope are not good enough, and I think still the technology is not good. You're looking at 30 degrees up with the endoscope, and you're trying to reach things up, so the angle instrument has to get a little bit better, but I think this is gonna keep getting better in endoscopy. I will be very, very grateful if in the future you can take care of this with endoscopy safely, And that's the thing, This is a surgery that is not a T-leaf. When you do a T-leaf, worst case scenario is a foot drop, yeah? CSF leak or something, But in here, is wheelchair, Thoracic spine, you just mess around with that. And then if you have a leak, especially in the front, on the side, they go into the chest, can be a nightmare, You can be opening, creating lumboperitoneal shunts, you name it. So you have to be, it's a procedure that the room for error is very small, but the rewards are amazing, like everything in life. Remember when you go to Vegas, playing the roulette, if you go in the numbers, take a lot of risk, but you make a lot of money. If you play with the black and red, yeah, fine, you get 50-50, but the reward is not too much, like everything in life. So the same with the lateral, If you do it right, it's amazing. If you're doing wrong, then you pay your dues. This is the classic approach, the way that I was trained, Neil, you remember this? You call the thoracic surgeon comes, he tell you, okay, Juan, what are we gonna do today? Very cocky. You know how the thoracic surgeons are. So they just come like, okay, what level are we doing? Oh, T9, T10. And he start like, okay, man, T9, T10. So we need to mobilize the diaphragm. And what rib you like me to take? I'm like, I don't know, man. He's like, well, we prefer T9. I was doing a robot case the other week, and he gave you this BS. When we do bypasses on the descending left, whatever bullshit, And then finally they go and they just open for you like what we call the sharp eye incision, huge incision, the one that you see on the left, on the right of your screen. And they give you a tour for the entire chest. They show you the azygos, they scare you, they show you the heart, the pericardium, they show you the lungs, they show you everything there, And you're like, and then you end up working in this little space, By the time you start your surgery, you're very scared. You're like, oh my God, where I am, They show you sympathetic plexus, they show you a million things there. It's like wow. And then the truth is you end up working like this. And this is what I remember Dr. Taylor and, Pimenta and Bill Smith, when this, we start trying to do this retropleural approach and the thoracic approach on lateral, we were like, what rib you take? And we always like, don't ask me what rib. Whatever rib is in your way, since the patient is totally orthogonal, that's the way it goes out, And then the diaphragm is just a muscle attached to the wall, and if you find the planes, you move it out, and that's the mobilization of the diaphragm, And I was challenging general surgeons and that when we're doing this approach, and they're very good with anatomy in the center of the diaphragm because they deal with the hiatal hernias, and that's what they deal with. But they never deal actually with the insertion of the diaphragm of the thoracic, on the thoracic wall. So my questions to them, they were like, always the answers were weird. I was like, listen, where is the diaphragm inserting on the ribs? It's like, well, T12. And then like, T12 what? Then I was doing a case when I was opening on T11 and I was getting into the retroperitoneum. It's like, why not on the chest? This guy told me T12. And that's why we start doing this dissection of the cadavers. And, we do it a lot with cadavers, and I think cadavers are a great place to understand things, that the true anatomy. And we found, I want to show you a picture, that actually that T12 is not true. So if you want to go over deep things, we publish in a couple of papers trying to be very specific, step by step, the approach, some of them anatomy, some of them not. But I can tell you, you read this, you watch the videos from SSF, from the Seattle Science Foundation, I can tell you that you can reproduce it, and nothing more satisfactory when I go like overseas meetings, and sometimes come after you give the talk and they say, Dr. Uribe, I'm doing this thoracic, did they show you a picture? And they say, I got it because of the videos from the SSF. I'm like, oh my God, it's reproducible, And I can encourage you have to do it because I think it's fair for the patients to have access to this surgery. It's such a good surgery. And I say just showing you here how reproducible it is. This is some picture of my cases, but the thing going on. And this is what I always tell the patients. I told the patients always when I consenting them 30% of paralysis, but I tell them right away, I do hundreds of this one and I never paralyze anyone, which is, obviously it's a one single surgeon, but I can tell you, it's safe. Nowadays I'm at the point that I'm not really concerned about paralyze them. I'm more concerned about, can I have a good plane and take the whole disc out instead of leaving this, what we did with Nima, calling the floating island. And this is important, and as you know, endoscopy is going more and more and more, and there is a really good paper that was published in Neurosurgery this year in January from the group of the endoscopy multicentric group, which I'm part of now of them since I'm start doing endoscopy. And if you look at that paper, it's very interesting. They show 41 patients, but unfortunately, there's one paralysis, And that's what I was discussing with them in a podcast that we did. I said, listen, I like it a lot, but one paralysis is a lot. Just put that patient, you change that patient's life forever, So I've been doing this one that is more aggressive in terms of the approach, but I never have a paralysis. So obviously it's my personal experience against a multicentric one, but you have to find a way that you cannot do that. And you see here, it's reproducible. See, a lot of the pictures is almost the same osteotomy, the same head of the rib out, the same part of the pedicle out. And at the beginning, I start doing instrumentation for these patients. Some cases were too long, and we do tomorrow screws of the plate, and the patients, they say, no, leave me alone, and they do good. Nowadays, actually, I only put the ribs, the pieces of the rib on the interspace, and I don't put screws and nothing, and the patients do great. So from the point of view, it's also not an expensive procedure. Not good for the companies. We're not using too much implants and this. And the funny thing is, you ask me why I don't use cages. It's because any company has been able to design for me a cage small enough to put that. It has to be like a 12 millimeters by 3 or 4 millimeter height and 30 length. And you know why? It's sad. It's no volume. So what's the point? We're going to make 3,000, 4,000 cages when there is no money, And I'm dealing with a company that is the nicest of all of them. They listen to us a lot. But Pimenta, help me out to get a cage. Mm-hmm. Yeah.
So I know I know it's not time for comment, but
No, it's good. It's good.
I'm
Keep it
struggling
open.
here because you mentioned that you never had a paralysis, right? I will give my own experience.
You have one?
And so one thing on thoracic disc is very different from lumbar disc, right? And people has a tendency to think that is a annulus that goes is soft and you can just bring it inside the disc. But what I've seen is that those calcified thoracic disc, they have a different pathology. They are linked to the end plate above and below frequently, or at least in one side. Years ago, I can say that maybe 15 years ago, I was doing one of these big calcified discs, and I was very happy with the amount of dissection. I could see a very good plane between the calcified disc and the dural sac. I had from one side freed from the bone, and I thought that I could really economy the corpectomy above, the triangle corpectomy above, and I tried to bring the piece of bone inside the cage, and I left the piece and came back, and the patient got paralyzed. So I have this cross in my life, and I know this is super painful, but it's very important. See, this image is typical. I think it's kind of osteochondroma. It's not really a thoracic disc. It's a bone pathology, which is different from soft disc herniation.
And in the German culture, the spine surgeons culture in Germany, it's a big belief that it's actually a adjacent pathology. It's interesting. I found some cases where I say they're absolutely a herniated disc. See, there's coming another one's like why you develop this and you don't develop on the lumbar spine? Why in the thoracic spine on the lumbar? And oil in the neck is more like an OPLL, but this is not like an OPLL. This is kind of weird. It's sad because this is a very rare problem, so we don't have too many volume. It's hard to to look at the natural history. And don't forget, most of the time, this diagnosis is incidental. These people have been worked out for GI issues, for heart issues, million things. Finally, they do an MRI and they look these monster things. And a lot of these patients are actually no symptomatic. And I told them, the problem is someone tell them that they have a risk of paralysis. They end up with you in the clinic. You tell them, you don't have myelopathy, you can sit on this. I always can do the surgery. And it's so funny because a lot of these people, they go home and they have this time bomb, similar to the patient, you're a neurosurgeon with the aneurysms, and they cannot live with this. And they call back, hey, listen, I take any risk, take this thing out of my body. I can just not live with this. And then you end up doing the surgeries. But my approach is trying to take them away, trying to do only the patient with real symptoms. Even with the radiculopathy guys, I say, listen, go get these infiltrations, even go and see if they can burn the nerve somehow instead of going into a discectomy. But sometimes, I have right now like one of these VIP guys, like a big CEO, one of the big car companies, and this guy has 2 or 3 small ones, and he's driving me crazy. He just called me last week again, I need this thing out. I'm gonna go someone else. I don't know what to do. So anyway.
Can you please describe the rib head over the foramen, how important it is to take
So I'm going to show you in the next picture.
Okay, good.
Yeah, and then after these images, I'm going to show you a video of this case that I did, and it's going to be a step-by-step everything, and then it's going to be good. This one, I like it is because of this one. This is a right side, and this is the important thing. You see where the aorta is? And I like this case because watch, when you do this retropleural approach and we use the expandable retractor, actually you can retract the aorta forward without even seeing. I not even saw the aorta in this case. And then I not even saw the vessel. And as you can see here, before and after, you see where the vessel end up, yeah? So it means like actually we were retracting the aorta without knowing. So I remember I was talking to thoracic surgeons, and they say, the aorta is a big holes with a lot of big wall. You can move them. The risk in here is avulsing, actually, the segmentaries. As long as the segmentaries let you do it, you can move the vessel a lot. And so when you have to go from the side of that, don't get afraid. Obviously it's better to go from the left, but in this one from the left from the left will be a big nightmare, yeah? So this is what Dr. Pimenta was talking, when we do these cases, we end up doing a similar, like a partial corpectomy like this. You see what the rib was in here. And you always, before the surgery, you cannot do the surgery without having a CT. Everybody has to have a CT and MRI, And when you look before the case, depending on what level you are on these mid-thoracic levels, most of the time the rib is covering the entire disc space and part of the pedicle that you have to drill. You will see later on. In the lower levels that you see here, actually the disc space is open and the rib is just covering the pedicle. And you have to know that things because that's important. And one of the success of this surgery is you have to have 100%, you have to be 100% secure where the anterior edge of the dura is. You just cannot rely on an X-ray, because a little rotation, then you don't know. And I'm gonna show you in the video how it goes, okay? So we create a classification. I'm gonna move fast on this. We have a paper on this, and the reason that we did the classification is because we want to have some communication, when we are talking about that, what is a big disc, not a big disc. So in the early 2000s, Dr. Dickman, as you guys know, he was doing a lot of endoscopy thoracic disc and that. He called the name giant thoracic discs and become now like a mainstream word, and it means like when it takes more than 40-50% of the canal, they call it giants, So using that, so we create these levels, type 0, type nothing is the one that are incidental, that is very little, is doing nothing. It's like a small doing really nothing, or they like just a bulge. And then you go the paracentrals, that can be a soft and central soft, and then the 2 calcifieds. They're giants, and they can be soft or calcified. So you can see the paper, and this is a little bit of examples of each of these. The paper is good because it gives you a good idea what's happening, and it helps you because, I think each one has a different treatment. The small ones, I believe the small ones soft, I think the endoscopy is a perfect surgery for that. Little footprint in and out, that you do it right, they do great. There is an issue with endoscopy. Endoscopy, when you put endoscopy, you cannot be on the chest, Just imagine if you violate the pleura with endoscopy. You're gonna put liters and liters of saline on there. And how you're gonna take that thing out, So you have to be, so the approach, by default, by doing endoscopy cases now, the endoscopic approach is posterolateral because you go in here. You have to be right here. You drill this part of the rib and then you get in here, and then you're trying to move the endoscopy as much as lateral, and you still have this 30 degrees view up. That's why you can do it. But you can just not go like the retropleural approach that we go totally lateral because there is no way to dissect the pleura. So this is one of the limitations on endoscopy. And when you're endoscopist, that is the challenge. When you're not there, a lot of things comes to your mind. So thoracolumbar junction is a different animal also, and this is because of the diaphragm. So you're looking here, we wrote this paper also with all the details how to tackle the thoracolumbar junction. And these levels are different. 12L1, T12L1, you can go almost truly retroperitoneal as long as you know how to start dissecting the costodiaphragmatic angle in here and move it up, and then you're in here. But these other levels, T11, T12, and that, you have to deal with the diaphragm insertions. And this is something that we can do in the cadavers. Obviously, in half an hour talk, it's tough to give you all the information, but the takeaway home from here is that the thoracolumbar junction is a different animal than the mid-thoracic one. Mid-thoracic is easy. You're just dealing with the pleura, and that's it. But the thoracolumbar junction, you're dealing with some of the diaphragm. And the diaphragm is not a big deal. You just can cut it, but you have to know that you're dealing with an extra structure there. And so depending how you are, if you can be 100% on the retroperitoneum, it's a much better. There's no reason to open the chest for free, yeah? So that's the paper that we put on that. This paper is only dedicated to the thoracolumbar junction. It has a really good things. This David Shue did an amazing job on that. At the time was one of the residents, and Corey Walker. And he has also a video, and he shows exactly how this thing goes. And again, remember what I told you, the thoracic surgeon? This is the story. You see, this is we get a cadaver, and I make a hole. This is the head is right here, the legs are here. This is on the lateral. And we put a hole like when this take the head out, this cadaver, you put a light on it. And I was trying to inflate the chest. And when you do that, I dissect T11 and T12, and you see that the costodiaphragmatic angle is very interesting. It's just not following one rib or the other one. You see how it is? The angle comes like this, and the ribs stay there. But that's what we always say, that when you're doing a lateral case, they say that 1L2, as long as you are under T12 or a T12, most of the time you are in here on the retroperitoneum. But when you are between 11 and 12, you go a little bit anterior and low, you can get in here into the retroperitoneum and move the diaphragm out, and you end up very good, And this is a good example how you deal with the thoracolumbar area. Okay, so now it's gonna be the video, and after the video, I'm not gonna bore you more because the more information I give you, the more crazy I get you, yeah? So as I told you, this is actually a brand new video for me because this case, I did it like 2-3 weeks ago. I put some inserts of another cases on the approach, but the microscopic part is actually that. So let's see what we can do. So this is a type 4, like a giant calcified, and this is the image. So you're seeing here, this is as big as you can get, This is probably one of the biggest that I've done it. As you see here, it's almost taking the entire canal on the CT. You see the bridge in here on this area. You see how it goes, and then the MRI, basically, there is almost no core. So this patient was a myelopathic, and I'm gonna show you how we did. So this is patient we choose the left side because it was better not to deal with vessels and that. You see here, so notice in this case, I put always this needle on the spinous process, and then I counted, as you saw here on this, let me just stop in here because this is important. You see there in the insert on the top, the little needle on there? You see the needle right here? So this needle is this needle. So when I start counting, don't forget, lead complication on thoracic disc, wrong level, yeah? So you put this needle in there, you count it, you recount it, and don't forget, these patients, every time you are going to schedule them, don't forget that in the OR, the best way to count is down, up. So it doesn't matter you count it from the top down, you get crazy. So always make sure that you have a counter down, up, because that's what you're gonna do in the OR. And that's very important. And then,
Juan, you should get, we use a fiducial, so you can
yeah,
get your
that's good,
radiologist
but that's
and
not
get
the
a CT
ideal work.
myelogram.
Yeah, but that's like a Mumaneni,
Yeah.
like a Praveen talk in the podium, You just go there, but the problem is I'm gonna tell you, most of the patients are, in my practice, these people come from another state, from another place. They come the day before the surgery. They come already with a CT. Are you gonna get a new CT on everybody? The insurance will not pay you for that. This is good in your ideal world, in the university. You're just messing around for a month and the patient is lingering and finally you put go to interventional radiologist, put that. When you can do it, it's perfect. But in the real life these people show up with an MRI, a CT, you cross your finger that you can count from the bottom, and then you have to deal with this, So that's why, I wish that I had that. I also use this technology, like stitching technologies, Lateral and all these other things that helps you in the OR to find. But be careful, it's very easy to get on those vertebrae look alike like nothing. And then you don't want to also spend a lot of time during the case trying to find out and counting again. That's why put a needle on the spinal process, you just mal it. It's very easy when the patient is asleep. And then you know that needle is at the level or one level above, whatever it is, and then you go from there. So incision using here, in this case, this is anterior on the top of the screen, this is posterior. You see the vertebra above, the vertebra below, and this is the disc. You see, I always make it offset. You know why? Because if you get a little bit offset, you have less pleura to dissect, less chances to make a hole in the pleura, and also you don't need to really go all the way from there. The skin moves a little bit with you. So it's a little bit, and normally it's like that. 6 centimeters incisions will make the trick, You can try a smaller. I don't know, Nima, you're gonna try smaller. Have you tried smaller? And then this is just in lining here. Again, what rib goes out? The rib that is in your way. So it's in the patient is in a perfect AP and lateral. Whatever rib is in your way, you take that little piece of rib. I usually take 6 centimeters of the rib, so I have enough room to dissect through the plane. This is on one of those papers, we have these things. We show what is the order of all the muscles on there. This is more of the thoracolumbar junction, but on the thoracic spine is just intercostals and the pleura. So using here, you open in the incision. This is simple, you use the thoracic instruments from the surgeon. We take that rib, using here, and we dissecting the rib. And you can go between the ribs, but you go between the ribs, you're 100% transthoracic. And then you're gonna put so much pressure on that ribs, and it's a torture. Just my recommendation, take a little piece of the rib, you use it as an autograft later on, and it's better to have actually a big gap of no rib than have two ribs hitting each other, so they tolerate better. You don't forget, these patients, no matter what, first 6 weeks, a lot of thoracic pain. You put some, I block the nerves in the way out, but we give you only like a little honeymoon while the patient go home. After that, 6 weeks of radicular pain. Using here, you're taking the rib, and then once you take the rib, this is the trick. You have to find out now what is the endothoracic fascia. It's a little plane that is virtual, that is between the pleura and the intercostal muscles, as you see there. That little plane, the easiest way to find it is you find the rib inferiorly, and on the bundle that is there, you start finding your plane, and you do. And using here, with your finger, you start dissecting this retropleural space. Little by little, you dissecting up and down, and you see how it's moving. And at some point, you end up putting the retractor. Using here, the retractor, this is how it looks, how deep. Now you put the microscope. Now we're gonna take the head of the rib. we usually take the head of the rib of the pedicle that is inferior. So this is a T9, T10. You take the rib that is on the top of the T10 pedicle. Why are you going to do that? Because I need to have access to the pedicle of T10. Why the pedicle of T10? Because medial to the pedicle, what is medial to the pedicle? Dura. There is nothing else. There is no vessel. There is nothing. So I use that one. So using here, I just drill the pedicle first. Let me just get in here. This is going too fast in here. Let me show you here. This part is important in here. So you see this, once I take the rib out, then I have the pedicle right there. This drill is doing a hole in the pedicle to find the dura. And then why I like to find the dura on the pedicle? Because then I feel with a pen feel what is the true anterior wall of the spinal canal. Then I know exactly where I am, because you cannot rely just on the x-rays, yeah? This is delicate. So using here, I'm drilling right there. I found the dura right there, you see here. And then now I start making the partial corpectomies. So using here, I'm cutting some of the 9 and 10. Now that I know where is the anterior canal, I make a cut with the Masonic, with the bone scalpel. I love it. This is changing a lot the way that I do it because it makes very nice cuts. And using here, I make an anterior cut and a posterior cut. And now I'm making these parallel cuts to the disc space. So the disc space is going this way in here, yeah? So using here, I'm making all these cuts in here above and below the disc so I can do that partial corpectomy. And this is the rest of the rib. This little part that is in here, cut, is part of the rib. So using here, then I start taking these pieces of the vertebra out. Using here, I just cut it in pieces with the Masonic, which is easy. What you don't want is to grab the pituitary and do like this. We have an example when we were in Florida. We have a paralyzed patient, one of our colleagues doing a corpectomy. The resident was getting this piece and he did like this. Probably he hit the dura back and forth a couple of times. The patient wake up with a big central cord. So you see here, so the trick is that. So once you do that, then you have the posterior wall of the vertebrae. You see, this is the posterior wall is right here. Yeah, and the whole herniation is right here on this area. So now the job is find the ALL in here above the disc, find the ALL, the PLL before under the disc, above the disc, and then you start dissecting the whole thing. And you see here, this is obviously after half an hour, whatever. So you see here, I'm trying moving that disc space on that cavity that I created anterior. So you see, little by little, you dissect, and then cranial and caudal, you keep releasing. As you see here, we have dedicated instrument for this. Now this is thank you to Alpha Tech. Actually, they put the big set for me of instruments to dissect this. Using here, this is like a 45 degrees, 90 degrees ball dissector. They're super long. They have special curettes, special everything. So it's good that they have a dedicated, now we have a dedicated tray for these cases. So using here, I'm just working little by little, finding my way to get the plane. And at this point, you have to decide if you are going to leave part of the disc attached to the dura and not to have the leak, or you're trying to keep finding the dissection on it. And using here, the big part of the disc is here, and then I keep trying to find the level. In these cases, the dura is so redundant, and this is after the dissection. These cases, it's so redundant that you see that the dura actually come like a big blister. And this is like I don't know, you guys seen this, you can the Africa, whatever, the people that put these earrings and they leave it there and they become that happened with this thing. This has been for many years that the dura actually is a huge dura using here. Once you take it out, actually the dura comes like a blister on the front, And you see here, this is probably one of the biggest one. I'm glad that it has a good plane, but you see here, you're working deep, you went through the approach of this thing, and then when you're gonna close, you do this trick, which works very good. You do a Valsalva with a red rubber catheter, you take the last of the air out, and then you don't need to leave a chest tube. Like around 10% of my cases end up with a chest tube next day, and it's a risk that you take. Sometimes I was thinking like, I should leave a pigtail on everybody, but then every time I ask the fellows and that, they say, don't do it, man. For 10%, a lot of patients get away. And pigtails and that, it hurts. Every time they breathe, it hurts. So, and this is the post-op image. You see this case, how clear looks the cord changes that already had this patient in here. And, let's see how much she recovered. This one was with a lot of myelopathy, but she was, at least immediately, he said a little bit of my numbness is better. So in any words, so this is a really good procedure. It's a great approach. It works very good as long as you practice, and it's all about anatomy. It's another example when I was not able to find the plane on the dura. You see here, I left this piece of bone attached to the dura, but then I avoided the CSF leak, as you see here. So sometimes you have to do that. Okay, guys, so I don't want to just keep going in here because I can talk about this all day, but I can tell you this is an amazing surgery, it's an amazing approach. If you're doing lateral surgery, it's worthwhile that you spend your time doing this. And trust me, once you do 1 or 2 cases, you help so much the patient with this. There is a bunch of complications that can happen. You see, this is one of mine. This actually, hematoma is 100% retropleural, So you actually dissect the pleura, didn't get into the lung, but then the blood built behind it. So you have to be aware that the thing can happen. It's not a big deal. Most of them, they're fixed with a chest tube, So you just need to put the patient overnight on the intensive care unit, make sure that the lungs are inflating. If for some reason they desaturate, you know that the solution is a chest tube, and 1-2 days with the chest tube, and then they get better. So thanks very much, and hopefully in the lab later on, we know we can have a good demonstration or something. Thank you, guys.
Great.
Any questions?
Awesome. Hey, Juan, I have a couple questions.
Yeah.
So if you can go back to just the exposure.
Where?
So tell me, yeah, that's perfect, actually. Go right there.
This one? This is another video.
That one right
Okay.
there. So tell us so I sometimes get frustrated. Okay, so I agree, like thoracolumbar junction, I go retro, behind the diaphragm, there's no reason to go in the chest. Sometimes you can use the retroperitoneum and sneak up. I get frustrated if I'm like a T7, T8, and sometimes I just, go in the chest, okay? Because it's hard to get around and you're kind of getting at the top. When do you go transthoracic? And then what do you do for, do you leave a chest tube? Do you leave a drain? Can you talk about, because part of the problem I have sometimes when I get frustrated is that you spend all this time to try to preserve the pleura, and then you get this tiny little tear, and then all of a sudden you can see the lung starting to come in. So maybe if you can talk about that a little bit.
Yeah, no, that's good. And the worst thing is this, you do the whole approach. I always try to be retropleural. If I make a hole in the pleura, it's not a big deal. But I want to keep going retropleural because the pleura somehow is the natural retractor in between the blades, It makes that. Watch this one. This is a really bad one that happened to me a lot of times. So you get the whole approach, you do the disc, everything. You finish the case, you take the retractor out, and always look at the pleura, and then you see air on the other side. Like, okay, you know what I have to do on that one? I get one of these dissectors, make a big hole in the pleura right away. So I open the pleura all the way because it's easier to take the air out, because this is a iatrogenic pneumothorax. The game is take the air out. So I prefer to make a big hole in the pleura, put the red rubber catheter there, and then when I do the Valsalva, I take all that. What you don't want is a few cases I was like, no, this is okay. Actually, the air gets trapped. You're already starting with a pneumothorax. So opening the pleura is not a big deal, and to be honest, I just do it more to be, proud of myself that I have this nice plane and that, but you can go transthoracic. Actually, you go transthoracic, the approach takes 2 minutes.
Yeah.
You just go boom, one hole, and you put the retractor,
And then do you put a chest tube in or no?
No, because it's still a iatrogenic pneumo, because the thing is that you're violating the parietal pleura, the visceral pleura that is attached to the lung. So the lung is actually not leaking air.
Yeah.
That's the difference. That's the problem that you have with the thoracic surgeons. When they do approach for you, they put automatically chest tubes on everything. And the reason is because, for example, the trauma people, they have these rib fractures. When they have the fracture, the rib get damaged on the visceral pleura, on the lung itself, and the lung is leaking air. In here, we just put the air, because we damage that, we get to the atmospheric pressure, and it's a negative pressure.
Just to add to this point here, when you use, tubes after the surgery, I learned in my experience that It's not the risk of pneumothorax that is the need of thoracic drainage, is the blood.
Yeah.
Especially
it's-
when we
yeah.
go
Yeah,
and do
corpectomies.
corpectomies.
Yeah.
We have to be aware of that. If you think that there is a chance, we are working in bone, so you take piece of bone, you may think that will not bleed, but the bone bleeds.
And
Most
I leave
of that's-
I leave a hemovac on everybody, no matter what.
that's what
On
I
the
was gonna
negative
say, yeah.
pressure, and that hemovac, you put a big sign, nobody touch it, nobody deal with this, because it's on there. And that's for what Pimenta said. And see, for example, 3 or 4 weeks ago, the last month I did too many, like a 5 or 6. One of them was a big chubby guy from Florida. And he came there, I did the surgery. When I saw the patient, man, I wish I wouldn't do this case, but you telemed, you don't know how big they are. And they show up you have to do it. So I did the surgery, went good. The guy was so happy. But then he called 3 or 4 days ago. The guy started feeling a little bit short of breath. He went to the ER. He has a hemothorax, and they put a chest tube. I heard from that they pull out 700 cc's of blood. So this guy developed, and he was 100%, and that one has a holes on the pleura. It was good. The images at the hospital when we were with us were good, and then he developed this hemothorax after that. But and then the other thing that I want to make sure that you guys see, I like this picture in here. See this drill bit? This makes a big difference in my practice, and this is thanks to Medtronic that put this thing together. These drill bits are the one that skull-based guys use it. They're 14 centimeter length, and they call clear view. And you have to write it up. You don't want to do a thoracic disc without this. And this coarse diamond drill bit, they come on 4 millimeter and 4.5. Without this, it's impossible, because these ones are as more aggressive than the regular diamond drill bits, but they're not as bad as the AMA, so you can be very close to the dura and not to have the leak. So all the little things make a big difference. And but I can tell you, if you really want to feel good doing surgery, try to do one of these surgeries. It's amazing how good they are.
Juan, what is your the technique that you like better, the drill or the ultrasonic?
Yeah, no, I use both in the case. I use the Misonics, the ultrasonic bone scalpel, to create my boundaries, all the cuts. The anterior cut, the posterior cut, the superior and the inferior, and you see these little cuts like this to make fast the corpectomy. But then the real surgery that is actually drill the posterior wall of the vertebrae, I'll do it with these guys. And what I do is I drill until it gets to the PLL in here, PLL in here, and then I connect in here so I can see the dura on the top, and then I drill, see this curve? I drill deep in here, and then suddenly you see that the fragment start getting loose. When you feel that this thing is loose, then you know that you can start dissecting that. So that's when I use this guy. I cannot live without these ones, It's a combination of that, and this is the problem, you have to be patient. It's a 4 or 5 hour cases. The small ones, you can be 3 hours, but,
Does the drill check, is it angle?
It's curved. Yeah, it's curved. Yeah, and this is another thing. I always commend Dr. Foley when he did the metric systems, because they use all this bayoneted. But I can tell you, by doing cases, bayonet is not the best figure for MIS. The best figure for MIS is slowly lazy curve. Instruments that have lazy curve, they're better to work with tubes. And this is this instrument. And then all the endoscopy guys, all the skull-based guys use it, because the lazy curve, sometimes the bayonet is a one-way go, If you work this way, then it becomes your enemy. When they're curved, you just can move it around very easily. Yeah, they're like a lazy, and they come on 13 and 14 centimeter length, which is great. In here you work sometime 150 on the retractor, but this one that is 2-blade retractor, you put it different than NEMA show up. Instead of anterior to posterior, you put in superior and anterior the blades. So you have a space in between the blades. You go on that one, and that length is always less than 140, That guy that I did from Florida, I told you, that big one, I was working at the end with the fingers, it's super deep, but most of the time you can do it with that ones, yeah.
And then the 6 weeks of pain, is it from taking the rib or is it from dissecting?
I think it's a complication of the rib the pressure that the retractor put on the rib above and below, and also the head of the rib down. You hit too much these intercostals, that's why it's so good, the endoscopic one. The endoscopic one, you make your incision this size at 10 centimeters, and you go there, you barely hit one of the intercostals only, and then you do that. The problem is, to me, is limited. You don't have the three-dimensional view. You take a lot of risks, and you have to be a badass endoscopy guy. And when you don't want, I remember I was doing an endoscopy one, and you start pulling things, and the leg jumps. My God, it's like, doing this one, you never see a leg jumping, Yeah, so. Anyway,
Awesome.
guys,
Thanks, Juan.
I appreciate it. Sorry for the time. I just get too much
Wait, I want to
happy
say
with this.
something.
Yes,
I want to
sir.
say something. Is that microphone working? So, kudos to you, obviously.
Thank you,
Juan,
James.
And Dr. Pimenta, Dr. Taylor, and Dr. Screen for creating this technique, and Neil and Dr. Pham, really cool stuff that you do. For me, let me just say something. I'm not necessarily a fan of lateral surgery, but these thoracolumbar and upper lumbar surgeries are game changers, for instance, for trauma or tumor surgery. This is an amazing opportunity for us as spine surgeons to really convene. This allows us to do a very effective posterior short segment decompression, tumor debulking, instrumentation, and then thanks to your advancements, we can do a way better anterior column support than ever possible. I just want to recognize it, and I think this is truly one of the ways we can totally change how we have done anterior column reconstruction in these settings.
Thank you. And the other thing is, Dr. Chapman, is that get rid of the thoracic surgeon. The access surgeon is a big deal. It's our surgery, it's our procedure. Now we're doing thoracic surgery by our own,
I want to just, I don't know whether Dr. Oskuin is going to talk about that. One of our fellows, with other fellows, did a study where we did anatomy of T12 corpectomies. The two insights were the diaphragm actually is way differently located than what is traditionally talked about. I think it's a publication now. The amazing thing for me was Dr. Oskulian taught the fellows how to do a T12 corpectomy. We then measured with a full ciliotomy what they'd actually done and damages, and none of them had any critical, were even close to any critical damages. They did beautiful corpectomies. So this is actually a very replicable thing thanks to teachers like yourself. So this was surprisingly 8 fellows, 8 cadavers, no injuries, beautiful, complete, all the goals were met. So this is teachable and doable. So congratulations on this game-changing technology.
That was great, Juan. Our next speaker is going to talk about using navigation. As you guys know, when we do lateral, we use so much fluoro. So thanks to young, smart surgeons like Martin, he's been able to advance and working with industry and using navigation instead of getting, radiation exposure like crazy.
Well, thanks so much, Rod. And, I'm always so excited to participate in, especially this particular course. And what I'm going to be talking about today is adoption of navigation in lateral access surgery. Last year, I was a part of the residents and fellows course. And so for those of you who are there, you may recognize this, right? So from the Paris Olympics. And I made the comment that on the left, this is me doing lateral surgery, and on the right, this is Dr. Pimenta doing lateral surgery, not really needing a lot of stuff, which actually is quite pertinent because, today I'm talking about navigation. And so when we talk about navigation, I'm going to start with the takeaway, right? And the takeaway essentially is that you can trust the nav in lateral access. And this is going to be for your surgical goals, increased efficiency, and decreased fluoroscopy. And it all comes down to trust, right? I mean, there was a point in time where, I looked at this machine that does computer-assisted navigation, and I really thought to myself, can I really trust this in real time when I'm looking at an image? And naturally, there was a point where I didn't quite trust it, but who I could trust was Bill Taylor. And so I worked with Bill at UCSD, and actually he, amongst many of the people in here, are one of the kings of lateral access. And I'll share with you, we had a conversation once, and he pulled me aside, and he's like, Martin, I was peeking into the OR, I saw you were doing an OLIF, and I've been doing OLIF for a few years now. And he goes, what were you doing with the C-arm in there. And I'm like, well, what do you mean? And he's like, well, we're in like the 2020s, right? We have navigation now. Like, why are you using C-arm? And the thing is, he used the word C-arm, but what I heard out of his mouth was like a horse and buggy. You know, it made me feel like I was in the medieval ages having an X-ray machine in there. And I just had this existential crisis about what I was doing. And so that's my path on adopting navigation. So as an overview, I'm gonna go over 2 cases, you know, a touch of literature, and then my own tips and tricks on how I got over my own learning curve in trusting the nav. So for the 2 cases, the first one, a 67-year-old coming in with low back and leg pain, lumbar ESI and facet injections used to help, not anymore. She's failed everything else, and she's neurointact, right? And you can see on the X-ray here, she's got a 4-5 spondy. And, you know, like Juan said earlier, 4-5 degenerative change, it's, you know, one of the most common things that we deal with. So you can see the spondy here, you know, centrally, she looks fine. She's got lateral stenosis on the left. And so, you know, I tell her, look, you're coming with a spondy, you're symptomatic, I'm gonna offer you a surgery. And so the surgery I offered was a single position 4-5 OLIF with posterior fixation. This is using the robotic system. The robotics has navigation built into it, right? And so the plan was to use that navigation system with that. She is positioned lateral. So you can see I use a flat Jackson positioned all the way to the edge of the bed. There are navigated instruments that are used, right, to do both the screws are robot assisted, the surgery is navigated, and this is my first X-ray. So other than the 2 X-rays to register the system, this is the first X-ray that I take. And you can see here the cage is in position laterally, cage is in position on an AP image, screws are placed, rods are placed, and this turns into like a 2-hour and 20-minute surgery, right? So incision is made at 8:49, drapes come down at 11:08. So this becomes a very, very efficient surgery for you know, a degenerative 1-level inner body. And you can see here her pre-op and post-op. And again, she did very well. Now, case 2, here, I have a 59-year-old coming in with severe back and standing intolerance. And you can see here, he's failed all conservative measures. He can't really live with this, neuro intact. And a little bit closer view looks, he's coronally off and sagittally off, right? So you can see his PI and L mismatch. Nowadays, we're looking into L4 to S1. We're looking into L1 PA, T4 PA. So all of these are off on however you want to measure his deformity. And a closer look, you know, he has a more major fractional curve, you can call it primary lumbar curve, but whichever it is, he's certainly off. And then his MRI, top center is L3-4, bottom center is L4-5, and then the far right is L5-S1. So vascular anatomy is favorable on whatever you want to do, and of course his CT scan here. So for him, I also offered him a surgery. For me, this is a 59-year-old coming in with adult degenerative scoliosis. And my plan was a stage surgery. So stage 1, L1 to S1 OLIF with a lateral ALIF. And then stage 2, the idea was a circumferential T10 to pelvis. So assuming that he's going to be corrected, it would just be perk from the back. So he's also positioned laterally. This time he's in the center, right, since it's a stage 1, so I don't need him all the way at the edge of the bed. And in this video, I want you to focus on that screen. So an O-arm has been spun, and you can see here with navigation, I can essentially just mark every single level, right? So there's no fluoroscopy here at this point. And so for 5 levels, I can see where I enter at L1, 2, L2, 3, L3, 4, L4, 5, and L5, S1, mark those incisions, and then start the process of the exposure. Like Nima said, I also place K-wires in all of my disc spaces first, which we'll go over in the tips and tricks. But you can see the K-wires placed there from L1 to L5. And then I also dissect in my lateral ALIF. And you can see here, again, even with the lateral ALIF, and I'm gonna blow this image here, I can confirm that I'm at the center of the disc space at L5-S1. So again, no X-ray that you would normally take to confirm that you're at where you want to be. After that, I go back, I place all the inner bodies. You can see here, I navigate from L1 all the way to L5. So 1, 2, 2, 3, 4, 4, 5. And then really, I shoot the X-ray for 5-1. right? So I do like to see that bone move. So I shoot that X-ray. That's my first X-ray to confirm all the cages are in place. So here are all the cages from 1 to 1 on lateral and AP. And then these are the incisions. Of course, we're in a lateral course, so all the incisions are always going to be fairly small. And you can see here on just the first stage, he corrects, right? That's the beauty of lateral surgery, where now what historically would be a very good open surgery can now become a minimally invasive surgery. And you can see here restoration of that lordosis with the lateral cages. And here, because of this correction, the idea is that everything from the back is going to be percutaneous, well, transfascial, but minimally invasive. So you can see here a T10 down to ilium planned. This is done with the assistance of the robotics platform. I do a single incision, especially for my larger surgeries. Everything is transfascial. I do vertebroplasty my top levels. And then this is his final. I did put in a kickstand rod on that left just to make sure he was coronally in balance. And then you can see that correction, right? So here's his CT scan, and then here's his X-ray. You can see him put back into coronal alignment. But more importantly, what drives outcomes is the sagittal parameters. So you can see here all of his sagittal parameters, whether you do mismatch 4-to-1 or T4 L1P axis, they are all back in alignment, right? And so, with this, just some literature. I know Nima did, actually last year, I remember he presented a lot of excellent literature, and so I'm just gonna put it in a few. Paul Park really came about in 2015, and he described sort of where the ideal cage would be if you're navigating. He divided the disc space in quarters, so anterior 25%, middle 25%, and then the posterior 25%. When you're navigating, ideally that safe space is quarters 1 to 3, right? So that was sort of what he described. And then he presented his case series in 2016. This was the image back, again, 2016, 10 years ago almost, right? People were doing navigation. And it was 31 patients, 66 levels, 97% of cages navigated were in quarters 1 to 3. And again, more importantly, the concern is if there's anything ever unsafe, and he didn't describe any neurologic or vascular complications. I would say 3 years after that, this is the UCSF group, right? So with Dean, Praveen, and Shane, again, they found and described their experience using navigation in OLIF, 214 patients, 350 levels from L1 to 5. Again, 95% of cages within quarters 1 to 3. And also no neurologic or vascular injuries from this approach. Everyone's gonna have some dysesthesias on the left, but nothing that was specific for the navigation. And then the last that I'll show was a Qureshi's group, 2023. They compared NAV with fluoro, so 49 patients NAV, 38 patients fluoroscopy, and they found no difference in their quarters, right? So whether you used fluoroscopy or NAV, whether they ended up in quarters 1 to 2 or 3 to 4, statistically, there was no difference. I will point out, though, that when you look at quarters 3 to 4, there were 4 levels that were posterior, right, versus 0 levels with fluoro, right? So naturally, if you're doing fluoroscopy, I don't think we ever rarely aim for that lateral 25%, but in fluoroscopy, nothing like that, but in navigation, they did find that. Still, though, they didn't find any difference in their complications or outcomes. And then anecdotally, in my experience, so OLIF 1 to 5, I've been navigating for about 1.5 years now, and I have a med student pulling some of this, but sort of rough data, 60 odd patients, 114 levels. I did have a few, right, at the quarters 3 to 4, right? So I would shoot the fluoroscopy, and the cage was like a little posterior at 3 to 4. Sometimes I left it, sometimes I repositioned it, but more importantly, and the big question that I always had, I was never so anterior that I ruptured the ALL. I was never so posterior or oblique that I was in the canalar foramen. And so, my conclusion was that it was safe and efficient, and Bill was right. And so I continue to use navigation for this. So for the tips and tricks that I found that were useful in my own adoption of this, 3 tips and 3 tricks. So I'm gonna tell you the tips, and then we're gonna go over them in detail. First, in multi-level cases, I place all my K-wires first at every level. Also in multi-level cases, I place the inner bodies from cranial to caudal. And then lastly, you want to make sure the iliac pin is directed posteriorly so that the array doesn't collide with your navigated instruments, right? So here's step number one. In multi-level cases, place the K-wires first. My concern was that if I did an entire level to its completion, and say I was doing 2-3, I went on down discectomy, and I put in that cage, I would always worry, what if the spine did shift? And now there's no way to know at this point with the array on the back. And so while the array and the navigation is still the most accurate, I will dissect down here to 2-3, place that K-wire, I'll come on out, dissect down to 3-4, place that K-wire in the center of the disc, come on out, and so on. And this way, it relieves the paranoia that I have that the navigation is changing in any kind of way. So I do recommend placing K-wires first, and then just going back to do your inner bodies and navigating that. Tip number 2, also in multi-level cases, place inner bodies cranial to caudal. So, I used to do multi-level cases from the bottom up, because I would do the 5-1 A lift, that's the most difficult. Then I would do the 4-5 O lift, which is a little bit odd because you're obliqued. And so I'd do the hardest level and go higher. And so it was a change. But in this way, I was not quite sure if I ever believed that the spine moved up until I saw it with my own eyes. Because if you think about it, when you work from the top down, the rest of the spine is attached to disc space, facets, sometimes you're bone on bone, attached to the sacrum, attached to the pelvis. There's no way you're going to move that south. So the spine is always going to be more easily moved up, naturally against thoracolumbar junction and the rest of the chest. So always start from cranial to caudal, and you can navigate all the way down. And then lastly, you just want to be sure the iliac pin is directed posterior. When patients are in lateral position, in my first few cases, I would just place it in the iliac crest. Sometimes the brochures, depending on which company you use, will show diagrams with the pin up there. And so I found out the hard way that as I did that, my navigated instruments would collide with that. So when the patient's in lateral, just follow the iliac crest all the way back to the PSIS. You don't have to put it right in there. You can come a little bit higher and more lateral, but just make sure it's really far out of the way, and that way it's never an issue when you're using your navigated instruments. Now, 3 tricks. So again, I'm gonna tell you the tricks, and I'll show you them in detail again. During retractor placement, right, attach the nav frame to the first dilator to direct and confirm your retractor direction. Next, for multi-level cases, place a K-wire into the cage after. I got this from Bill, actually, and so this was actually a tip that I found to be very easy to go back and reposition. And then if you're unsure of the placement, just leave the cage a little proud, right? It's always going to be easier to mallet in the cage with a few taps rather than backslap it out if you're unhappy with how it looks. So again, during the retractor placement, attach the nav frame to the first dilator. We don't have yet retractor systems that can be navigated, although many of the companies are designing this. Until that happens, you'll see there in the image, the retractor is down, all the dilators are in. With this particular company, you do have to remove one of the inner dilators to fit the nav frame. But once you put the frame down, as you can see in the square, you can then confirm that your retractor is placed in the proper position, which generally costs a few x-rays. So here, you can navigate that, make sure you're aimed in the right direction, and then navigate the rest of your discectomy and cage. Number 2, place a K-wire, right? And so here, you can see from L1 to 5, I have K-wires in at 1, 2, 2, 3, 3, 4. Invariably, and for me, I'm very neurotic. I like my cages to look as perfect as I can get them. And so now, with a K-wire there, instead of putting your finger down and trying to find that gap and find that cage, or putting a blunt probe and trying to find that metal, all you have to do is just slide down that dilator, open your retractor, and then do whatever you need to do to reposition if you're unhappy with how the cage looks. And then here, you'll see that if you're unsure, just leave the cage proud, right? So at 1, 2, the cage is slightly proud, it's off center. Same thing at, what is that, 3, 4? Sorry, 1, 2, 3, yeah, it's 1, 2, and 3, 4. And so in this case, it's much easier to just mallet that in and get it center. Again, I know this from personal experience, because if it's too deep, you get the backslap in there. Backslap is very strong, so you invariably just slap out the entire thing, and then you have to put it back in anyway, right? So if you're unsure, just leave it a little proud, and then you'll be able to mallet in to where you want. So in conclusion, again, I'll say that there are other applications. Inner body surgery is really the most common surgery. But again, I navigate my lateral corpectomies. Thoracic disc herniations, I think, are helpful to navigate because all you have to do is spin the O-arm and you see the disc, right? So here, it mitigates a lot of the concern in being at the wrong level because you just navigate and you see the disc herniation and then you drop down your wound and trajectory and your retractor placement. But there are plenty of other applications in lateral surgery. For lateral inner body surgery, though, again, my conclusion, which I started with, you can trust it for your goals, for your increased efficiency, decreased fluoroscopy. We went over 2 cases, some literature, and some tips. Again, here are those tips and tricks. Place the K-wires first, place your inner bodies cranial to caudal, put the nav frame posteriorly, and then at the end, navigate the retractor, leave a K-wire after the cage, and it's always easier to mallet it in. So, thank you.
Can I ask you a question, Martin?
Yes.
Thank you for learning from all my mistakes, too. I appreciate that. Everything I've done wrong, I try to run back in and tell you right away. I could tell you also, leaving the cage proud, I think that's really important, especially when you're navigating, because it's really hard to know where you're at. So I diligently measure it. And actually, I have a new thing I was going to tell you. I have the tamp made that has a little wing that sticks out from it. So you tamp, and then the cage can't go back past the end plate because it sticks on the side. So it's a really good idea. And in fact, you can use a curette, you can use any instrument you want that hangs out over past your cage. And then when you tamp the cage in, it hits the bone and doesn't push the cage too far.
Yeah.
Which works really, really nice. But I find the same problem that you have is the cage placement is the hardest thing for me, and I don't really know why that is.
Yeah, I mean, I think coming from fluoroscopy, my first expectation in using nav was everything was going to be perfect, right? And so I'll tell that to you up front, it's not going to look perfect. I remember, like, I've been using fluoroscopy for a while. You know, Bill said that nav is great, the reps say nav is great, and so I think to myself, this better be great. And I use it, and I'm like, this is like, I wanted a dead center, and it was forward at the front, right closer to the ALL. I'm like, this doesn't look fantastic. But again, the idea behind the nav is that it may not be super perfect, right? But you have all the other benefits, right? It's faster. And as you know, Bill would tell me at UCSD, x-rays are not free, right? You're gonna accumulate them over time. And so the more lateral surgery you do, if you can offset some of that to make you safer as a surgeon and healthier, I think many of this is certainly worth it. Nima.
Sorry, Martin, can they hear me?
Yeah.
Okay, perfect. So I delved into this topic last year.
Yeah.
Paul Park's first paper was a hybrid, navigation and fluoroscopy. And I think Neil commented on this, that the error of navigation is not anterior posterior, it's up down cranial caudal.
Yeah.
And it's like 2 millimeters from what Paul Park was saying. 2 millimeters is end plate. End plate and a lateral means subsidence. So all the papers that say navigation is great, they comment on the anterior posterior location of the cage, which I agree with. But nobody comments on what is their subsidence rate with navigation. So, and then that's what we were talking about, that yes, the soft tissue navigation is perfect, but when you put your hardware in, you kind of like, you talk about paranoia, like I think I haven't gone over my paranoia. Maybe I have to take more Prozac, but I have to bring the fluoro because I don't trust it at the end to not violate the end plate. I know the risks of having fluoroscopy over time accumulate. I mean, I buy the risk.
Yeah, I think I wanted to show, where was it? It was that CT. Yeah, so I have the same paranoia too, because the idea is that with fluoro, you can tell if you're subsiding, because once that end plate subsides, like you're done, right? The whole point of the surgery is lost. And so I think, you know, some of the ways I've tried to get around it, naturally, when you're looking in the wound, you can see some of that disc. So much of it is feel, but unfortunately, it is still something that you give up right? Because I've certainly done cases where I put in a bit of a, I put in a trial, it's a little bit too big, then I put in the cage, a little bit too big. You're just looking at a computer screen, and then you shoot the floor and you realize, well, some of that end plate has subsided. The cage was just either too big or not. The way I've gone around, these are, the reasons why these cages look a little funny, they are custom 3D printed cages. And so I think, I adopted them right at the same time. And I wonder if, because these cages are a little bit softer and more patient-specific, I've gone away from seeing some of that subsidence because there's less hard edges that may dig into the end plate. But at least with some of these cages, I haven't had as many of those concerns that I did on the earlier side using the off-the-shelf cages. All right, if that's helpful. Yeah, Zach.
Just a comment on the coronally tapered cages, create a really nice correction with that.
Yeah.
Do you have any tips on the best usage for those coronal tapers? I think I've often felt when we're doing these this is, if we're doing laterals, especially on like a bow type C,
Yeah.
where you want to get a little indirect decompression, but you don't want to throw the coronal shift off too far.
Yeah.
Is that a potential usage for them? I haven't used the coronal tapers, but I've had some inclinations toward it.
Yeah, I mean, I guess in a way you could argue that this is also about type C or a primary lumbar curve. And I had the same concerns. And you'll see the bottom cages, and this has been a learning curve because I've been telling him to make that downside taller and taller over time. And what I did here, actually, I accessed, L1 to L5 with K-wires, but I actually did, I think in this case, I might have done the bottom ones first, if I remember. This last, I did about type C last week where I did that. And so I accessed everything with the K-wires, and then I did the lower curves first, right? So that way I would see if I got the correction before I actually committed. But I think about the same thing because you can certainly naturally throw this person completely off to the wrong side. And so for the coronal taper cages, that's definitely been helpful to try and push them up on that lower side to avoid kicking them off to the wrong side.
It seems like you've inserted pretty much the smaller side first on those. Can you go, well, I guess actually at 2-3 you went larger side first, but
Yeah.
does that take some extra care, not to violate the end plates? I mean, it seems natural, right? The cage you have at 3-4, okay, fine, you fit it in there and you
Yeah.
fix the curve, but you're kind of going backwards there at 2-3.
Yeah.
I mean, look, nicely done with no subsidence, but I just curious if there's any technical points on that.
Yeah, I mean, I think, the technical points and the great thing about, I think, the lateral course is there's so many ways to do lateral surgery. Again, my introduction to lateral surgery was straight to OLIF. And I think with the OLIF retractors, typically there's more leeway to see because either you have their anterior psoas, and so in that way, I cut underneath the psoas and I make sure the annulotomy is very wide. Yeah. And so I think in that way, my annulotomies are at essentially the anterior 25% all the way back past to the posterior. And by that large release, I think I get more of a discectomy, at least in my own hands. And I think that's why the bones move. And I think that's why in this case, I mean, the cages A to P are quite large, and it's mostly because I'm inserting them in sort of at the front corner, and then they fit into the back. But that's the only thing I can think of that might be a little bit different. But yeah, I mean, I certainly think about it, especially when you're going from the open side and you're lifting. I always go from the left, so whether I'm working on concavity or convexity, I always come from the left anyway, and so I haven't found that much of a difference. For the coronal taper, if you're coming from the convexity, naturally that larger side of a coronal taper is going to be that fat bulldog end, but it still goes in. I think it's just working it so that the disc space becomes horizontal, and that way, as the cage goes in, it lifts it to that horizontal. And that's the best I can figure.
So you're trialing to the larger side?
Correct.
Before you insert?
Yeah, so I still trial everything, and I trial it to I sort of measure it, because with the cages themselves, I just look at what the trials look like to sort of match it, and then I'll trial it to that.
Question. So you often go from cranial to caudal when you put your cages in. But if you're trying to fix a pretty severe flat back syndrome, do you put your A-lift first, 5-1 and 4-5, to get the maximum lordosis, and then go from the top down?
So if I'm doing this, I will still go from top down. I think I still assume that naturally if I'm doing the lateral ALIF at the bottom, then I'm going to get the maximum that I'm going to get. And so, doing that first, I think doesn't change what I do at the top. Again, that also said, I rely a lot on the predictive analytics of things. Many companies now will help to simulate what the spine looks like based off of either the cages you do or the osteotomies you do. And so I admittedly rely on that, right? And so it's not perfect, but based off of that preoperative simulation, I know that, this is the maximum I'm gonna get. And I always tell them to overcorrect at the bottom because we never get as much as we want, right? They will give you this beautiful plan, this beautiful design, and invariably it falls short. And so I always tell them to actually add a few degrees to the cage design or to the rod, assuming that the things they can't predict are the facets, right? What if they're hypertrophic? What if I actually don't release the disc as much as the computer simulation prepares for? But I'll still do that at the bottom, right? At the end, assuming that I get that correction at the bottom, and I haven't found any difference or downsides.
Can I ask Bill Taylor, if in this case you would go from the left, second, can you comment on taping and navigation versus a more fixed construction? The difference is make sense or not to have, the difference between taping and doing multi-levels, if does affect navigation or not? And if you go from the top down.
Yeah, so thanks. I mean, Martin's the one who's really the expert on navigation. It started, but I agree with you. The problem is normally when we think about it, we all start at the bottom, right? And work our way up. And I go from the top down now too, specifically because it's farther away from the PSI spin. You can put another spinous process clamp if you want to and get some correction. But I go farther away from the PSI spin, and I'll do almost all of these prone now, and I would have gone from the opposite side just because I think it would open it up a lot easier. These are cages from, I'm sorry, I'm blanking on the name of the company.
Carlsmed.
Yeah, Carlsmed. They're not just coronally tapered cage. They're specifically designed for that implant, and that's one reason why they go in so nicely. But it going from laterally, more direct lateral, or it would be hard to get in on that side. But I go from the top down, and I honestly put all of the pedicle screws in first. And like someone mentioned in the back, the biggest problem is the patient starts to sink a little bit as you go along, and so you lose the up and down when you're trying to do it. So, but that's a great result, and the idea of pre-planning it, I think if we're not doing that, then you're in real trouble. And I don't think it's wrong at all to use the unit or the preformed rod, because I find you get a lot of correction when you're doing that, especially when you turn the patient prone. And I think it saves you. And I also notice, if you notice your cages, people always talk about lordosis of their cages and what they're going to get. Those are not really highly lordotic cages. They're not hyperlordotic cages, but you still got a lot of lordosis because of the placement of the cage. So I think a lot of things goes into getting that lordosis too.
And again, for a case like this, it's 5 interbody levels. If I were doing this with fluoroscopy, it's going to be at least, everyone tries to reduce it. In my hands, it's always going to be like 5 to 10 shots, right? I take a look at the center. I'm not sure. I shoot posteriorly. I swing around to the AP. I mallet it in shot. It's not perfect. I take another shot. I swing around to a lateral again. It's a shot. And that's at each level, right? It's a lot of fluoroscopy, especially if you're going down the path of MIS deformity or even just a lot of multi-level lateral surgery. And the fact that the total fluoroscopy, and this wasn't perfect, I repositioned and mallet in a few of these, as I showed earlier. The total fluoroscopy for this case, though, was about 10 shots, which is a large reduction in X-ray.
Yeah, I mean, also, but when we're using navigation, Joe, I always remind people is the least, you were getting less fluoroscopy time for the surgeon, not for the patient. And I think at some point, that's going to come back to get us. I mean, 3 or 4 CTs in the same day, which I've seen people do in our OR, is a huge amount of radiation for that patient. I mean, I've seen them, as you know, they shut down the room sometimes because they've had so many CT scans in there. So we think about radiation to us, but at some point, we're going to have to start considering radiation to the patient too.
Yeah. Great. All right, thank you.
Awesome. Thanks, Martin. That was terrific. So Martin's going to change and go to the lab, and he's going to do an awesome, actually, he's going to demonstrate the exact navigated procedure he just talked about. And then I'm going to talk a little bit about sort of more advanced lateral procedures. But more importantly, I think, for me, I want to talk about some of the things that we sometimes forget about, which is, to me, it really comes down to the anatomy. And I remember, it's amazing, when you look back, Juan and Luis and I were talking about last night is, just how much this area has evolved. And I remember when I first did my first lateral case, I used a microscope. I was so scared that I was going to cut a nerve. I literally went layer by layer. It was like a 7-hour lateral. And then I found my first level was L4-5. I found the femoral nerve. And then back then they didn't have the nerve monitoring that they do now. And then I put my retractor right over it and pulled it back. And when I look back on it, it was crazy that I even did it, But that's how far we've come. And again, I've been very fortunate to, live in Seattle, have the opportunity to do a lot of this work at the Seattle Science Foundation. And then these are my disclosures. This is a new one, actually. This time last year, I was laid up in bed. I just gotten discharged from Harborview. I was there for a week. I had a bad ski injury, and this is my x-ray. I had a lateral approach on my knee. And thank God.
Was it minimally invasive?
It was
tubular?
It was open. Thank God, Jens Chapman, who saved me, is one of my doctors who was on call, and I called him. I said, Jens, I think I broke my leg. And I sent him my CT, and he goes, oi. So that's my x-ray from last year. But, when I think about lateral surgery now, it's incredible how much it's evolved. And even, guys like Jens who only do posterior, it's the cool thing to do now, right? Everybody wants to do minimally invasive. They want to do lateral. They want to do prone lateral. And there's a great picture of Dr. Pimenta, who has actually been a huge mentor of mine. And I know Juan and also Bill Taylor. Like I said earlier, when we first started doing this, it was amazing. I was so scared about the nerves. I literally would dissect. I use a microscope to go down. I'd find the femoral nerve and then dissect down. So to go, and I would never dream of doing a case like I show there, where you have a significant thoracolumbar curve. To me, it's unbelievable. And if you look at it from spine surgery, it's all the things that we want. It's truly minimally invasive. You have almost no blood loss because you're going, whether it's retropleural, behind the diaphragm, or retroperitoneal, you're right on the disc space. And then you don't even have to use fluoro anymore because we use navigation. We use a lot of navigation. And I think the learning curve has gotten better. The companies have gotten better. They do a better job with the retractors, patient-specific implants, the positioners. It's almost, when I look back, and it's really gotten to the point where it's very proceduralized. Again, for me, having done this for a long time, and then once you start feeling comfortable doing kind of the smaller procedures, you can apply to the cases that Juan showed, to the cases that Martin showed. And then I use it a lot, we use it a lot here because we're a tertiary quaternary center. We use it all the time for tumor trauma cases. I mean, there is nothing better and to do a one-level corpectomy with one above, one below. I mean, these patients do great. You don't have to have these huge shark bite incisions that, you know, traditionally we would do. But again, I think the most important thing for me is understanding this anatomy. Okay, so as orthopedic surgeons, as neurosurgeons, I never even knew what was in the retroperitoneum. You know, it's like you don't even care. The only time I think I got exposure to it is when, you know, you're doing shunts, and I remember I like didn't put the distal end of the shunt into the peritoneum, and everybody was laughing because it was all coiled up, and it wasn't even in the retroperitoneum. And so, you know, urology, general surgery, those areas, you get taught about it. When you look at a neurosurgery textbook, there's nothing about even the lumbar plexus. There's not even a chapter on it. And I remember, you know, Dr. Pimenta, when we talked about it, you know, we've been talking about this for almost 20 years, it's a completely different, it's like taking all these different specialties and you're merging it into one. It's really remarkable to me that you take all this technology now and all these approaches, and still, you know, our basic textbooks are all wrong. You know, you look at all the old anatomy pictures that they have, you know, they have these horrendous, you know, pictures of showing the plexus. And again, we've been fortunate here in Seattle where, you know, we published a ton on the actual anatomy. You know, we have really amazing fellows and research students who've taken apart, you know, and again, what we found is, so here's Jens, and then that's his cousin. You know, they look similar. You can tell they have some genetic similarities, but you know what? Their lumbar plexuses are going to be totally different. And to me, there is a lot of information that we still don't know. You know, and again, it's amazing to me. We were talking last night, you know, and my kids, I mean, everything is online. You know, textbooks are almost becoming like, they're digital, but, you know, everything is like, you have to be able to post an image of something to get kids' attention, even if it's for like 5 seconds. But to me, you know, if there's anything that you take away from today is knowing that there's nerves in the psoas, and then this anatomy is really important. And most lateral surgeons that are very good, experienced, they've had complications. They understand what's, you know, where are you going to have a problem? Is it going to be L4-5, L3-4? You know, how long can you put the retractor in? And again, we've done a lot of these dissections here, and I'm really fortunate. I've got great partners and amazing history here at the Seattle Science Foundation. You know, we've got Dr. Chapman, Dr. Mayo, Schildhauer. These are all very smart, experienced orthopedic surgeons. We've done tons of pelvic, lumbar dissections. It's incredible to me how much we still don't understand about this anatomy. Again, here's a cool 3D reconstruction of that's what the plexus looks like. I mean, it's so complicated. And again, these are some K-wires. You can see how, I mean, that's daunting, you know, to know that you're going to do a lateral approach and you got to go through all those nerves. And this is what it looks like when the nerves are dissected out. You can see there's the femoral nerve, there's the L3-4 disc space. And when you're doing obviously a lateral approach, you see the fluoro and you're doing neuromonitoring, but that's what you're dealing with underneath. And this is another great reconstruction one of our fellows here at the Seattle Science Foundation did for us, but you can see how complicated that anatomy is. And again, each patient is different. And in my experience, the older females who you look at their MRI and they have like, their psoas are really small. They're starting to get, sarcopenia, osteoporosis. These are very challenging cases. Again, fortunately, I'm very grateful for, the team here at SSF. We've been able to document digitally, whether it's through this course, publishing, a lot of our work and getting it out, getting the information out to surgeons all over the world, and even Omar, who, Juan and, you guys, it's amazing how I go to a meeting and they go, oh, hey, we saw your course and we saw Dr. Taylor and Dr. Pimenta, they did a prone lateral. And for me, these are kind of like my pearls that I've learned through the years, is try to get as much information as you can from the preoperative imaging. So I like to get a CT scan. Even if I have questions, I'll get a CT of the abdomen and pelvis. You can see the aorta, you can see the abdominal contents. You can see a lot of stuff in there. And again, with Hounsfield units, with pre-op planning, all the companies now have all amazing, sort of pre-built, you can do some of your measurements. Martin was showing some of them. And again, I think it's really important when you do these procedures, you don't want to start with the most complicated level and then start doing corpectomies and thoracic discs that Juan was showing. So you want to start with an easier case and then work yourself up to doing, the more complicated cases, doing thoracic discs. Then you can do some thoracolumbar stuff. And then again, I think the most rewarding cases for me are these. Imagine doing a lumbar corpectomy through a tiny, tiny little incision. That to me is like truly minimally invasive. But you have to understand the anatomy and you have to understand the approach. So if there's anything that you take away from today is I think, you'll see a lot of the procedures, but fully understanding where the plexus is, where you're gonna run into trouble. And again, this is, I'm glad to be standing. This is me last year. After my surgery, I had the fellows and my partners come visit me. This is me at Harborview. But these are the kind of cases that are so rewarding. Here's a patient, again, certainly you could do this from the back. I think for me, having, done a lot of lateral procedures, this is a great operation to be able to do from posterior first and then get some realignment and then go in and put a nice big corpectomy cage just like this and get really good realignment. Again, for me, I think probably starting in the TL junction initially, and then you can work your way down as you feel more comfortable because the plexus, retractor time, understanding all that anatomy, is important. And there definitely is a learning curve. And then here's some other, cases that I've done. You can see here, patient did not have anterior column support, morbidly obese. Obviously, the chances of that healing were not good to begin with. We ended up went in, did a lateral, and then staged it, and then went back and did a posterior approach. And again, as you start to, feel more comfortable doing these procedures, you can, like now, I never thought I could do a L4 corpectomy. I do it all the time. And again, knock on wood, my femoral nerve palsy, all those things. I've had every complication you can think of, but once you feel comfortable, you can start doing cases like this, where you can do, this is a patient who had, it's an L4 tumor. You can see through a tiny little incision, you can do this huge, and again, all the companies now have these, this is an expandable cage. Imagine, you have a cancer patient who needs to have a huge corpectomy, you can go to Barrow and have that operation down below by Juan, You can see how big Juan's incision is, and he has an access surgeon. He has a general surgeon, vascular surgeon, and a thoracic surgeon for one surgery, or you can come to Swedish and have a tiny little Band-Aid. What would you rather have? You know? So, and that's really, truly, you know, that's to me what is important, is because then you can start, you know, doing these cases. And again, I don't recommend you start doing these corpectomies down in the lumbar spine. Start somewhere higher up, you know, where you start to understand, okay, where's the disc space, where's posterior, where's anterior? And we use it a lot for infections now, tumors, deformity, revision cases. You know, you can do a lot. It's incredible, you know, with all the, I mean, look how nice of an implant this is, and how, you know, you got good end plate coverage. You can go in, you can get the entire posterior wall out, get good reconstruction of the anterior column. And again, I mean, these cases are, once you feel comfortable, after you do a couple, you can start doing, you know, this is a 2-level corpectomy that we did. And again, it's truly amazing that you could do this, and it's through a tiny, tiny little incision. The patients do great. You know, for me, is understanding the anatomy, feeling comfortable. And actually, you know, when we're doing these, you know, I really spend a lot of time going over that. I can't tell you how important it is just to review every single image you have. MRI, Psoas size, you know, all these things, the vascular anatomy. Use as much information as you can before surgery, and then have everything assembled, you know, have your cages so you're not spending, you know, an hour or 2 hours trying to figure out what kind of implant do you want to use. You know, for me, I think the biggest improvement has been in the devices, because, you know, you can start with a tiny little, you can use these small little core. This was like a medium-sized core cage. Look how much this thing expanded. I mean, this is truly remarkable. You know, when people talk about MIS, I mean, this is truly MIS. Unfortunately, you know, we still have to go in from the back and do the back part, but you can still, you know, you can take a lot of bone out from the front and get very good anterior column reconstruction. Here's some more cases. You can see that, you know, we did here. This is actually a case Jens and I did. And here, you know, this is an L4 corpectomy, right? I mean, who would have thought? I would have never thought 15 years ago, right, Luis? People, I remember I did my first one, everyone was like, you're crazy, you know, should not be, you know, you shouldn't do it. But I mean, here we are now, we do it all the time. And knock on wood, I mean, Jens, you've done these with me. How many femoral nerve palsies have we had? Yeah, you know, I've had injuries. That was early on in my career, again, when the neuromonitoring wasn't as good. We were kind of slow. We really didn't understand, you know, retraction time, all the different things we've talked about. So I think I'm gonna probably stop there because Martin's probably ready to go. But these are just some more cases. I'll just kind of zip through. You know, I mean, this is truly remarkable that, you know, you can do stuff like this and get really good outcomes. And then here's, I found a picture of Jens. This is in residency. I don't know if you guys knew, but Jens had a little bit longer hair. And this is in Dallas. He was at UT Southwestern. And he grew up in Germany. So when he came to the US, and he's a pretty talented guy. He's a musician as well. And so this is his band. I think they had just played. And so you can tell he's pretty excited. Again, you know, when you look over time, you know, we've just done, I think our fellows have reviewed our series. I think I've done probably close to 100 lateral corpectomies. And, you know, we're looking at everything. And in fact, one of our fellows, research fellows today is going to talk about, you know, does the Psoas shrink? or does it stay the same? Does going through the psoas make a difference? You can see here, I mean, we've done hundreds of these cases, and fortunately, we've got a great lab here. This is Gary. I think you guys all know Gary. We've done so many, cool things here at SSF. And here's a cool revision case that we did, Jens and I did together. This actually, a really grateful patient had this subsidence. You can see the cage. And then the patient had, Jens, you remember, huge anterior shark bite. The incision wasn't even close to where, and we were like, do we open the old one up and go in and do a Uribe incision? Or do we go in laterally and go behind it? And I said, Jens, let's go behind it. And how big was the incision, Jens? Tiny, right? And we didn't even have to go through the old incision. And we actually cut the cage out, and you can see there, I had to cut it in half and then take it out. And then you can see we just literally redid the corpectomy, took out the rest of the bone and put in a nice large interspace, and the patient's done great. Again, thanks to all of our fellows and everyone. This is a plug for our book. This was the first book on the anatomy of the lumbar plexus. It's like one of the top selling books in TEMA, thanks to everyone who was involved in it, but mainly, as I alluded to earlier, there's no books on the anatomy of the lumbar plexus. And thanks to all the faculty and everyone here, every year we do this course, I learned so much from everyone. So thank you so much. Any questions? Omar?
I got a question on that last revision case. Did you stand the ureter when you went back in there to revise that?
We didn't. We thought about it, and I think if our thinking is if we were going to go back in from the old approach, then we would do it. But since I was going to go lateral, Jens actually had already teed the patient up to have that done. I said, no, I think we can do it. I think it wouldn't have been a bad idea. But it literally was like pristine anatomy because we just landed right on the lateral vertebral body. And the only tough part was we just couldn't get the cage to come out because I don't know if you saw, but there was so much subsidence. And I didn't want to get into the end plate above and below. And so we had to use that metal cutting burr to try to cut the cage in half. That was the hardest part of the procedure, is to just get that cage to come out. But fortunately, we did not see the ureter because it was so, usually it's a lot more anterior. So, great. So I think we're now going to switch to the lab and see if Martin's ready for us. So Martin is doing a prone procedure, and he's going to do it navigated. And I also think he added the robot in. So Martin, how's it going? So you can tell he's got it set up there.
All right, can you hear me now?
Yes.
Oh, perfect.
Yep.
All right, Nick, come in the frame here. Nick's actually going to be doing all the work here. I'm just going to be window dressing. So what we have here is the setup for robot-assisted prone lateral. As many of you know, for any robot or navigated case, the screws go in first. So we've already done that here. The robot system is attached. Screws are in here. And to orient you, this is the cranial and then caudal, right? So we're approaching from the left. And so we're gonna get started on the approach. So Nick is gonna have the navigation probe, which is perfect. All right, so here with the navigation, and I think they'll be able to show you, hopefully, the frame in a screen by screen. He's looking for the disc space right now. And again, the benefit, of course, in all navigated procedures, there's no fluoroscopy here, so you're not shooting X-ray. and you're still able to see things in real time. And that seems like a pretty good starting point for incision marking. So here's going to be a marking pen to mark that incision on the skin. And again, my incisions, the skin itself is very loose. And so you can make your incisions about, like 4 centimeters or so, 1.5 inches. If you're doing for the first time, feel free to make it as big as you like. There's nothing that's going to compare to the size of a thoracic surgeon, right, doing a shark bite. So if you're ever unsure, just make it a little bit bigger. So once that incision is marked, Nick is going to be opening the skin here. And once we get through the soft tissue, he's going to identify the fascia of the muscle layers as well afterwards. Do we have a pickup for him? Like a rat tooth? Perfect. Let's do this one. So here's another for you. Let's go ahead. So he's getting through the skin right now. So subcutaneous fat. And then oftentimes for ease, once that's open, then you can just sort of spread a lot of that fat out of the way. And then here, he'll open up the fascia of the external oblique, so go ahead and open that. And naturally, once this is done, typically I'll use like a curved mayo to spread. We got a scissor here. So I'll sharply open the external oblique fascia with a scissor, and then once that's open, then you begin to spread through the layers of the muscle. So again, really no different in how you do any lateral access, whether lateral decubitus or prone. And then always important to keep in mind, the bed is rotated. Right now, the bed is pre-rotated about, say, 20 degrees. So that's just to help keep your brain in mind that you're traveling in a lateral orthogonal direction. Most people are sitting, so looking eyes down is very comfortable to do so. And actually, depending on the height of how you're sitting, right, you can get the bed higher up or down once you get to that stage. So right now, with the soft tissue dissection, the bed is fairly low. And then later on, as we start putting in the instruments, then we can raise up the bed too. So go ahead and put your finger in there. What do you think? Retroperitoneum? So this is a common, when you put your finger in and you're feeling, it's natural to put your finger up, like we're so used to putting our finger up. When you put your finger up, you're just dissecting soft tissue here in terms of the skin and the fat. So you actually want to put your finger down straight away from you. And what you're feeling, the fact that you're not feeling anything here is we're still not quite through,
there.
right?
Yeah,
So it's going to be a little bit deeper. So go ahead and take this and continue to spread through the muscle. Again, just put the tips are blunt, so just put them right in and spread. And as you put them right in and spread, you'll feel a hole develop. Again, as long as you don't cut anything, you'll be fine. So just go ahead and put it in and spread. And it's going to be a downward, again, the abdomen is going to be angled down, so just make sure you angle down and spread. Do you have that endokidner? Good. How's it feel now?
Getting there.
Empty space? All right, so again, for the tactile feel, naturally you want to be able to put your finger in and feel empty space. If you feel anything blocking you, and I sometimes describe it like a sheet. If you put in your hand and you still feel a sheet of something, you're still not quite through. So it's still going to be a spread. And naturally, if we had loops that are headlight, you can always look inside and look for that bright yellow retroperitoneal fat. For those of you who are neurosurgeons in the audience, it feels like, say you're doing like a peritoneal shunt, right? And you put your finger in, there you're intraperitoneal, but it should feel very free. So that feels free, yeah? Go and put your finger in so they can see it. So now what Nick is feeling, it's just all free in there. And the pads of your finger, what does it feel like?
It's soft, but lumpy.
Yeah, so soft and lumpy, which is the retroperitoneal fat, right? So soft and lumpy, so that's always good. So the next step, since we're navigating, just put this in, right? Initially, I'll say that if you can see the nav screen, what it felt like was this, right? So can you, Jed, can you go and zoom out a little bit? So on the screen, L4 is marked. So if you see a yellow dot, that's actually going to be L4. And initially, it felt like this, right? It just really wasn't going anywhere. And that, to me, tells me that we're still in the soft tissue. So now go ahead and feel that empty space and gently advance your nav probe. And go ahead and as you're advancing, make sure you're looking at the screen to give yourself an idea that you're traveling in the right direction, right? So this step is purely just to make sure we're in the retroperitoneal space, right? We're not gonna dock anything, place any K-wires yet. But this is to tell us, you see how close he's getting? So clearly at this point, we're in the retroperitoneal space, right? So this confirms that there's still not anything that's blocking us. So once I confirm this, I do spend a few, probably a minute or so. So go ahead and take an endokidner. I put my finger in, and it's gonna be finger endokidner, and then you just wanna sweep everything away from superficial to deep. So go ahead and do that. And oftentimes, I will have my tech on the back table make a sponge stick, right? So sponge sticks themselves will have a little bit more grip in doing so. Got a poor man's mini sponge stick here. And if your fingers are long enough, sometimes you're able to reach. I've never been able to feel the psoas in this position, just with the extra body habitus. But once you're convinced that everything is below you, now you can put in that navigated dilator again to really take a look on the screen if you're right on that muscle belly of the psoas. What does it feel like in there, Nick?
You can still feel that, the retroperitoneal space, and again, we're just clearing out, bringing that anteriorly and making sure there's nothing trapped posteriorly or towards the ceiling.
Okay.
And I think I'm as deep as we want to be.
Okay, so now switch it with the nav dilator. And here, the nav dilator is blunt, so sometimes I'll just use this, right, to sweep forward, right, to sweep forward. And again, you want to look at the screen, making sure you're not aimed too far anterior or posterior, right? And we're right there on the disc space, right? And so that's a very easy pass all the way there. Okay, so normally at this point, oftentimes they'll have like a navigated dilator that, as you saw from my talk, I'll put in a K-wire. In this case, with the equipment available, we don't quite have that, but what we'll use instead, do you have the outer cannula of this? Oh, thanks. So what we'll use instead as a guide is, here's an outer cannula. We're gonna send this down again. Right, I agree, all that feels free. So that seems, what do you think, Nick? That seems pretty reasonable?
Yeah, I agree, yep.
All right, so we're gonna slide this down over everything. And then why don't you pass that first dilator inside? Do you have a mallet? And then gently mallet that in. Okay. And then now the rest of the dilators will go on top of that, right? So again, like any MIS surgery, you just want to be sure that as you go down, it's a twist, right? So you want to twist it down so it passes all that soft tissue. Good. There's this one here. Perfect. Now, Nima actually put out on his slides like a really good tip and trick. And I think, when we take a look at these dilators, the most common thing that really makes a lateral surgery just very unenjoyable is actually you take this system and then you open everything up, and as you open it, all the fat just starts to pooch in the way, right? And so what I found, I actually do something similar, but instead of using Ioban, I will use a glove, right? So you can see a glove here, and my techs will then just take this and then put down 1 or 2, thanks, depending on how long the system is. So 1 or 2, and this will keep all of the retroperitoneal fat out of the way, especially as you open this up a little bit wider, right? So here's 2, and then now when you place this down, right, this sleeve actually keeps all the fat out of the way. So I thought that was really nice. So go ahead and put down the final.
Now with this larger one, would you like spin as well?
Yeah, so this just keeps
While
the,
getting it down.
yeah, I would still spin it since we're in a sort of an empty space. And then go ahead and insert this in. Okay. Again, during this time, things are not navigated, right? So you just want to have good technique and get a general sense of your airspace. And here you can still twist this around, right, to make sure it seats all the way down. So go ahead and hold on to that retractor, and then I will help attach this here for you. Okay. So we'll lock this provisionally in place. For me, I always like using the eggs. I never really like using the handles, so I'm just going to take this out so none of the navigation is blocked. And then we'll take out the outer ones. So go ahead and take that out. I'm going to open this. You can open it up slightly to fit out and take out the inner. It's going to be this one here.
Up here?
This tiny one.
thank you.
Yeah, it'll pin in. Is that opening? Am I wrong? Judd, which? Oh, that's right. Okay, thanks.
There we go.
All right.
Now we can open.
Yep, so go ahead and we'll take these out, and then we'll pass that down, and then now we'll get a general sense of where we are. Okay. So, go ahead, all the way in. Okay. So here, in this case, when I take a look at the nav screen, the things that I'm thinking about is, the nav may be a little bit off, right? Because when I take a look at this, really, the tip shouldn't really be in bone. But in this particular sense, what I would do, I'm going to loosen this, still change the frame so that it's going to be orthogonal to the disc. So this means, okay, good. So I'm going to lock it here. And what we're going to do at this point is we're going to open up the retractor and take a look down, right? So in this case, if the nav is accurate, then we're centered slightly on top of the disc space. If the nav is inaccurate, then we'll certainly be able to see down the tube.
Oh, all this one, you think?
Yeah, why don't you open that? Okay, and that's good there. And then why don't you open this one to pull everything back? And so at this particular case, now we're going to be working down the tube. So here's where I'll start to raise the bed. So bed will go all the way up. And then why don't you go ahead and insert in these lights too? And we'll take this out as well. And then, do you have another one of these?
Oh, gotcha.
And let me see, yeah, do you think you can move this down there? I don't want to touch it with my goopy hands here. Yeah, I'll get this for you, thanks.
Thank you.
Okay, good. So go ahead and take a look on down. What do you see down there?
Still seeing some of the Psoas, it looks like to me.
Okay, let's take a look. Oh, good. Okay, good. So go ahead and take this and then dissect down a little bit there. So when the inside looks that tapered, and especially sometimes when you use the glove like this, it keeps everything down. And so what will be helpful will be to just open these out just a little bit, to fan them. And now, when you take a look down, right, a thin layer of psoas, but go ahead and dissect down a little bit beyond that. And hopefully feels hard. I mean, hard is always nice rather than spongy.
It does?
Okay, good. Right, so there, some layer of fibers still that you see. Naturally, in this case, what I didn't show is neuromonitoring. So that question was asked earlier. I do monitor when I do prone cases, especially transpsoas, I do monitor, and that would be something that would have been done, I think, with the first dilators, naturally if we had neuromonitoring here. And so that's something to make sure that we're safe from the plexus inside the psoas. Okay, good. So why don't you take your nav probe here and tell me if you think that we're accurate or a little bit inaccurate. Okay, go ahead and aim this frame upwards. Okay, good.
So I am feeling the kind of sliding off the lateral osteophyte there, so
Okay,
it does
good.
feel accurate at this
And then that
point.
feels soft there. When you push that feels soft? All right, perfect. Okay, so now, once we've identified here, the steps that I do, and I know all the lateral surgeons in the audience have their own series of steps. I tell all my residents, as you'll see in my talk later, KCP, KCT. So KCP, KCT. First K is knife. This is a large knife. I don't think we have oh yeah, let's use this one. Thanks, here we go. A little bit of a smaller knife. So the first K for KCP is knife. So in the knife, you do your annulotomy. And so the annulotomy is done first with the knife. And then after that annulotomy is done, it's the cob, right? So KCP, so knife cob, and then your pituitary, right? So this is really what gets out that disc. So nice large annulotomy from as far back as you can get to as far front as you can get. You can square a box. In this particular case, there wasn't a whole ton of disc on that lateral aspect. And so the discectomy itself may not be as enjoyable in using the knife. So once you've gone through there, here's the cob. Okay. And then here, I'll cob in either direction. And here's the mallet. And again, here, really, as opposed to putting in pedicle screws where you really need the millimeter to sub-millimeter accuracy, the whole point of nav is just to get your general direction, right? So we're going directly orthogonal, and then we're going A to P, and to make sure we're in the disc. So,
Can we flip?
yeah, let's do this way. I'm gonna do this way. Thank you. And so here, on the screen, it looks like you're on and above that osteophyte in that dip. Do you feel like that's accurate or not accurate?
I do feel like that's accurate. So
Let me take a look in here.
I
Can I
think
see?
our retractor may be aimed a little too north. I think I might be at the upper portion.
Yeah, so let's move it here. So I'm gonna loosen this, and you can move the retractor looking down there where you like.
So let's, yep.
Do you feel like that's disc?
I feel like that
Do you have that
is, no, that is the osteophyte. So I think we just need to
Okay.
more so aim the retractor distal.
Yeah, can I take a look in there? Oh, there's disc, okay.
Yeah, it's kind of the lower end of our working space here.
Okay, I agree.
So
So go ahead and hold on to that, and we'll scoot it down. Okay, you want to slide it down? How's that? Is that enough for you?
I think that will be.
There you go. I feel like it's sinking in, yeah?
So I'll take the knife one more time.
Skinny knife, here you go.
Better.
There's the disc. Okay, good. Oh, great, thanks. Do you have a longer one?
Cobb?
Here's the Cobb.
Thank you.
You feel like you're sinking into that disc?
Yes, now, and I agree.
Good.
With our nav here. Mallet, please.
Well,
Thank you.
and so again, it's to make sure that you're going in a good direction, and anterior to posterior, things feel reasonable. Right? So here, and this feels normal. Again, the things that would stop me is if you're malleting too hard. If you're malleting too hard, you might be in that valley of the vertebral body at worst. And so a lot of this, although it's navigated, it's still the tactile feel to make sure that things make sense, right? Because there's always going to be the possibility of error still in some way. Okay, good. Go ahead and keep going all the way across. There it is. Sorry, I'm blocking you.
I think that final,
Yep, keep going. Perfect. So here, once you're all the way across, I do take this and I rotate it about 15 degrees north and south. This way you make sure you really release that annulus. Good. Back. Good. Okay. And this disc looks pretty small, but in KCP, so KCP, knife, Cobb, pituitary, the next case, kerosene. So in the kerosene, when you look down there, that annulotomy box looks a bit fluffy, right? And so there's a lot of debris. Actually, let me give you a pituitary. Why don't you use the pituitary, take out that disc. Forgot the P in KCP. Here you go. All right, how are we doing on time? Any questions so far? I think we're... Okay, good. Let me get section.
Can you hear me okay? Yeah, I think it's going good. Maybe if you can just show the disc, and then we'll start to get ready for our next speaker. So I think Dr. Taylor is gonna, like in 5 minutes.
Sorry, you said we got 5 minutes?
Yeah, is that all right? How accurate is it right now, Martin? Does it feel like it's pretty accurate?
It feels pretty accurate still. So
Great.
here's the Cobb. I can see inside, and this is sliding right into the disc space, right?
Great.
So it's still very accurate in this particular case. And naturally, you always just want to check to make sure your eyeballs match what you're seeing on the screen. And this is very accurate still, right? And here I feel the lip of that contralateral side.
Maybe if you can, Martin, just within the next couple of minutes, just get a lateral, just to see how far off or how accurate you are. Is that all right?
So you want a lateral X-ray?
Just an X-ray, yeah. Just to
Yeah,
see.
let's do it. So why don't we come in for a C-arm? Yeah. Actually, let's do an AP since you're there. Yeah, to make sure. Have the screws loose. Launch it back out 6 feet. Right, so there's the Cobb in the disc space. Our retractor's not perfect. It could be moved more cranial, right, if I'm being critical of that. But that's sliding along the accurate space. And why don't you come to a lateral now?
That actually looks really good. I mean.
wag south.
Martin. Martin,
Yes.
And wag south.
one. So listen, I usually like to put modular screws just to avoid what you see on the x-rays, that towers in your way, in case that you take x-rays. And then you put the towers when you finish with the lateral. And then
Sorry,
you cut
I
the
can't
rod.
hear you very well, to be honest. You said the towers will oftentimes be in the way?
Yeah, and because of that, I always use modular screws. Then
Yeah.
I do a lateral, and then I put the towers and the rods, and then, because you never know when you need an x-ray, even if you're navigating, the towers are always in your way, and if you put modular screws, you obviate the towers all the time. They also keep the bleed going, the towers. When you have modular screws, you can, the bleed is less, a little losing. So it's a lot of advantage on the modular screws.
Yeah, no, I definitely agree. And in one of the pictures from my prior slides, you'll notice I also didn't have any towers on. If you take a look at that AP, sometimes those towers can block the contralateral side, and you just never are really sure if the cage is all the way across or something looks odd, and it distracts the eyes. And so routinely, I also do the same. I'll leave all the towers off, and then I put them on at the end as well. All right. So here on the lateral X-ray, again, we're in that disc space, so pretty much exactly where I would have wanted if we had continued right the rest of the discectomy and then placed the cage as well. Okay. Any other questions from the audience?
I think we're good. That actually looks really good. Thanks, Martin.
All right, perfect. All right, thanks, you guys.
Fantastic. So we're going to continue, and Dr. Bill Taylor is going to talk about how he sort of evolved in the last 20 years.
Evolved.
Yeah.
I'm glad you didn't say transition, so I say evolved is a lot better. So 25 years ago, I went and visited this guy in the upper right-hand corner, and I thought that I would just go to, Brazil, and I'd have a nice time. I'd see Sao Paulo, and I'd see Rio. I had no idea that he was going to change my life, and that I was going to spend the rest of the time trying to catch up with him. He still rides that a lot better than I do. That's the first paper we published a long, long time ago. I also give Martin a hard time because he always shows pictures of his impossibly cute children. So now that I have a grandchild, I thought I'd have to put that up there. Most of my good ideas come after a little bit of food and wine and books too. But I always like this picture on the bottom because this little kid thinks this sign is so important. It's important to them, and I think too often we're standing up just spouting off things that we don't really know about, and we're not really sure what we're talking about. I always say I'm not really here to take away your plan, but I actually am. I'm here to help you change. I'm here to help you evolve. I'm here to sort of move you forward. I'd much rather be here in all these places, but this is sort of what we got. So I'm talking about prone versus lateral, not just lateral. So we're trying to compare when do we do prone, when do we go lateral, and how did I start in lateral and end up in prone? And I think that lots of times that's really easy to answer that question if you just promote and pick the right questions. So we always look for answers first. Everybody talks about those things over on the right, which are the answers, but the questions are really how we get there. And I think the questions are much more important. And I probably could stop after this slide, to tell you the truth, because I think these are the sort of the things that we really look for in surgery. So what are the questions we're asking instead of trying to provide the answers right away? How do we promote lordosis? Well, that's easy. You put the patient prone. You get 5 to 7 degrees just free by putting the patient prone. So why would you give that up in lateral? How do we maintain correction, prevent subsidence? Easy. Large grafts, anterior column support, which is what all lateral is about, right? Posterior support, being able to do that very, very easily. Put in pedicle screws, you don't have to stand on your head, you don't have to lean sideways, you don't have to rotate the patient. So doing a prone is how we were thought about doing it. It's easiest. Then at 5-1 is the real problem. So what do you do at 5-1? And someone asked a question earlier about lordosis and 5-1 and cages, and I would tell you that is the primary advantage of doing something lateral, in the lateral position and getting a lateral lift. And anyone that tells you they can compete with that, I don't think they're telling you the absolute truth. What I can do is I use a multi-cage T-lift. I put 3 cages in. I prevent subsidence post-operatively. I gain what I get from lordosis. I do a minimally invasive T-lift or a PLIF. But I would tell you that if 5-1 is your problem and you're looking for lordosis at 5-1, out of proportion to what you have, then it's going to be really tough to get that with a T-lift. But I can prevent subsidence afterwards. How do we reduce complications? Streamline, speed up the surgical procedure. Someone just showed a case, I forget who it was, an OLIF, 1 level, pedicle screws. They said it in 2 hours. If you looked at the timing, it was an OR, or it was Martin. The OR was supposed to start at 7:10. He made skin incision at 8:39. So I think you should count that in the time for the patient, because all the positioning time and everything you do takes time to get there. You turn the patient prone, you position them prone. It's easy, fast, and everybody knows how to do it. So speeding up and utilizing navigation. Yeah, absolutely, you can put that pin in the iliac crest. You can work sideways. You can put in pedicle screws in the lateral position. You can do a T-lift standing on your head if you want to. But the reality is, it's 100 times easier to do that when the person's prone. The best comment I ever heard was right here. It's much easier to do a lateral surgery in the prone position than it is to do posterior surgery in the lateral position. And that's what I always try to remember when I'm doing it. So, simplifying decision-making. You're going to run into some case that you're doing where you can't do what you set out to do, right? I'm down there. I planned this great case. Like the scoliosis patient we showed earlier, L1 to L5 lateral. I'm going to get this great correction. Everything's going to go great, but that's not going to happen every single time. And when you have a problem and you're in the prone position, you can easily release the facet joints. You can easily gain lordosis. You can easily decompress the patient posteriorly. So it really simplifies your ability to make decisions because you have options. So I would say for all these reasons, think about why you're doing that and then go from there. And I do think that toxification is a new word. It's something that people talk about with our current political process. You know, we're not really discussing ideas anymore. We're branding people as good, bad, left, right, instead of talking about ideas. And I think sometimes we sort of look at these procedures as company and surgeon specific, which is exactly what I'm doing right now. I'm talking about PTP versus LLIF versus OLIF, and Louise is going to talk about something later. The reality is that if you look down at the bottom, these are all the sharks swimming around you. And Neil is going to come up right there, and he's going to scare you with all those cases that he does, and he's going to show you the last 200 levels he's done since last week and all the patients he's operated on. But the fact is, I think if we look at this in a different way, we're doing ourselves a better service as surgeons. So I would like to take what I consider a patient-centric approach. Now, of course, my patient-eccentric approach is going to end up exactly where I want it, doing prone and doing a PTP. So I apologize for that ahead of time. But let's talk about what a patient-centric approach is and what are you asking. The first thing is, what are you doing, right? What level are you operating at? That makes a difference. What side are you coming from? That makes a difference. And then why are you doing the surgery, right? Do you need to gain lordosis? Do you need posterior access? Are you doing a standalone case? Do you need to do a decompression? Can you rely on indirect decompression or direct decompression? What's the correction that you need at each level? You know, it may be that you have to do an ALIF at L5S1 because there is no better procedure at 5-1 to get correction than an ALIF from the front. And if anyone tells you different now, we're certainly working on things that are going to change that around, but that's a long way coming. And then how do we easily do fixation, right? I mean, it's pretty easy to do fixation when the person's prone. And I learned actually from around here that from looking at everyone's cases, pretty much make an incision midline, pull the skin over. It doesn't matter what the incision likes. What matters is what you do when you're inside. And then where are you working too, right? What are your facilities resources? So I have people that are doing, surgery and you just need a fluoro machine, but do you have a bed? Do you have navigation? Where are you doing this? How long can the patient stay in the hospital, right? If you have a problem, where do they go and what happens? And then management of complications. What do you do if you get a vascular injury in the ASC and you don't have a vascular surgeon within 200 miles, right? And then it's a real problem. So I think people have to think about where they're operating. Do you have navigation in robotics? Because the reality is, the reality is that the navigation in robotics is used. Now, all I did was search an AI to tell you what the complications were. I would say that this list of complications is certainly not extensive. I didn't research, I didn't do any work on it. I just plugged into AI and they spit out. I always look at it as nerve, vascular, and abdominal complications. And each one of these procedures has a set of complications and risks. If anyone tells you they never have a problem, then I think they're really not telling you the truth. But the thing that we always forget about is that TLIF and other procedures have lots of risks too. They have CSF leak risks, they have all kinds of risks that we don't think about, including pseudoarthrosis and other things. So everything we do has risk, and how do we manage that for each procedure? So this is a case we did last week. I think, to me, this is a good case to look at. It's a patient I've had for a long time. I did not recommend the stimulator, but it got in there long before I saw him. He's had an ACDF, he's had a couple laminectomies, and now he's got pretty mild adult degenerative scoliosis. But what level are you operating on? So we go back to the what level are you operating on? And I think that becomes important because really you want to think about what's the anatomy at the level that you're operating on and how is it critical? Do I need to do something where I come in and avoid the psoas muscle or avoid the lumbar plexus or avoid the vascular structures? And the fact is each level looks a little bit different, right? So here you're at 2-3, the vessels are midline, your plexus is posterior, you've got a kidney in the way of the retroperitoneal space, but it's no problem to get there. You don't need a posterior decompression. You're gonna go from the right side, as I know Martin always says he goes from the left side. How much lordosis do you need for this case? And we averaged it at about 10 degrees. And the reality is, I think this is a level where you can do a direct access, 90 degrees from the side. It's very simple. You go trans-psoas. No one's gonna bat an eye on that, and you're not gonna have any trouble for all those reasons. So each level that you operate on makes a difference. 3-4 is really the same. Do I need to do a decompression? What's the retroperitoneal space like? Which side can I go from? And the fact is the right side is preferable in this case because of the scoliosis. I can go directly lateral. I can go through the psoas muscle. I don't need to dissect anteriorly. I don't need to avoid any lumbar plexus. And it's so much easier to work directly lateral, straight up and down the tube, not at an angle, and start out in that direction. What happens when you get to 4-5, okay? So in other words, here, the vessels are moving a little bit laterally. Are we heading for the 50-yard line? If you look at that, you might see, and again, I think that although you can see some of the lumbar plexus and it's starting to creep in front of you, you have space on the left in front of the psoas muscle, but you want to do the other side from the right. So now you're sort of stuck on the right. If you're going to do this prone, you're going to get about a 15-degree cage. You don't really need a direct decompression. And so what I do at 4-5 now is sort of a new procedure that I call the prone angled trans-psoas, which we'll talk about in a second. And then we're at 5-1. And again, for me, if I have a low PI patient like this person is, I need about 30 degrees of correction. My sagittal balance is about 7 to 8 centimeters off. This is someone that's ideal for this procedure, and I can easily prevent subsidence and get some nice distraction. And this is sort of what we end up with at the end of the day. We take out that stimulator and then put it back in at the end. We can gain about 30 degrees. I think that the preformed rod, a unit rod, is great. As someone talked about earlier, I do a facet fusion or a posterior fusion at the levels above where I don't want to do a lateral. I certainly could have done a lateral at 1-2 in this case, but it was quite easy to do those levels. And I think this works out really, really well. It's a PSIS pin posteriorly. You spin, you navigate, plus minus for me for the robot, a nice correction, and I think people do really well from that. So this is really comes from Louise. He sort of talked about table rotation technique at 4-5. And I think this blends the two procedures really well together. So in other words, what I usually start out is I start thinking about angled transpsoas. So if you look at the middle screen, we're sort of diving in there. I'm coming down through the front of the psoas. I'm angling. I still have the patient directly lateral directly in the prone position. But with navigation, I can identify that spot. I usually pre-plan that when I'm doing that. It's almost impossible to do this with fluoro. You can't get there. And so you look on the CT scan, you get about 15 degrees, and then you're in a good spot. But when you get down to actually doing the surgery, which is the middle piece of it, I don't see any reason, and that's why I call it the navigated table rotation or a prone angled transpsoas. I am really hopefully taking the best parts of the O-lift, direct lateral X-lift, patient's prone, coming in just in front of the psoas muscle, avoiding the lumbar plexus, avoiding the vascular structures, using navigation to get to that point. Now, I can easily dock where that green line is, and in fact, that was my plan. But so often I end up farther anteriorly through the anterior part of the psoas and in that spot. And so it's very, very easy in that spot to get down to there. And then I can very, very easily use my navigation piece. This is another case from the left side up on top. I'll go through the anterior portion. This is my plan beforehand on the blue line on the top. The reality is you don't need to follow along that. I first started off shooting for the 50-yard line, but with a 2-bladed retractor, as you can see in the fluoro on that side, I can dock very far anteriorly, take advantage of avoiding the lumbar plexus if it's a problem, avoid the psoas muscle, and then I put the shim in that spot. I put my anterior shim in, I expand my posterior blade posteriorly, and I then put a posterior shim in, and I rotate the retractor to 90 degrees. And I think you get the advantages of all those procedures, especially at 4-5. I don't think it's necessary at the other levels. I think we're kidding ourselves if we don't think each level is different anatomically. I think we should think about how we operate on each level and what the advantages are for prone. And this is sort of the cage that ends up there. And again, this on the bottom is, you can put 2, sometimes 3 cages in there. I can get great distraction. You gain about 7 degrees of lordosis in the study that we're looking at in that spot. And that's sort of where I like to end up now. And I think at 4-5 especially, it makes a difference. So we sort of talked about each level is different. So my procedure gets tailored to each level, and it gets tailored to what the patient needs. So why am I doing it? And the reality is, if you're going prone, you get a lot of other advantages just from that position. Psoas changes its location. It starts to move a little bit posteriorly and gets out of your way. The plexus moves posteriorly. The peritoneum falls anteriorly and gives you more space to work in. You can absolutely gain lordosis very easily in the prone position. That's why prone surgeons have an advantage over us. So don't forget, you want lordosis, you want space to work in, you want to move the lumbar plexus away from you, and you've got an excellent, excellent opportunity when you position the prone and when you push a frame. And in addition, the iliac crest moves farther out of the way, so 4-5 access becomes very easily. Familiar position takes 10 or 15 minutes to position the patient. Simultaneous access is nice. Better access to 4-5. Coronal bend with a table in there correcting it. And these are sort of all the things that you get from going prone as compared to doing lateral surgery in the lateral position. But I always go back to the point that it's much easier to do lateral surgery in the prone position than to do posterior surgery in the lateral position, especially with navigation. And the fact is, you gain, this is a study which we sort of looked at what you gain when you put the person prone in segmental lordosis as compared to a lateral surgery. These are standard cages in some of them. And so really what you get is you get about 2/3, whereas if you're in the lateral position, you get about a little bit less than half. And then you gain the advantage from the person being prone. You can reduce the patient prior to doing the lateral, which is very nice when you're doing it. You can either do that with positioning or you can do it with distraction. And that's really nice to be able to do that. And this is a multi-center study, which you can see a lot of people were part of. Louise is on there. And the reality is, looking at the prone complications, there really are pretty similar to what you would expect. You definitely have some anterior thigh numbness. The vast majority of those, 75%, are mild. And the reality is if you do this with neuromonitoring and you follow along, you position the patient appropriately, and you are careful in using the docking technique, persistent radicular palsy is really dropped to 0.5%, femoral nerve palsy 0.5% in that location. So you really have gone that very far, and the reality is no increase in other complications when you turn the patient prone. So the reality for me when I'm doing it is, number one, ask the right questions. What level are you operating? Why are you operating? And where are you operating? And those things give you an advantage when you're talking about prone because you're managing your complications. So, and what do I like about doing that? Simultaneous, very simple procedure. It's almost impossible to do that when the person's in the lateral position. You get single position surgery without the trouble. Positioning, lordosis, again, and also time, right? I mean, the reality is you turn someone prone, it takes you 5-10 minutes to do it instead of taping the patient down and really working at it. Psoas gets rid of your neural complications. Your retroperitoneal space enlarges. I really like the idea that this is easier for decision-making and instrumentation because you're going to do a case, you're going to run into problems sometime. I can't get lateral, something happened, the patient had surgery that I didn't know about, which is you see people who video visit for the first time and they come in to see you. They said, oh yeah, I forgot, I had a bowel obstruction, I've had 3 separate surgeries, and that's going to happen to you. So how do I manage that? And the reality is you can always do a T-lift from that side very, very easily when you're prone. I really like the idea of a multi-cage, which allows us to really prevent subsidence postoperative. We looked at about 50 cases in that with multi-cages. The total subsidence is still significant because you're really talking about intraoperative subsidence, but postoperatively, 2 cages are the same as an ALIF cage, and in fact, the surface area is slightly larger. And the reality is you can use direct versus indirect decompression when you're prone. You can preserve all those advantages, and I really think that the neuromonitoring is absolutely critical. When you follow along with the neuromonitoring, if you do that safely and carefully, you can do this with a very, very low chance of any neurologic problems. And I put that in bold because Martin already talked about it. The reality is about 50% of people in the world now in a mature practice are using some sort of navigation. If we can't make this procedure navigation friendly from beginning to end, they're not going to be doing it in 10 or 15 years. And it's very, very easy to do it when you're prone. And I use robotics in exactly the way you're not supposed to. I use it to try to keep up with Martin because he does every case like that. So I use it occasionally because the residents tell me it's so much faster when you do it. And then I say, I don't really like it. And then I spend another 6 months and then I do another case. So don't look at me for the robot. But I absolutely think if we can't continue to advance that, you're going to run into trouble. So think about the patient. What level am I operating on? What are the risks at that level? Why am I operating and where am I operating? And I think what you'll come to find out is turning the patient prone makes it access very, very easy, and start thinking about sort of the Luis Pimenta technique of table rotation, which with navigation, I call it the prone angled transpsoas with navigation. And I think that's a good way to sort of mix the 2 procedures and avoid any problems with the lumbar plexus. Thank you. Any questions? Yeah.
I've got a question regarding in this particular case, the crest comes down just below the super end of L4.
Uh-huh.
And to me, that would be an easier prolateral approach to do. But what happens in the case where the crest goes up a little bit higher, just to the level that this space of 4-5? In my hands, I've never been able to do it prolateral.
Yeah, so if you look at the literally, and Louise I know did an excellent study, you might be showing it later, about looking at access to 4-5. So access to 4-5, with the legs slightly extended and a little bit of coronal bend in the table is actually better when you're prone than it is in the lateral position. Because when we started, I took out a couple pictures of us putting people like at, 80 degrees in the lateral position, thinking that was going to open up the space. And the fact is, it doesn't really open up the space, especially at 4-5. So the best way to access 4-5 is to prone position, in fact. And there's a couple studies looking at that. The second thing is, there are also instrumentation that allows you to get down there. So there's a lot of angled instruments that you can get down there and work at. And whoever just showed a case, I think it was Rod that just showed a case, you saw those angled inserters that he had. Those were like 20 or 30 degrees. Use the angled inserters and all the angled instruments, and you really can get in there very, very easy. And I don't think the iliac crest is a problem anymore. The time that people call me and they say I had a problem, if you look at the film, it's almost always a transitional level. So they've counted 5-1, there's an S1, S2, there's a transitional level, the vessels are wide, the psoas muscles have split, the lumbar plexus is anterior, and you should not, which is exactly this case here. You really shouldn't be doing it. So look at your anatomy in the retroperitoneal space. You're going to say something?
Can I complete a little bit the question? Instead of asking the crest is high, you should ask, what is the contraindication of 4-5, right? And the contraindication of 4-5 is not the lateral X-ray that shows the crest high or not, is the AP MRI. And why is that? Because we learned in the past that when you see the Mickey Mouse style of psoas muscle, you start thinking that this is a transitional level. And recently we did a study that, because we have right now the patient in prone and with the leg extended, the muscle comes backwards, right? And as the muscle comes backward, they will not be anymore a Mickey Mouse. The problem is, where are the vessels? So it's not anymore the Mickey Mouse that tells you that it's a contraindication, are the vessels. If you see the vessels on the lateral, going lateral to the vertebral body, this is a contraindication. This is a real transitional level. So the contraindication is transitional level. How is the MRI? So forget lateral X-ray, forget to see where the crest is, touching the disc 4-5 or above the 4-5. We learned that with the positioner, we move the crest 25 degrees. So it's possible to do everything, but the risk are the vessels, not the psoas muscle, not the plexus, the vessels.
Good, yeah.
Bill, that was really good, amazing. It's become so far with lateral, it's ridiculous. But let me ask you this, now that you're done prone, would you ever go back to doing a lateral transpsoas? Would you ever choose to do a lateral transpsoas?
Yeah, so I think when you look at that, I thought someone might ask that question, because the reality is we sort of talked about going transpsoas, and I think it matters what level you're at and what it looks like. So I think we become sophisticated enough to say, I can go, we'll call it directly lateral because everybody knows what that means, although no one really does that. We can call it an X-lift, we call it 90 degrees, whatever you want to. But I do think at what level you're at makes a difference. And if you're at 2-3, it's so much nicer to work orthogonally from the very beginning. I don't think you have to worry in that case. And the vessels are out of the way, the plexus is posteriorly, especially when they're prone. And I really think that docking situation makes it so much easier. With a 2-bladed retractor, you could dock in any location you want and then open the retractor. But I do agree with you. I have gone now, especially at 4-5, and we stimulate now in those levels, and we're greater than 20 milliamps almost every single time because the plexus is posteriorly. And I've gone to more anterior with the prone position, using navigation to do that, and then opening posteriorly, which you've been doing at every level for a long, long time.
Thank you.
Yeah, but the difference is through the psoas muscle.
Yeah. So we'll come down, so we still do that. And I would say in that, the paper that we showed, I mean, the reality is trans-Psoas, neuromonitoring, looking at the level, a mature practice, your persistent femoral nerve palsy should be way less than 1%. All right.
So I think we got a break right now, right? A small break for 15 minutes.
Look at those nice cages.
So we don't need a break, actually, please.
Two chili cages that you show.
Exactly.
Is a two-level chili. Two chili cages in.
I guess Zach is in the lab. I hope so. I think Zach's doing your demonstration on the XLIF into-body fusion. Hopefully he's in the lab. Zach, can you hear us?
Just in case if it's necessary.
Yeah, here, why don't you just, you can just, yeah, that's fine, we'll just,
Zach, how are you doing? You ready?
yes, we are good. Can you folks hear me in there?
Yeah, we can. Go.
Okay.
Go, take it away.
So I'm Zach Napier, Indiana Spine Group. We've got Mark Kramer here, fellow, who's staying on as faculty, superstar fellow here, and we got Anthony on the C-arm. So we're ready to roll here. We're very excited to show the lateral interbody fusion, the surgery that started the whole movement. The original paper from Dr. Pimenta and Dr. Taylor was out in 2006, but Dr. Pimenta told me he's been doing these since the 90s, the late 90s. So this surgery is an awesome surgery. It's very effective. It's a gold standard. I personally have migrated to the PTP, the prone trans-Psoas. I very, very rarely do this surgery, but it's a great one. And the principles are the same, whether you're doing a lateral surgery in the decubitus or the prone position. So we're gonna go over those principles, which are positioning, retroperitoneal access, docking, disc preparation, and cage placement. So positioning, of course, this patient is in the lateral decubitus position. It is critically important that you position your patient so that the disc space of interest is parallel to the floor. You want your C-arm technician working from straight up and down to parallel to the floor. Orthopedic surgeons will get that. We like things to be orthogonal. So I started with an AP X-ray. Are we able to see on the screen that AP X-ray? Awesome, okay. So it is a little bit blurry, but what we really want to note is that there's not a significant amount of rotation. We have a clear view. The bottom disc space in the screen is 5.1. We can see 4.5 here. The pedicles, which look like eyes, the pedicles immediately below the disc space should be roughly symmetric. The spinous process below, which looks like the nose of a face, should be in the middle of the face. So this is an acceptable AP image. And then we move to our lateral image, if we could just put that on the screen. This cadaver fortuitously has a degen spondy at L4-5. The crest, we've been able to move out of the way through our careful positioning. We'll be working up against the crest here, but I think we'll be able to get the job done. So if we could, actually, if you could just pull out for a second, Anthony. Watch the camera there, yeah. And we'll shoot to the camera here on the patient, please. Can we do that? Can I move the camera? Oh, nice, okay. Where's my cross? Thanks. So if we could get a top-down shot here, folks. Oh, we got it, perfect, okay. So just for an orientation standpoint, I am at the posterior aspect of the patient. So this is posterior. This is the pelvis is down here. Head is up here, and then this is anterior. So nothing too complicated. I've just drawn out the L4-5 disc space. This is the iliac crest we can feel right here. And I made an extended line through the disc space. This is to aid in our C-arm technician in moving in directly along this line. So we have an appropriate AP X-ray. So that's positioning. Can I see a knife, please? In terms of access, I make an incision directly over the disc space and go through the dermis of the skin. Much is made about the layers of the abdomen. You'll encounter the external and internal oblique musculature here. I typically go through that bluntly. Much of the time, you can just stick your finger right through the transversalis. If you can't I see a scissors? Yeah. If you can't, I prefer to use a scissors, and I put the tip of my finger just about a centimeter from the tip of the instrument. So that way I know if I go through, I'm not plunging to a dangerous extent. Plunge through the transversalis fascia, open the scissors, and we've entered the retroperitoneal space. Now, it's important to know that you're in the retroperitoneal space. In the prone position, it's a longer working distance. I will often use an accessory incision just to confirm that. Here, it's a little shorter working corridor, so I like to feel that I am, in fact, in the retroperitoneal space. Specifically, what I want to feel is, I want to feel the inner surface of the 12th rib. I want to feel the transverse process of the vertebra I'm working on. I want to feel the undersurface of the ilium. These are the boundaries of our potential space here. So this windshield wiper maneuver allows me to establish that I am in the retroperitoneal space. If I can put my finger directly onto the psoas muscle here, I don't think there's a need for an accessory incision in this case. So the next thing we'll do now is position our dilator exactly where we want it on the disc space. So I'll have you pull in, Anthony, and I'll take the first dilator. And there should be a K-wire in there. Yeah, so pull in, Anthony, and let's just get a nice lateral shot right over our disc space of interest. Okay, so this is a pretty good lateral x-ray. We can see our 4-5 with our degen spondy in it. So what I'm gonna do now is, and this patient is thin, but not every patient is thin. So passing this dilator, I wanna pass it along known landmarks. I never want this blindly traversing the retroperitoneum. So I'm putting it along my finger, directly inserting onto the surface of the psoas muscle here. Can I see a grabber here? So Anthony, can you raise the C-arm slightly, please? Or is the camera right on us? That's okay, that's okay. You don't need to, I'm good here. So if you could give me a shot there. So I'm gonna just center my dilator, shot there. And shot here. Let's see a shot there. My brain is working backwards because I'm used to doing this in the prone position, so left is right and up is down, but we can still get where we need to get. So, shot here, please. So, let me see a, do you guys have like a way to advance this? Okay. Hold on one sec. Let's get a shot right here, please. Okay, great. And then you can pull out slightly. Do you have a mallet? Okay. So as I'm going down through the psoas muscle, I am mapping the lumbar plexus. When I first heard this term, I thought, are we making a treasure map? What does this mean? Are there Cartesian coordinates involved? What it really means is that we have to be certain that we are anterior to the femoral nerve. We are anterior to significant motor branches in the lumbar plexus. The way that we do that is we use a directional triggered EMG. So we will be stimulating where this probe is in each direction. And what we want is a low number means you're close to the nerves, a high number means you're far away. So as long as we have low numbers that are only posterior to us and not anterior to us, we're okay. We're okay to move on. If you have low numbers in the front and low numbers in the back, you are in an axilla of the lumbar plexus. It is not safe to proceed from here. So we're going to do our plexus mapping here. We're not really, this cadaver is not really hooked up. So we're just going to pretend that we have kind of high numbers here, maybe some low numbers at 4-5 behind us. That's okay. And so I will now sequentially dilate down onto the psoas muscle. So when you dilate and use these dilators, I like to have a continuous downward traction on the dilator. So I'm really feeling some tactile feedback as I'm dissecting off the disc space with this dilator. So we'll move. Probably looking at about a 110 working length here. And each dilator we are stimulating with the EMG as well. And these dilators will have a tendency to back out on you, so you'll want to keep that downward manual pressure on it. And now let's see do we have another dilator or we're into the retractor? Yeah, so let's see a retractor, if you could get it just fully closed and not towed or anything. And we'll drop it right down on our disc space. We'll get a little more, yeah, 110 would be about right. Whatever. What's closest to 110? 100, 110. Oh yeah, 110 would be perfect. Thank you. How you approach the disc space, it really depends. Traditionally described as in the posterior 1/3 of the disc space. I think that's reasonable and totally appropriate here, so that's what we're going to do. There are certain retractors that allow you to attach in the front of the disc space, which is another option. We're going to be modeling a 3-bladed retractor right now, which is designed to attach in the posterior aspect. So just as we get that retractor over to us, we'll proceed. Yeah, I think if we're plus or minus 10, that's no problem. 100, 120. I would say any questions, but the audience here literally invented and perfected this surgery for 20 years, so it's probably me who should be asking the questions.
Hey, Zach.
Yes, is that Dr. Pimenta here?
Yeah, so one thing that I want right now to criticize your approach is that you use the medicine ball to cross the 3 layers of muscle straight in direction to the in-4-5, straight to the retroperitoneal space. This technique, we usually dissect more posterior in direction to the quadratus lumbaris, and then we do this bluntly. If you do this bluntly with a scissor, you have higher risk to cross the peritoneum, right? And maybe have bowel injuries. So that's just a commentary here. Even in what I'm telling is that even in lateral, if you want to use the scissor to go through the retroperitoneal space, you should go more posterior.
More posterior.
Yeah, and then you can go bluntly. But if not, you have to dissect layer by layer, look to the peritoneum, and then with a finger take out the peritoneum from the direct approach.
I mean, if I can continue on what Luis said, I think it's a really, really important point. For me personally, I've completely gone away from any sharp instrument whatsoever. Once I hit the external oblique fascia, your finger will never damage anything. You can use your fingers to go all the way down. I've actually defended 2 bowel injuries from exactly this. As Luis said, if you're as good as Luis and you go posterior, you're safe. The problem is people go with the met straight down, and you do get bowel injuries or peritoneal injuries from it. With your finger, interestingly enough, it's very rare to damage anything. And you look at vascular surgeons, they never use this. Vascular surgeons do not use medicine balls. We use it a lot in our technique, we're used to it. They use fingers a lot, you learn from them. Plastic surgeons, these guys all use fingers. So fingers are good though, you won't damage anything. So just the added point. Or do it like Luis, be really careful and go back. Stay posteriorly to avoid that.
Yeah.
Peritoneum, that's all.
Thank you. Yeah, great points. I typically am using finger only for 90% of these. I think if there's a tympanic, hard transversalis in a young patient I can't push through, should have made a better point. Yeah, direct that posteriorly. And again, I was holding the medicine bomb in a way that, a centimeter or less is exposed. But either way, working posteriorly, accessory excisions, yeah, all really good points that I should have mentioned there. So we're going to bring our retractor down now to the spine. And we'll have our C-arm back in, please. Which side do I attach this one to? Here? So it moves anterior. This one, right?
Whichever.
Hold on. Okay. Okay, so let's get a shot here. Okay, so I'm gonna just move my retractor slightly caudally and slightly posteriorly, and let's get a shot there. And let's angle, and shot there. And shot there. Okay, great. So I'm gonna now take these out. Let me have you pull out slightly, please. Oh, you're gonna take these dilators for me. Yeah, let's do that. Why don't you get, some light for me, please? In here?
A little bit higher. On top of this. Yep, just like that. The pressure fits right in there. Perfect.
Okay, and we'll need some lights. These are out. Yeah. Facing me, the picture? Facing out. Okay.
For those of you who don't know, Zach just attached a camera to the retractor. Maybe Zach, you want to talk about that? It's an additional camera that's actually attached, so you can look down the tube. And we now use it. It's an amazing teaching tool. I just love it. And just goes on the retractor, doesn't come on your way, and you start seeing inside the tube now and right down the channel.
Cool. Okay, let's see. Do we have a good visual for you folks yet? No, it doesn't look like it. Is this a focus adjustment here, or?
It looks like there's no light down the tube. Is the light on?
The light is on. Can I get a sucker, please? Okay. Do we have a smaller sucker by any chance? Okay, there you go. All right.
It's focused on the camera. You want to focus that? Yeah.
Yeah, do I just turn this?
Yeah, blue one.
Let's see. How do we get?
Yeah, you're getting the blue. The blue. Keep going. There you go. Up.
Is this camera not aimed?
Yeah, it's not looking. There's a small little knob on that, Zach. The blue.
No, yeah, I see it.
Yeah, turn that and you adjust the camera.
Let's see. I'd like to get you guys.
I think you need I don't know if you can hear me, I think you need a hex key to move the camera, because right now it's just focus.
There's a hex key that goes into that small little blue hole on the camera.
Yeah, because I'm staring at disc, but I don't think this camera's aimed.
The camera's looking back, that's all.
Yeah, I think we're looking at the blades. Is there a button that will, or a screwdriver that can move this? Let me see. Maybe I can move the angle. It is nice to see down here what I'm looking at. Shoot. Do we have any?
Is anyone from Vision here?
Yeah, it's a Vision camera.
Yeah, anyone here? Like Martin said, there's a small key.
Let's see if I can just Can I point it? All right, so that's where we want to be. And it's designed to go in these holes. You know, it's not aimed right. That's the problem. Shoot. Well, that's where it needs to be aimed.
Maybe try turning it around. Yeah.
Where do I put it? Nah, that takes up the whole operative field. Well, will this look down? This camera look down? You know, I'd love for you guys to see down here, but it's not really totally critical for the demonstration. So maybe we'll just keep moving for the sake of time here. Yeah, pull that out. Unfortunately, we couldn't get that to focus where we wanted it to. Okay, so come back in and take another shot for me here. So I've just pushed this retractor in. That's not bad at all right there. Oh, okay. I guess we're gonna block it with that. Just give me one more shot there. Okay, so this retractor position is pretty good. I would say, if anything, I'd like to tilt it a little more anteriorly, which I'm able to do. Can I take a shim, please? So this is a rigid intradiscal shim. This will affix us to the spine. I am staring directly at disc. Another thing I'll do is I will stim before you shim, kids. I will stim and make sure that I'm not, eliciting some major nerve response right before I drop this shim in. Again, under direct visualization. Mallet, please. Okay, let's go ahead and get an AP and then a lateral view. I do like to check that this shim is where I think it is. So there we go, and get me a lateral, please. This is a large disc space, and so it's pretty likely that we're gonna have put this right in the disc. I think on a very collapsed disc, it's worth taking your time, and potentially also an AP fluoroscopy to make sure you're right in where you think you are. And so this is fine. This is in the disc space, and we're okay to proceed from here. So let's go back. Well, actually, you can just stay. I'm going to take a couple clicks here now and basically expose my field. I'm going to have you take one more shot just so I know where the anterior bound of my retractor is. So go to the other view, sorry. This is not an extremely high iliac crest. I'm up against it, but I'm really not working at much of an angle at all. Yeah, so I could even probably open anteriorly one more click here. Maybe two. Shot there, please. And shot. Okay, great. Let's go to the other view, please. So I've got a nicely exposed disc here. I don't know if the camera can catch that. And I do like to leave this wire in as a fixed reference point until I'm ready to start the annulotomy. So I'm going to take the wire out now. May I have a knife, please? Great. And so we'll make a cut or annulotomy in the disc space here. Is this knife, oh, not out. So there basically are two types of discectomies you're gonna do. One being the most common is a very collapsed disc. And really your job is just to distract it without breaking the end plates. This is a little more rare where you're doing a discectomy where there's actually a good amount of disc in the disc space. And so I will go ahead and just pass this knife through, cutting through the disc space, and then I'll go onto a cob here. The small cob, great. So we'll use the cob to, mallet, please. Shot. We use the cob, and we can see I just need to move a little bit lower, actually. And shot there. And shot. So we'll use the cob to shot there. Migrate along this disc space. Shot. Shot. And so it's important when you're doing trans-psoas surgery to break the contralateral annulus pretty much on every pass of every instrument. What you don't want to do is plunge recklessly, damage structures on the other side. You can actually hurt the other plexus by getting in too far. So what I like to do is a controlled grip where I know my hand's going to hit the patient if I'm through by more than a centimeter or so. And I will just pop through. You can feel that annulus break. Give it a nice little twist. You should feel the disc space release a little bit. So I'll come through there. You can do a pass on the other end plate too, shot. You can do a pass there, shot there. On the other end plate too, that's not imperative. It looks like my retractor is moving a little bit. I'm typically putting 2 shims in, so I'm pretty locked in. So I'm just paying attention to that. May I see the knife again? So the name of the game is getting into the disc space without breaking the end plates. So that's what we're trying to do here. And so I'm really reaching under and getting down to that 5 end plate with my knife. And I'll see the cob again one more time. Shot here. Good, and have a nice tactile feedback on that 5 end plate that I'm indeed denuding the end plate. Shot here. And shot here. Shot there. And I can feel a nice rebound of that annulus on the contralateral side. So again, just kind of a controlled breakthrough, a little release there. So let's move on to the box cutter. The box cutter is a 4 box cutter we'll start with. It's a really effective tool at removing disc especially in disc spaces where it's not extremely collapsed. So shot there, please. So shot there. I'm starting with a small box cutter, and then we'll go to a 6. I think a mistake people make when they start doing discectomies is there's a little too much picking going on, and you really want to try to remove this material efficiently. So box cutter is a good way for that. Shot here. Shot. Okay, that's just kind of stuck on there. Great. Pituitary, please, and the box cutter. Sometimes it'll pull out a nice little piece of sashimi for you. Sometimes it'll leave some loose pieces. So I'm just working on removing those loose pieces. And let's take an 8 box cutter, actually. Mallet here. Shot. Shot there. Shot. Okay. Whoop. All right, that's not attached. It's really tightly. So let's now go ahead and see the pituitary and then a trial. Why don't we look at that expandable one that you had? That was pretty cool. So that's 7 hand passed in there. This is a tall disc space. And so we're gonna end up, take a shot here, please. And shot here. We're gonna use an expandable trial here. I think the important thing is expandable cages are cool. They're a little newer, but they're no substitute for good carpentry. I think you're gonna use an expandable cage really to hold the disc release you've done. you can't expect the cage to create more disc release for you. So if you want to get the full pop or expansion of that cage, you're going to have to trial line to line to the expanded version or size that you want. Let's get a shot here. Let's get a lateral view and see what this trial actually looks like. Does this, okay. That's fine. We don't need it. Just if you can just shoot a lateral here. I just want to make sure that we're in, what looks like an appropriate position in the disc space. You can see the quality of our AP X-rays has eroded a little bit. There might be a small amount of rotation, not a ton. Oh, cool. Okay. So there's our trial. I think this is in a pretty good position, folks, meaning that it's anterior in the disc space. In terms of the size, I think things look pretty appropriate here. So what are we actually expanded to? Is this 12? Is that the anterior height is 12? What, do we know the posterior height? Okay, anterior is 12. Okay. So why don't you pull out for a second? I'm gonna pull this out. So you want to try and look in the camera now?
Yeah, let's take a look.
Yeah, let's look. So
Here, we'll adjust it.
yeah, if you could move it. Okay, good. So that's our blade. Let's see if we can look a little anterior and then get the focus. Yeah, is this the focus, the blue? Okay, hey, there we go, folks. Are you able to get a clear picture there of our discectomy channel? Yeah, well, let's see, those lights are a little bright.
Lights down to like maybe 80 or something.
There we go. All right. Can you guys see that cavity there? Can I see it, the push-pull?
Yes, we can see it.
Okay, great. So, now we'll have the team assembling the cage on the back table. Let's do that 20 degree and try to expand it maximally. It's a little hard for me to tell the exact amount of trialing we've done here, but as a general principle, if an expandable cage gets you to 15 degrees and 9 posterior height, you'll want to do a 9 trial if you're going to get it all the way. If you're okay with it not expanding all the way, you don't have to trial line to line, but it would be my preference to trial line to line to know that you're going to safely get what you hoped for. So we'll go ahead and push this cage in now. These tabs are actually a little extra. Okay. Mallet, please. I'm just hugging my posterior shim as I put this cage in. Can we go ahead, please, to the AP view again? So Anthony, you're gonna push in and rotate your C-arm. We'll get a shot there. This shot is more to determine length, but we're gonna take the length that we have available to us here. So we're starting to abut the, and a shot there. Okay, so this is the length we're gonna get. We're now gonna expand. Most expandable devices have an expansion mechanism like this. And this will torque out for us. So let's get a shot there, please. So we're watching things expand. Go ahead. And this is a big disc, so we might get some expansion here. Shot here. And this is a feel thing. You gotta be careful. If the patient has bad bone, you don't wanna be cranking right through the end plate. That being said, by virtue of spanning the epiphyseal ring, these implants really do have a lot of resistance to subsidence. Shot here. So we're expanding. Geez. This is kind of a lot of expansion. I'd be getting a little uncomfortable with this much expansion in a live patient, but shot here. So let's go ahead and, this pops all the way to 20, huh? Okay, so now I'm getting some resistance, and we'll torque out. So let's take a look. How does this detach? Gold counterclockwise? Yep. Sweet. So let's go ahead now and get in the lateral view, please. Okay, and let's pull out the retractor just so can you pull away, please? So, you know, on these expandable cages, I do have some concerns about the surface biology. So I typically will off-label BMP in these. I've got some good follow-up on these, and they do fuse. That was a worry of mine, but they've all fused that I've seen so far. I do backfill with a little bit of flowable DBM. I think it acts like a mortar to reduce pressure on the surface areas there. Do we have the camera in here? You guys can see the cage in there?
Yeah, Zach, we can. Zach, that's actually beautiful. I mean, really well done, and it's always hard on a cadaver to show everything you need to show, and yeah, I think you did a great job.
Okay, so
Because Nima has got another one following on the nuances of lateral approach, and maybe when he does his, both of you together can answer all the questions, and we can just discuss our lateral approach again, right? So
Sounds
I
good.
want to get, you finish what you're doing, that looks really good.
Yeah, we'll just get
Is-
one final lateral and see how we did
Sure.
on the lordosis and stuff, and
Is Luke here?
we'll get out of there.
You want to come up and key yourself for your talk? Well, Luke's got to talk on does a psoas shrink after lateral procedure.
Will you take a AP here?
Catch up on time
Or
here.
a lateral right here, lateral right here. Yeah. Okay, so yeah, that's it. That's an expandable lateral. It's really effective for these mobile degen spondies. Let's get a shot that's just kind of right in line with the disc space. I think you're gonna, let me see your, let me see your, unlock your WAG a little bit. Other way, sorry, your cant. And a shot there, please. Yeah, so you can see we're not violating the end plates. We had a pretty severe, significant restoration of height, reduction of the spondy, so it's a good case for an expandable.
Looks fantastic, Zach. Thank you.
Thank you.
All right.
Thank you. All right.
Luke, go ahead.
All right. Yeah, thanks for having me, guys. My name is Luke Jopi. I'm a research intern here at the Seattle Science Foundation. I do have a pretty significant disclosure to make in that I've never done lateral surgery on a live patient because I'm not a surgeon. I'm still applying to medical school, but I've been very fortunate to work under Dr. Chapman, Dr. Skuian here, and look at some of their cases. So I'm going to tell you about one of our studies here. Now, you guys are the forefathers of the lateral approach, so we certainly don't need me to talk about the anatomy of it. But what I'd like for us to draw attention to is on the left here. This is a model from one of our previous fellows, Dr. Pericles Godolius, and it's really just showing how tightly associated the lumbar plexus is with the psoas muscle. So we've also seen well-reported, transient weakness, transient numbness, especially on the surgical side, after the trans-psoas approach. So what we were wondering is, in the long term, is there any sort of, changes in psoas morphology, any sort of lasting plexopathy, weakness, numbness? So in terms of the study design, we looked at all lateral patients from our institution from 2016 to 2024. We're comparing the surgery side versus the non-surgery side on MRI. And we're looking at, cross-sectional area, functional cross-sectional area, fatty infiltration, as well as clinical symptoms of weakness or numbness after surgery. We excluded any patients who would have any sort of, inflation or deflation of their psoas. So anyone who didn't have sufficient MRI follow-up, any excessive deformity, spinal cord injury, tumors, trauma, or infection. In terms of our patient breakdown here, we can see that on the right, the flow chart. We did actually have a significant exclusion. So if you note, almost 80% of patients were excluded from our initial finding because they didn't have images. So only patients who were symptomatic were actually imaged after surgery with MRI, which is pretty significant, and we're going to touch on that later. But we did have a final sample of about 108 patients for us to look at, and we measured both at the standardized level, which is the L4 upper end plate, as well as the target disc space of surgery. In terms of initial findings, there was a lot of variability. On the left here, you could see a patient, this was a gentleman in his early 60s, presented with debilitating bilateral leg pain, worse on the left than on the right. So he ended up receiving an L3, 4, and 4, 5 interbodies, as well as a posterior 3 to S1 fixation. He ended up developing severe recurrent weakness and pain in the right thigh. And 4 months later, you could see these secondary images. He ended up having to get a revision. He had herniated at L2. He ended up losing about 33% of the psoas cross-sectional area on the right side, so the side of approach, and about 10% on the non-surgical side. Compare that to the gentleman on the right here, also in his early 60s, did very well. It was just a 1-2 and no posterior fixation. He actually gained about 20% on the surgery side on the right and about 25% on the non-surgery side. So we see a lot of variation in terms of time course as well as how patients do. Average patient was about 67 in this cohort, about 3-year follow-up and relatively equally matched in terms of sex. So in terms of a histogram of how patients actually do, we don't see any significant skewing. On average, it was about 6% decrease specific to the surgery side. No significant changes really in the ipsilateral side. What I'd like to point out with these two graphs here to the right, highlighted in red here is the ipsilateral side, so on the surgery side. It's very variable, so it's hard to predict whether patients are going to have a great gain or a great loss after surgery, whereas on the contralateral side, it's much more predictable around the line of best fit. The question then becomes, how do you predict it, right? Like, what was the ipsilateral side? And we found that the only significant risk factor, at least in our cohort, was 2-level fusions. Surprisingly, surgeon laterality of the approach, location of the surgery, length of stay, and operative time didn't have any impact on whether the patient gained or lost. So that kind of suggests to me that patient lifestyle factors might play a bigger role than the actual operation itself. Here's some statistics on clinical changes. So you can see most patients had no change. The key takeaway here is that there was no side-specific changes in clinical outcomes for weakness or numbness. There was a bilateral, very, very minor decrease in terms of strength. So about 10% of a grade on the Oxford scale, 0 to 5, on both sides, and no statistically significant sensory changes. So what are the takeaways from this? Decreases in psoas size, about 6% on average specific to the surgical side. There was decreases in psoas quality, so on average it raised about 1%, which was a relative increase that was pretty high. But we see minimal clinical changes, so there was no side-specific changes in terms of clinical outcome, and a very, very minor decrease in terms of strength, again, like 10% of a grade, so very minor. Does it matter? I would say when we're thinking back to our cohort, when we had all those patients who were excluded, who didn't have symptoms, who didn't have images, we're thinking that these patients are going to be, much more severe in terms of their recovery. They're going to have a more difficult, time in terms of symptoms, in terms of like psoas morphology, and yet we still see hardly any sort of, significant findings for that. To me, that kind of reinforces the minimally invasive nature of the procedure. Even in the symptomatic cohort, we don't see significant changes. In terms of what that means for our patients, if patients are nervous, if they're anxious about a transpsoas procedure, how that's going to affect the psoas or the lumbar plexus, this data, we can kind of reassure them, even though there's a very slight decrease in psoas size, we're not expecting to see any significant clinical changes that would affect functional quality of life. We talked about a lot of the limitations. It's always great to take this with a grain of salt. We do have a significant sampling bias. We have a staged approach for many of these cases. We do have a large population of surgeons, so we have a large population of techniques, which makes it difficult to associate statistical power with surgeon, and of course, neurological examination. Now, finally, the last and most important point of this presentation is a lesson from Dr. Escuian. He always says to surround yourself with people who are smarter than you. And I feel very, very fortunate to be here at SSF and to be able to do just that. So huge thank you to everybody on this slide and many folks who I didn't have photos of for everything. My mom has had chronic back pain ever since I could remember, crippling radiculopathy. And so being able to be up here and kind of, give back to this community is really exciting, and it's really an honor for me. Thank you.
Look, thank you. It was a really good paper and very interesting, but I got lots of questions. And I don't know who's going to answer now. One, I mean, I like the premise of the study and what you're trying to say. How do you explain contralateral changes? That is one, right? Why would you gain muscle mass? That is two. And three is, were you able to correlate any of the clinical symptoms to any change in the Psoas? Or they purely random? Like somebody had a clinical change and somebody else had a Psoas change. Is there any correlation there?
These are all really great questions. Our discussion section in our writing lab was definitely fraught with a lot of back and forth on why we see contralateral changes. Our main kind of running hypothesis is that if you're having a successful LLIF, if you're correcting a lot of these symptoms of, deformity, any sort of pain, maybe a patient's restored to a more active lifestyle afterwards, and that would contribute to, an increased sort of like muscle mass on the contralateral side. Whereas, the variation caused from the disruption of the trans-Psoas approach, maybe that affects the ipsilateral side a bit more. So that was kind of our main running hypothesis for the contralateral side there, yeah.
What if I throw something at you? Do you think it could be a variability in the measurement, an error in measurement as you get in? These are hard to measure. You're looking at 6% change in cross-sectional area.
It definitely, this is something that I tried to be really careful about. With any measurement, I took it about like 2 or 3 times, and every time it was reliable within itself, within like 2 or 3% of each reading. So it was, very accurate, at least to the best of my ability. But yeah, it was definitely perplexing our findings a little bit.
So let me just thank Luke for, first of all, congratulations on a nice presentation for your first time in front of a surgeon's audience. Congratulations, right here, interruption, applause. And your humility is awesome. Let me just give the faculty here a little premise. This emerged out of a negative hypothesis bias of the speaking person here, of myself. I was sure that we would find that the psoas gets maimed. And I was pleasantly surprised on repeat viewings, and we did some independent measurements also to be sure that these are pretty consistent. We've actually done a previous paper that I think is now out on a slightly different subject. So the psoas is probably one of the best ways currently to assess functionality status and sarcopenia of patients. It's reasonably well validated. So I was pleasantly surprised how the psoas has a bounce back capability. It actually does show and reflect activity level of patients. So surgeon's trauma is less bad than what I suspected. So my null hypothesis was basically confirmed. This is an erroneous assumption on my part. There's some functional limitation, but it's not as bad as I thought and can be compensated functionally, to address your point. So in a way, I think this should validate that if done properly, like what Dr. Pham so nicely pointed out, and all your hard work has shown and evolved into, this is actually a reasonably forgiving interval. So just wanted to point out the context.
Oh, wait, no, thank you.
Oh, here comes Dr. Pimenta.
Yeah, so I'm sorry that I was changing myself. I didn't see, but I imagine your conclusion that the psoas, as you manipulate the psoas, you can see that the psoas shrinks in volume. We did a long time ago, more than 15 years ago, a study on the function of the psoas muscle with dynamometers. And we found that around 75% of the cases, the function of the psoas where the psoas was worked, reduced. And that's why we really, at that time, pushed for physiotherapy after the procedure to make the psoas restore the function. I think it's important to know, and this is related also to how long, how difficult the case was, how many levels you do through the psoas, so it's all things that matters, right?
Yeah, I think that's a really great point, going back to, combining that between what you said and what Dr. Chapman said about like psoas as predictor for patient activity and for patient quality of life.
Yeah, another point is that the psoas, as we know, is much more volumetric at 4-5 than in other levels. So you should expect more problems when you use more aggressive 4-5 techniques.
Yeah, that's a great point. Thanks, Dr. Pimenta.
All right, I think we're going to move on to another lab. Nima, can you hear us there in the lab? Then come up to the podium. You're not escaping. You're not escaping that easy. And that's fair. We kind of seen the same lab that Zach did. So maybe, I don't know, Nima can take the stage and maybe talk about maybe some nuances of lateral that you sort of encountered or faced, and we can just have an open discussion for 10 minutes or maybe on
Sure,
the
so Dr. Uribe said that,
fine nuances. Good, good.
what's that?
Now we'll do 10 minutes of this, it'll be good.
Yeah, we could do 10 minutes. Maybe we can do like a Q&A or something.
You know, why don't you tell us, I mean, what you had, some small nuances that you had to do to make your life better in lateral surgery? What have you found? What have you done?
Great point. Okay, so let's start with the L45, which is actually a great job. You canceled my lab. Well done. You were so good.
The same lab, you did a great job.
There's nothing left to do. But anyway, but I think with the crest, that crest that you showed, Zach, that was a favorable crest. I think that's one of the challenges of L45. How do you navigate with the crest? I think, again, it's not CME, the two-blade retractor has really helped me because of two things. One is with the three-blade, if you hug in the crest and you open, no matter what you do, you're going to push against the crest. You push against the crest, it pushes you up. With two-blade retractor, once you land on the disc, you open along the disc. You are not dealing with the crest. And if you are, let's say you're using a three-blade retractor, what you could do is you have your shim in the posterior blade, you don't deploy it. And then you check an AP, you mallet it in. Once you're in the disc, you use it as a pivoting point, and then you can push against the crest a little bit to neutralize it so you maintain your orthogonality. I think the nuance is all about how do you maintain orthogonal angle to the disc? How do you navigate or map the plexus? And then you have to have some sort of a workflow to minimize your retraction time. Go ahead, Dr. Taylor.
I would actually go back to like at your skin incision, and I would go back to the dissection, because I find a lot of people that get down to 4-5, I dissect right down on top of the iliac crest.
Yes,
Actually,
I hug, I use the bow to release those
That's
muscles.
exactly what I do too.
The skin mark tells you where the disc is, but I hug the pelvis. You don't want to be short of that. But so that's one of the things I would say, the maintaining orthogonality, and then mapping the plexus. I think, again, Zach mentioned this. You want to get to the point that you are low numbers in the back, high numbers in the front. I also don't think the exact numbers matter. You're looking for the gradient. I think the specific number, it's just an internal reference for how that patient is simulating. And I don't have a magic number. I would say maybe like a 5 milliamp difference is safe, but it has to be low number posteriorly. So your lumbar plexus is behind you. You don't want to retract it anteriorly.
Can I add on the two-blade retractor?
Of course, yes.
I think it's really favorable to dock in the anterior blade on the
Yes.
front of the disc space. You're much
Bring it
less
posterior.
likely to have plexus issues that way.
And if you, I'm going to add to that a little bit more. So if I don't get a good numbers in L45, again, with the two-blade, even a three-blade, the idea is to go more and more anterior and maybe a little bit higher, because the nerve has a curve that the safest area would be to go in front and top, and then bring it obliquely down to center on the disc. With a two-blade retractor, you can also walk it back. I've done this before. That you go anterior and then you walk this back, and then you put your shim in.
Now, Nima, is it prone lateral or direct lateral, or does it matter? It's the same thing.
I think it could go for both.
I mean, would you
use a two-blade
change
retractor
what
for
you
every-
do if it's prone lateral as opposed to direct lateral?
Do I change what I do?
In terms of placing the retractor?
No,
It's the same thing. It's eventually the same thing, ultimately.
yeah.
What about pre-op? I mean, what can you tell everyone? Pre-op, how do you decide it's going to be a problem or not? Luis sort of talked about a little bit about the blood supply. You look at this vasculature. You
Is
look
it
at
a
what do you
problem in
do?
terms of L4-5?
Well, I'll tell you
or-
why. Well, in the past, we had made such a big fuss about the crest and the height of the crest and all that stuff. I don't know. Is that still valid? Do you guys look at that? What do you look at pre-op? For everyone
Honestly,
knows?
this sounds strange. I don't even look at the crest anymore. With two-blade retractor, I don't think it matters. The other thing about two-blade retractor is good is you have a flexible cone that you work through. With a three-blade, you essentially have a rigid cylinder. You have to, you're obliged to go between those three blades. With the two-blade, you can go at an angle. So that's actually your angled instrument. I've never used an angled instrument with a two-blade. What do you guys think, Dr. Taylor?
Rarely.
Rarely, very rarely.
We don't need to use, even. if
Because
it's
your instrument can
angled,
come at
you
an
go
angle.
Between the blades, so you can go.
Exactly, that's what I
side.
mean, it's, you have a flexible working zone as opposed to this rigid.
There's a limit where you will hit the bar, but
Fair.
it's.
But I think one of the
it's
greatest changes that I've seen in whatever 23, 24 years we've been doing, we really have, like you said, moved away from the crest and why the crest is that. And you're right, it actually is immaterial. It does come back to the vascular anatomy. It pretty much
Yes, sir, yeah.
dictates where that crest is. And you look at the MRI and vascular anatomy, you can pretty much predict it's going to happen or not happen. And then, like you said, you use these tricks to get away from it.
Yes.
But you plan before. Otherwise,
Yes.
you shouldn't be getting into a case and get stuck in the middle and then say the crest is in my way. That should have been pre-op planned. I think that's a message, I guess, I would like to say. Shouldn't get in there and get stuck.
I think as Dr. Taylor mentioned this, is like each level is different. You can apply the L3-4 is probably the easiest one. You can't apply the L3-4 concepts to L4-5. L4-5 is obviously the hardest one because of the crest, because of the nerve and all that. But that's kind of what I wanted to discuss. Some of those things you can't really show in a cadaver. You can't show mapping in a cadaver.
But in terms of shim now, like Zach talked about anterior docking, I think you said posterior docking. Does it
So with
matter?
two-blade-
What do you do?
With a two-blade, I think you have an option to go anterior. That will save you. That's the idea of stim before shim. If you go anterior, I don't even think you need to stim before you shim because there's no way the nerve will be there. Obviously, assuming that you mapped it correctly.
Can you use both shims on both sides? I almost always use anterior and usually use two. If the channels of my discectomy is not big enough for a 22 cage, I'll pull one of them right before I insert. But usually I just work between them.
You actually don't even need to pull the retractor to make it bigger, you just expand it and it'll open up enough. So you only need an 18 opening to put a 22 cage in. So just stick with an 18 and everything for the most part, and then the last thing you do is open it up a couple of clicks and you get a 22 cage in.
You know what I'm saying? I had two shims in, and so the cage literally couldn't fit between the shims, so I would just pull out the shim only.
Oh, I see.
Yes.
Just to make enough room in
It'll-
there.
if you
Yeah.
Because I don't want to blow it apart.
Yeah, but if you open it up a little bit, it'll expand just enough to put the cage in.
But again, this
With
is,
the prone, Martin, with the prone, I put two shims in because I need the stability. I actually put two stiff shims sometimes if I really want it to be stay.
Always two stiff shims at 4-5.
Because of the prone, yeah, with the prone position, gravity, at that stage of the surgery, gravity working against you. So you want the stabilization.
And you're at an angle, it's a little precarious, you're trying to move quickly.
Exactly.
but again,
You want the
this is,
stability.
I just want everyone to understand, what we're discussing is specific to a specific procedure.
You're right,
Because
yes.
there's a lot of laterals also done with two-blade retractor that goes superior, inferior.
Correct.
Rather than expanding along the disc. So you can expand along the disc, which is what you're describing, which is fine, or you can expand, on the vertebral body up and down, which is another way of doing it, right?
Correct.
And there's no shim used in that. I know people use pins to dock on the body, and I've gone away from that, but I don't know if people still do that because you don't want that pin in the vertebral body to hold the blade down. I've seen someone get the segmental with that. So it's sort of, I've gone away. So there's so many nuances, I think, we sort of learned over time to get over there, right? I think the third is opening the blades too. At least when you go body to body, don't open a whole lot. I've seen people open the whole blade all the way out. That's how you get your segmental. just see the disc. So I like the disc expansion.
Yeah, along the.
Just see the disc, you don't need to see anything else. That's all you need to see. So there's the small things, I guess. If you want it, open the incision. Stop struggling through a small incision, not a big deal. Sometimes skin's in the way, open it up. What else, guys? I don't know, that's become such a common procedure now. I think it's become bread and butter for everybody. What about young guys? Anyone have questions on the technique? You'd like to know, you're stuck somewhere? You'd like to know something? You guys should be asking.
I kind of, I brought this question up to Dr. Pimenta just in passing last evening, but, we often talk about the retractors, using shims to make sure the retractors aren't drifting, getting the stiffest kind of construct to hold the retractor. But now, what are your guys' utilization of robotics to hold the retractor? And I haven't seen it yet myself, but the new kind of pneumatic arms, things like that. What are your thoughts on that, since that seems to be a big part of keeping this procedure safe?
So I can tell you the pneumatic arm, because I've used that, I think, pretty much more than anyone. And it actually works really well. The problem is you need two hands to work it, because you depress it, and it's not like you can open up, move it, and then tighten it. So you have to move it and depress it, and it sags just a little bit after you use it. But once it's in position, it holds really well. So I actually do really like the pneumatic arm. I would tell you, I've tried to use the robot back and forth. I would tell you that if you want to pass the first dilator, it's a long pass with the robot. And then the second thing is you really need a separate fascial incision, because you're not going to be able, you have to put the actuator right down on top of the skin. And so you have to have a separate fascial incision to at least put your finger on the first dilator to make sure you know where you're at. So I would pinpoint a spot with a robot and go to it. But the reality is, I think that navigation in that case is going to be better. And the last step is people talk about navigating the retractor, but the key thing is not navigating the retractor, it's navigating the two shims that you put in, and that's why two shims are going to become even more important when you're navigating. So you navigate the shims that are in there, and that tells you where you're at, which I think is going to be the critical piece, not the retractor.
Is there an option in the industry that you can navigate the shim? Not yet.
Not at the moment. Next year.
I'm wondering.
Next year.
That's what I figured.
Navigating the sim. Okay.
Sounds like you're predicting the future, Dr. Taylor.
To your comment about the robot holding the retractor, I don't necessarily do that. In OLIF, you don't really hold it there. But I have asked, because there are some robotic systems that hold the retractor. Those robotic systems are ground mounted. So the concerns because I've asked that same question, the concerns that were answered to me is that oftentimes you may want to rotate the bed. So if you tell anesthesia, hey, can you rotate the bed a little bit, and you forget, then that's the issues. And so the people that I've talked to them move away from that, even though it's a nice, rigid system. But at least with pneumatic arm, it's attached to the bed.
So it's attached to the bed, which is really nice. And if you look back, DePuy actually made, remember their robot arm that they had that nobody used like 10 years ago? It was actually really good. It was just a rigid instrument holder that you would put in place, much like a pneumatic arm. And I do think that's really critical. And the pneumatic arm works really well. You can adjust it wherever you want. And then, but the reality is you want to work orthogonally, but initially, you're sort of going to be usually at an angle, especially when you're talking about 4-5. So you're at an angle to start, everything gets put in, and then you want to translate it up to 90 degrees. And that's really navigation that tells you that. But you can easily do that with a pneumatic arm.
Yeah, and the arm is another way to make it as rigid as possible, because we use retractor, two-blade retractor in a single piece because it's lighter. It's not only because it's nicer to go from anterior to posterior, it's lighter. You saw you struggling with this big, heavy retractor with an arm that is long, so it's much easier to move with gravity with a three-blade retractor. We learned this early on, so choosing, two-blade retractor, lighter, fixing with two shims, and adding a very strong arm, mechanical arm, automatic arm, that is a plus to the rigidity and better for navigation.
Yeah, the critical thing too was shortening the length of the arm or retractor, because everyone makes it long because they want it to reach over the table, the top. But that's why someone asked earlier, where do you put the arm? So I put that one on ipsilateral just below, and the arm, if you notice, with the prone system is really short. And that helps with the rigidity more than anything else because it lessens the lever arm.
All right, guys, we have some lunch? Anyone's getting hungry?
Beautiful.
Lunch break,
Excellent.
let's go. We're back here at
this lunchtime? Yeah.
12:35? All right, thank you.
In 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future. If you want to have CME credits, please do it through the all-access pass. So coming 2025, please keep tuning in. Free content, high quality, always available, but please use the All Access Pass if you need to claim CME credits. Thank you so much.
Hello, I'm Dr. Sakib Hassan, and I'm at the Seattle Science Foundation for the 3rd Annual SSF Endoscopic Spine Surgery Symposium. This is the first multi-institutional didactic symposium in the United States that focuses exclusively on endoscopic spine surgery. This course is a comprehensive instructional series that delves into the intricacies of endoscopic spine surgery. Through advanced didactic lectures and cadaveric demonstrations, our all-star faculty will expose attendees to the cutting edge, the latest techniques and technology. We'll cover the indications, optimal surgical corridors, and operative pearls, as well as the benchmarks and functional outcomes following full endoscopic spine surgeries. You'll then get to put what you learned into practice in the state-of-the-art SSF BioSkills Lab with unprecedented hands-on learning. Due to the very hands-on nature of this course, spots are extremely limited, so please sign up today. We look forward to seeing you in Seattle on July 25th and 26th.
Good morning, I'm Jens Chapman. I'm here at the beautiful Seattle Science Foundation facilities. Today I'm thrilled to announce to you a new program that we have. It's called the Seattle Science Foundation VIP Platinum Experience. This exclusive package is designed to take your participation to the next level. It includes your course registration, 2 nights hotel stay at a nice local facility, ground transportation to and from course activities. Furthermore, as a Platinum Experience participant, you'll gain unprecedented access to a world-class faculty and take part in exciting networking opportunities. You'll join us at the faculty dinner, a unique chance to connect in an intimate setting and even assist in a live surgical cadaver demonstration during the course. To top it off, we'll feature in our ssfyoutube.org videos and our social media channels and showcase your expertise and commitment to advancing medical education. So don't just attend an SSF course, immerse yourself in the full experience. Elevate your journey directly by signing up for the SSF VIP Platinum Experience today. I look forward to seeing you at a future faculty dinner here at SSF. Hi, I'm Jens Chapman, and welcome to the Seattle Science Foundation We thank you for your interest over the past years in our regular programming, and we will continue to look forward to a great new 2025 program series. As always, we pride ourselves in offering free and widely available high-quality content, and I'm, as a spine surgeon, always very intrigued in learning from this. Coming in 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future. If you want to have CME credits, please do it through the all-access pass. So coming 2025, please keep tuning in. Free content, high quality, always available. But please use the all-access pass if you need to claim CME credits. Thank you so much.
Hello, I'm Dr. Sakib Hassan, and I'm at the Seattle Science Foundation for the third annual SSF Endoscopic Spine Surgery Symposium. This is the first multi-institutional didactic symposium in the United States that focuses exclusively on endoscopic spine surgery. This course is a comprehensive instructional series that delves into the intricacies of endoscopic spine surgery. Through advanced didactic lectures and cadaveric demonstrations, our all-star faculty will expose attendees to the cutting edge, the latest techniques and technology. We'll cover the indications, optimal surgical corridors, and operative pearls, as well as the benchmarks and functional outcomes following full endoscopic spine surgeries. You'll then get to put what you learned into practice in the state-of-the-art SSF BioSkills Lab with unprecedented hands-on learning. Due to the very hands-on nature of this course, spots are extremely limited, so please sign up today. We look forward to seeing you in Seattle on July 25th and 26th.
Good morning, I'm Jens Chapman. I'm here at the beautiful Seattle Science Foundation facilities. Today I'm thrilled to announce to you a new program that we have. It's called the Seattle Science Foundation VIP Platinum Experience. This exclusive package is designed to take your participation to the next level. It includes your course registration, 2 nights hotel stay at a nice local facility, ground transportation to and from course activities. Furthermore, as a Platinum Experience participant, you'll gain unprecedented access to a world-class faculty and take part in exciting networking opportunities. You'll join us at the faculty dinner, a unique chance to connect in an intimate setting and even assist in a live surgical cadaver demonstration during the course. To top it off, we'll feature in our ssfyoutube.org videos and our social media channels and showcase your expertise and commitment to advancing medical education. So don't just attend an SSF course, immerse yourself in the full experience. Elevate your journey directly by signing up for the SSF VIP Platinum Experience today. I look forward to seeing you at a future faculty dinner here at SSF.
Dr. Adnan, my name is Zach Napier. I'm here to talk about sagittal plane optimization in prone trans psoas lateral interbody fusion. First of all, it's just an honor to be here in the presence of lateral surgery legends. I have learned something from basically every faculty member in this room, either in person or through the Seattle Science YouTube videos. Just a little bit about my background and how it shaped my perspective on lateral surgery. Really had pretty limited exposure to lateral decubitus surgery in residency and fellowship before I took a private practice job with Tyler Smith, a prolific lateral surgeon and really a pioneer of prone trans psoas surgery. And so I was very fortunate to have his mentorship early in my career. During my first month in practice, I flew down to Carlsbad and I did a PTP cadaver lab with Dr. Bill Taylor. What a cool guy. I remember he left directly from our lab. He had a surfboard in his car and he went to go surfing. But he really made that surgery seem cool to me. And so, while most faculty here had an extensive experience in the lateral decubitus position before they gradually some transitioned to prone, I'm one of the first of the generation of surgeons who really jumped right into prone trans psoas and prone lateral surgery. I had an opportunity to come here and present on this 2 years ago with Dr. Chapman and Dr. Oskuian. And I've been in practice at Indiana Spine Group in Carmel, Indiana for the last 2 years. Yes, that's Dr. Sasso's group. Thank him for his support as I continue to develop our PTP program. So we're going to discuss sagittal outcomes of lateral interbody fusion in the lateral decubitus, as well as the prone position, touch briefly on sagittal goals of lumbar fusion, and then spend time on techniques to use PTP-LIF to optimize sagittal outcomes. So the key points of my talk are that prone lateral surgery gives us an extra gear of lordosis compared to lateral decubitus. I like to think of a traffic light that's superimposed over the L2 to 5 disc spaces. At L4-5, you want to create as much lordosis as you can. At L3-4, it's actually going to depend on pelvic incidence and spinal shape. And at L2-3 and above, you usually don't want too much lordosis. So we'll talk about cage position and other techniques to dial in our segmental alignment goals. This is the obligatory slide for every lateral talk. All lifts are not created equal. This is a lateral course. We know the lateral is the biggest, baddest inner body. It provides a biologically and mechanically optimized environment for fusion with a wide apophyseal spanning implant. Lateral interbody fusion provides a powerful coronal correction, but really only a modest sagittal correction, unless we do an ACR, which has its own complication profile and may create too much proximal lordosis. Lateral decubitus positioning presents challenges regarding access and lordosis, and thus PTP emerged with distinct advantages. The advantage I will focus on is increased lordosis. As the classic Lanky papers show, careful prone positioning has a profound lordosing effect. Another advantage is increased access to L4-5 and cephalad levels via coronal bending of prone-specific positioners. Segmental lordosis gains have been widely described by many people in this room, with prone positioning resulting in greater increases than lateral decubitus. One paper in particular out of HSS in 2011 demonstrated the importance of cage positioning. This paper looked at 67 levels, all with the same 10-degree cage, and found a huge variation in lordosis creation, with 7.4 degrees with anteriorly placed cages and 1.2 degrees of kyphosis with a posteriorly placed cage. Another interesting paper out of Japan had a similar conclusion that cage location was the most important factor in determining segmental lordosis. The authors presented a diagram and suggested that the way to maximize lordosis was to place the tallest cage possible as anteriorly as possible. They also discussed appropriate cage width and angulation to maximize stability and minimize subsidence without blocking posterior closure of the disc space. Surgical targets for lumbar lordosis have been widely studied since Dubosset's cone of economy in the 1970s. I would like to share a couple of principles that have influenced the way I think about laterals. Pierre Roussely classified the asymptomatic spine into one of 4 and later 5 shapes based on sacral slope, which is related to pelvic incidence. The hallmark of these spinal shapes is an increase in total lordosis as well as an elevation of lordosis apex with increasing pelvic incidence. For most spinal shapes, the apex of lordosis is at the center of the L4 vertebral body or below, with approximately 2/3 of lordosis coming distal to that apex. Roussely presented a geometric equivalence between upper lumbar lordosis and lower thoracic kyphosis, and suggests that an excessive increase in upper lumbar lordosis or an elevation of the physiological apex would result in a reciprocal lower thoracic kyphosis and lead to proximal junctional kyphosis. 2 principles from Roussely that I keep in mind when performing lateral surgery are to maintain appropriate distal or caudal lordosis with approximately 2/3 coming below the apex, and to avoid excessive proximal lordosis, especially in lower PI patients, as this can lead to junctional kyphosis. While much time and energy are spent debating the ways various alignment targets are different, most authors agree that targets must evolve from global to regional to segmental as we become more precise in our reconstructive efforts. Alan Daniels and his group compiled this table from normative publications of mean segmental values in asymptomatic patients. And while there are certainly issues with categorizing continuous variables, this table does give a general reference of about how much segmental lordosis the average patient has based on pelvic incidence. What really stands out to me about this table is that for the broad majority of pelvic incidences, you should be achieving at least 20 degrees of lordosis at 5.1 and 15 at 4.5. The following are techniques for controlling sagittal alignment in prone lateral surgery. By far the most important is cage placement. Anterior cages create lordosis. Anterior docking is a technique that allows the surgeon to safely and reliably place cages anteriorly in the disc space. We will discuss static versus expandable cages, anterior column release, and finally simultaneous or alternate work between the anterior and posterior columns. Anterior docking means fixing the retractor to the anterior aspect of the disc space with a rigid intradiscal shim. Like most things in lateral surgery, this started with Dr. Pimenta. I typically use a 2-bladed retractor that's shown on the left side of the screen. This allows for shim insertion through either or both of the blades, anterior and posterior. The 3-bladed retractor on the right only allows for shim insertion through the posterior blade. So you can see in the bottom picture, the star would be an anterior shim insertion site, an anterior docking. Retractor stability is critical to safe and repeatable prone lateral surgery, as gravity is pulling our retractor anteriorly toward the vessels. Nima said very eloquently that it is a double-edged sword. It gives us lordosis, but it also gives us the challenge of instability to deal with. So it's my preference to use a 2-bladed retractor with shims that are rigidly fixed anteriorly and posteriorly. I'll tell our fellows, once we have our shims established, like that bottom middle picture, it's like bowling with the gutter blockers in. Because when we're doing prone trans-psoas surgery, it can often feel like that skier where you're clinging to the side of a mountainside, and you'd certainly rather have 2 skis than 1. So I published my first 72 cases and 116 levels using this technique of anterior docking. 57% of the cases included L4-5. We found the technique was safe with no major adverse events and effective in terms of significantly increasing segmental lordosis and improving sagittal parameters measured. We also found that the surgery was efficient with a steep initial learning curve. You can picture the OR staff rolling their eyes on the left side of the table as I'm figuring out the workflow. But after 30 cases, that same staff became my NASCAR pit crew.
Now it is very rare for a one-level case with a navigated percutaneous PSF to take more than an hour, including closure. The study sample coincided with my introduction to expandable cages, and I noted that an anteriorly placed expandable cage may facilitate appropriate maximum physiologic expansion of the disc space. So here are some cases. The first one will be an example of anterior docking. This is a classic L4-5 degenerative spondylolisthesis, lower back pain, radiculopathy, claudication. So first thing we do is look at the MRI, and we can see, I wouldn't choose this as your first lateral trans-psoas surgery, but there does appear to be a neurovascular corridor behind the vessels, anterior to the plexus. I try to reformat the MRI to get a shot right down the disc space, and this one I couldn't, so I get one shot below. This is the worst things would ever look. As long as I don't see vessels wrapping around the side of L5 like a 5-1 vascular anatomy, it is approachable through a lateral trans-psoas approach. So in this case, I used the anterior docking technique. The picture on the left is my initial docking attempt. This is mid-anterior vertebral body. I got EMG readings of 2 in all directions. So I knew I wasn't anterior to the lumbar plexus. I did a maneuver where you sweep anterior to the psoas and dock the retractor very anteriorly in the disc space with that bottom picture. And prior to putting in my anterior shim, this is a really important move. On the left, I palpate the disc space with a pen field and I shoot an AP X-ray. If that X-ray were to show that the pen field had migrated across the disc space, that is way too anterior to put in an anterior shim. So once I have a firm endpoint like I did in that picture on the left, I'll place my shims, allowed me to safely place the cage and expand it, complete the reduction with the reduction tabs. You can see an appropriate placement of the cage and a nice restoration of segmental lordosis in a totally percutaneous fashion. So another case here showing just segment-specific interbody cage placement. This is a 67-year-old female. She had a prior laminectomy. She has a kyphotic L4-5 disc space, and small enterosthesis at 3-4, retrolisthesis at 2-3. So in this case, we looked at the MRI cross-sectionally. The neurovascular corridor was amenable at all levels, and we took a level-specific approach here. At L4-5, I chose to do an anterior docking approach here with an expandable cage. And then at L2-3 and L3-4, I placed a static midline 10-degree cages to not create excessive lordosis. And so we were able to see a nice restoration of sagittal contour here. Specifically at L4-5, we took it from either neutral or kyphotic disc space to 15 degrees of segmental lordosis with no posterior work. Again, this is all percutaneous. So what if we need more lordosis? What if we need a lot of lordosis? Can PTP help us with that? So this gentleman, he's a 62-year-old. He had a prior L4 to S1 non-instrumented fusion in the early 90s. He has a stepwise anterolisthesis from L2 to L4. He has a PILL mismatch of 44, very positive SVA. So to approach this case, you can see the posterolateral fusion mass. You can see the very generous iliac crest sampling on the left side of the bottom picture there. You can see as a kyphotic L4 vertebral body and the anterolisthesis as mentioned. So severe stenosis at L3-4 and L2-3. So I approached this in a single stage. I started with PTPs, placed one at 2-3, and then I placed one as well at 3-4. My intent was to use the PTP as a fulcrum for sagittal correction. I did place an anti-migration plate on this cage just in case. And so as we were reducing the PSO, we saw a pretty significant dural buckling and reduction, probably coinciding with an ALL release. So combining the techniques of PSO and PTP with an anterior column release, we're able to obtain a significant focal sagittal correction here. Those are the 7-month views showing no subsidence, maintenance of alignment. He's now a year out, doing quite well. And so, just because we can create more lordosis, does that mean that we should? This was a case a little earlier in my practice.
excited to try out Dr. Anand's fancy going between the ribs technique. And I got really nice lordotic interbodies at L1-2 and L2-3, but in retrospect, with what I know now, this was years ago, this is probably too much proximal lordosis and not a harmonious distribution. Another case here, this patient walked into my clinic with a prior 4-to-1 fusion. He had foot drop, back pain, radiculitis, postural issues. He's a very low PI patient. So really, the apex of his lordosis should be at the L5 vertebral body. In this case, I would resist the temptation to place lordotic interbodies at 2-3 or 3-4. And what I actually did was a front back surgery with a hyperlordotic ALIF to restore an appropriate apex of lordosis. I did place laterals in for indirect decompression and stabilization and fusion at 2-3 and 3-4. But you can see I used a 0-degree cage at L2-3 because I really didn't want to overshoot that proximal lumbar lordosis. That's a type 1 rod bend superimposed. You can see if anything, I could even have used a softer landing proximally there. So other techniques, there's simultaneous or alternate posterior work that you can correct sagittally through. This patient, grade 2 spondy degenerative at L4-5, she had an amenable neurovascular corridor. The issue was we only had 15 millimeters of bony overlap. The smallest cage was 18 millimeters in width. So here we actually did a percutaneous reduction with pedicle screws before cage insertion. So we placed that cage in there and got an appropriate reduction and sagittal correction. And you can see she got a postoperative CT showing a nice indirect reduction here. Last case, this is a patient that had a prior L2-5 fusion. He had a thoracolumbar kyphosis, proximal and distal degeneration. And so the prone Psoas, the PTP approach, it can be applied to the thoracolumbar junction. This is one of Dr. Ribe's many publications on the thoracolumbar junction. I just rotated the picture to suit the prone vantage point. But basically with this patient, I was able to take one rib and access 3 disc spaces to place hyperlordotic implants to address the thoracolumbar kyphosis, put bone graft in actually at the 4th disc space up there as well. So very broad access through taking one rib, placed a hyperlordotic ALIF at 5-1 for an appropriate sagittal correction here. And so my key points again, prone lateral surgery uses gravity to significantly enhance the lordosis we can generate. So use that lordosis wisely. I like to think of that traffic light over the lumbar spine, red light, yellow light, green light, depending on what level you're at. And certainly anterior placed expandable cages can help us maximize lordosis when appropriate to achieve our segmental alignment goals. So thank you, everyone. Welcome questions.
So that case, Zach, that you showed, you had an ACR, you had a lordotic cage, and you had a PSL. You really think you needed all that?
He needed a lot of correction there. I don't know if I could have gotten it any other way.
If you really look at that PSO, you probably didn't need it. I was wondering, but I don't think you got much from that PSO, to be honest. Yeah, ACR looks great.
Yeah, so what happened was as I was reducing the PSO, the ALL gave. And so,
you hadn't done the ACL before.
I didn't do a formal ACL.
Got it. Okay.
I was using it as a fulcrum.
But that I found very useful. I think
once that gave, I said that's enough correction back there. And that 4 did start kyphotic though. So yeah, it's not. Yeah, because I wasn't sure what would happen if I compressed more once the ALL had given, right?
I think to me that's been a big change. I'm sure a lot of people will do it. If I can get an ACR in place of a PSO, I'll do an ACR any day. If it's a better choice, and there's an opportunity to do an ACR is much better than doing a PSL.
So wasn't planning on an ACR there, it was more like a sandwich PSO.
Right. You're lucky they didn't fall out. Oh, you had fixed it, so you're lucky. Oh, that's great.
For the front back case, did you stage it or did you,
I did it, so I did it all at once. And that's a nice thing about PTP is this case we were doing at our at Indiana Spine Hospital, surgeon on with our staff there. So this whole case took 5 hours. If I was going to do that at our community hospital, it would be an all-day thing. And if I wasn't doing PTP, it would be four positions. But really, to add a PTP interbody to a case of this nature it's about 20 minutes of operative time per level. And so it really can't beat the efficiency of that. I think if I had to go to decubitus, I just wouldn't do the laterals.
Do you have an assistant? Like, say, if you're doing the PTP up at 2, 3, or 3, 4, is there someone else with you who's like helping to expose? And is some of that simultaneous in some way, or?
I think that's more of a novelty, or at least I haven't been able to functionally incorporate that. The PTPs are so quick that and the fluoro's in there the whole time, that I just kind of get them done and get out of there. Yeah.
Hey, I would only add, I think that's a good question, Martin. I found the biggest advantage is because when you do a prone, it changes the sequence of how you do surgery. You don't do the lateral first and the interbody, you do the pedicle screws first. So if you're adding a T-lift, especially at 5-1, that's why I usually do the T-lift on one side and the PTP on the other side. So a minimal invasive T-lift with a retractor attached to the pedicle screws, you can send, for us, a resident down and tell them, just drill out all the bone before the pedicle screws while you're doing the other side. So there are advantages. Simultaneous doesn't work all the time, but I think specific parts you can do. That's what I do.
So just with the A-lift first, or?
I actually just took the rods out in the back because I knew it was really important to get all the correction at 5-1. I didn't want to bust the end plates. So I took out the set screws, flipped, put in that's a 24-degree A-lift, and then back to prone, laterals, and then just put in the screws.
All right.
Thanks.
No more questions. We'll get Dr. Chapman up. I think Dr. Uribe already spoke on his lateral corpectomy. So is Dr. Chapman around? Where did Jens go? He was here.
I had a talk on corpectomy, if you want. I think we had enough conversation about corpectomy. In my opinion, we should gain time that we.
Yeah, we should. We get right.
We lost, right?
No, we definitely gain time. I think Dr. Chapman's got a talk on lumbar alignment and intradiscal osteotomy. I know it's his favorite topic. Where is he? Maybe he thought his talk is later. You want to go ahead?
You could go, Dr.
Sure. Boundaries is the one.
What are you talking about? Go for it.
Okay.
Yeah, we're talking prone lateral anyway. You want to go, Bill?
Sure. No, it's just
prone versus lateral, does it really matter? Yeah, it makes sense.
It says boundaries PowerPoint right there, this one.
I was just gonna rename this.
Oh, no worries.
Thank you so much.
Oh, right below that. Right there. Good. Well, I'm happy to step in quickly. This is, I try to keep up with Martin with showing pictures of my children, but so I just want to identify what I was tasked with was identifying barriers to lateral surgery adoption, and outlining enabling technology, and then look at future development and future cases, which I think is a pretty, I may go over some things that people have looked at, but the reality is I think the barriers to adoption of lateral is sort of a really important piece, but it boils down to a certain set of things that you can really tackle pretty easily. Number one is anatomy, which we'll look at. The anatomy is really simple. It is not complicated. Even though the picture that, who showed that earlier?
All the blood vessels.
I think it was Rod showed a picture of earlier with all this stuff in the retroperitoneal space. But it's something you can manage. Complications, I think, are the things you really have to think about, and how can we manage those and the difference between those two, and especially hip flexor and the pain that we talked about in the psoas muscle. Technology and equipment we're short of navigation and robotics. This is standard equipment that is in every OR. And then the learning curve, as how many people always talk about. I took out my slide on the learning curve to do that, but the reality is it's just about an 80% learning curve. We talk about learning curve like it's something unique to medicine and surgery. In fact, it really started with the with the assembly line at Ford, figuring out how many cars they could make per hour when they started. And we're no different than people working at the Ford plant, wherever it is, assembling cars. The reality is our learning curve is almost identical. It's about an 80% learning curve. After about 10 cases, your timing improves significantly. I would tell you that the reality is after 1,000 cases, you're better at 1,010 cases than you are at 1,000 cases. It's just your rapid improvement tapers off quite a little bit. There's actually some really good work on that. If you're interested at late stage in career, like 1,000 cases, you think, oh, I'm done learning. But the reality is if they look at it, and the work was done in prostate surgery with urologists, the patients do better after they've done 5,000 than after they've done 3,000. So there is learning that happens, but it tapers off. I just think the cartoon in the bottom, you really got to ask what you're looking for, right? If you're going for a hike out in the woods and you don't see the Eiffel Tower, don't be disappointed. Minimally invasive and lateral surgery is you have to be realistic about what you can do. This, I think, is what I stole that from Roger Hartle. I think it is nice because you have to figure out not just where it fits in traditional open surgery and minimally invasive, but where the benefit is and where the benefit is in your practice, because every practice is different. What I found is what Martin does, even though we sit in the same office every single Wednesday, his patient population and the people he sees and the surgery he does is different than what I see. And so I just encourage everybody to figure out where that benefit is. And in some ways it's not exact, but I do think you're going to find that out. So anatomy, we'll talk about a few things. And remember, the anatomy of the retroperitoneal space, and I turned the top one is sort of, as you see an MRI scan, the bottom one is prone. Remember the ascending colon in the within the space, and then the descending colon within the the opposite way around. You got to remember the vessels that are in there, psoas muscle, and the lumbar plexus within the psoas muscle. I think the most important thing is just to know that the retroperitoneal space is a potential space that people use all the time to gain access. And if you look at that top picture, remember, it's not just psoas muscles you're looking at. The vasculature, as you heard beforehand from Louise, if you're looking at is this a transition level or not, think about the vascular structures rather than just trying to look for nerves or psoas muscle. The vascular structures are really the tip-off. And then the musculature is really important too, especially when you're talking about doing something prone, how to safely access that. And that's really finding the quadratus in the back there. And instead of going right for the psoas muscle, palpate the quadratus, depress the peritoneum, open the retroperitoneal space as access to there, which I think is really, really helpful. Vascular structures, again, know where the bifurcation is, middle sacral vein, know where the vessels are in that spot, and especially down at 5-1, you can see the vessels, you can see the psoas muscles have exited, and this was leveled down at the bottom. I always show that. That was called 4-5 because of a transitional level. It's a herniated disc, as you can see, but they called it 4-5, and it's clearly not. So your responsibility for the lateral is not just identifying, but to know the anatomy. And this comes from Juan for the transpsoas and the approach. These are not flat structures, remember? This is a 3D structure. The genitofemoral nerve and other things are on the top of the psoas, and the ilioinguinal hypogastric run in the layers of the abdomen. So that's why we do blunt dissection. But if you have a good idea of what you're looking at with the lumbar plexus and what you can stimulate and what gets better, I especially like the psoas talk that we heard earlier. The reality is people forget there's not a named nerve to the psoas. It's ventral roots at every single level. So if you dissect across the face of the disc space, you're going to get the ventral roots from that level, and that's often why you get atrophy and often why multiple levels are a problem more than just a manipulation of the psoas. So safe and easy access should not be a barrier to approaching. Again, we're talking about prone. Blunt dissection is critical to avoid the ilioinguinal and iliohypogastric nerves, which run in the abdominal wall. And you can bluntly pass your finger in there as again, Dr. Pimenta and Juan talked about. So palpate the quadratus and then locate and push the peritoneum down. And again, I'm sorry that everything I do is prone-centric now, but these techniques will do whether you're in the lateral position or whether you're in the prone position. So plan where your incision is.
is where your incision is. You can easily navigate that. You can get depth from that navigation, which is nice to plan beforehand, and make sure your patient's secured. In the prone, you're using a frame. So the first thing I do is palpate the quadratus rather than dissecting through, sweep downwards, open up the retroperitoneal space. And there are three things that I make the residents do to be sure we're in the retroperitoneal space, whether you're doing a lateral, whether you're doing a prone, whether you're doing an O-lift, whatever you're doing is you palpate the undersurface of the iliac crest, the transverse process and the psoas muscle, and underneath the rib. If you can palpate all three of those, you're definitely in the retroperitoneal space. And I always say the same thing. Retroperitoneal was like someone's definition of pornography. Can't describe it, but I know it when I see it. And this retroperitoneal space, if you can't describe it, you know it when you feel it if you're doing it bluntly. So make sure that you can feel all three of those, all right? And then I dock at an appropriate location and place the retractor, which we sort of talked about earlier. For me, is level dependent and because of the location of the plexus. So complications, again, we sort of looked at before. I think over on this side, we always forget because we're focused on nerve and vascular and abdominal complications is A-lifts have complications with nerves too. They have vascular complications, which are higher, and less so abdominal complications, probably because we have general surgeons or vascular surgeons doing it. But people always forget about, they say, well, I do a T-lift because I don't want to risk those other complications. But the fact is, a posterior T-lift has nerve complications, vascular complications, abdominal complications too. And again, the nerve complications are really not that much different from the lateral approach by the time you figure in foot drop and other things in compression. But the real difference is this: poor correction, higher subsidence, increased infection, increased CSF leak, and pseudoarthrosis. And people forget that because they don't really have that problem. And we don't have a problem. And Martin does 10 O-lifts a year. When's the last time you had an infection? I just had one recently, so I want you guys to realize that doing it lateral. But it's not a common thing. And so we forget that when you're doing all posterior surgery, that's a real big complication. I don't think we should forget those things. I would say that lateral position, again, slightly higher pedicle screw breach rate if you look at the single position lateral. But don't forget about all the things that don't occur when you have that. And if someone tells you, well, I've never had a nerve root injury when I do a posterior T-lift, then you really should not be listening to what they have to say. But each one of these have their own issues. And I think it matters. It matters what where you are and who you have to work with. So this is just a hip flexion weakness. Remember, those run along the face of the psoas. They run obliquely. The more levels you dissect, you can't test for them. There's no neuromonitoring. You can't visualize them. They're small, mostly unmyelinated nerve roots that go directly that, and they're one of the first branches. So unfortunately, I think this is just what we're going to get. The idea is that it doesn't matter whether you go transpsoas. It doesn't matter whether you dock on the anterior part. This occurs because of the interaction between these ventral roots, which run obliquely in all those locations. And the more levels you do, the more likely you are to get multiple of those branches. So the thing that we sort of talked about, enabling technology, where do we sit? Again, neuromonitoring, I think, is absolutely critical, especially if you're doing prone, and especially if you're putting in pedicle screws. The reality is it's not that easy. I had someone ask a question last week in conference, said, well, I know Martin was there, was one of the orthopedic surgeons, said, well, what's your number of pedicle screw when you test that is going to be a problem? And the reality is, once again, it matters if you're at S1. It matters you're at L2. And you could have a lateral breach and still test perfectly fine at the upper levels because you're not in contact with the nerve root. So the neuromonitoring needs to be interpreted. Robotics, I think, is great. Navigation is much easier. Patient positioning is critical. Patient positioning is critical whether you're doing this in the lateral or prone, because you really have to have access to what you want to do. And you've already heard a couple people talk about, if I'm using navigation, where do I put my retractor? Where do I put the PSI's pin? I don't want to be fighting with myself. How do I keep the navigation working properly? I also make a comment on navigation is,
if you're using navigation, it is not a failure to bring the to bring the x-ray machine into the room and do a fluoro occasionally. You've just saved yourself a lot of time, a lot of takebacks, and a lot of radiation. And all of a sudden I hear these people, well, was using navigation, but I'd have to bring the fluoro machine. It's like, who cares? Bring the fluoro machine in, spend 10 seconds getting a good x-ray at the end of your case so you know where you're at. It's not a failure. And then pre-op planning. I just think we've got to, people have an algorithm in their head that they want to do. And I think, again, you got to listen, why are you doing the surgery? What level are you at? And where are you doing it? And you see all these great things people putting on Instagram. I always worry about, people that tell them they do a 10-level fusion and they discharge the patient the same day. I also the learning curve we talked about, I've heard a lot of famous spine surgeons, very, very well known, who said, well, you should do what you do best because that's best for the patient. I just think that's an excuse not to learn anything new. I think that's an excuse for people to just keep on doing the same thing because they don't want to do anything else. It's a lot of work to learn something new, especially when you reach my advanced stage. So it's a lot easier when you're in residency. And I really dislike hearing people stand up and say, well, the best surgery for the patient is the one that I do best. Well, your colleague down the street may have a better surgery, and I worry about when I hear that from someone, and I think this is one of the things we really need to work out against. Neuromonitoring, intraoperative modality, multimodality is the key thing in neuromonitoring, right? Use all the facts you have. Triggered EMG, free run EMG. The clinical EMG doesn't change. That takes about 6 to 8 weeks. SSEPs, MAPs, and then for us, certainly saphenous SSEPs. EMG is not enough when you're doing a lateral surgery if you're going to dissect through the psoas or retract at all. There's absolutely no reason not to use SSEPs. I also tell you that, some of that didn't project. Sorry about that. There's a couple studies looking at time. We tried to repeat this with a pig study and couldn't do it as well because I really wanted to get the lumbar plexus and the size of the nerve root I thought was important. This is a tibial nerve, which is really small. But the reality is time matters when you're retracting the nerve. Venous congestion, venous hypertension, relative ischemia, and as time goes on, it gets worse. But it is not an absolute number. If you hear people start talking about, well, if I do the surgery in 20 minutes, I'll be perfectly fine, that's nonsense. You could do a surgery and take 5 hours and the patient would be fine. What matters is that individual person. Time does matter though, but it's not an absolute number. But certainly the faster you work, the less problems you're gonna have. So I would tell you, saphenous SSEPs are great for doing that. Automated femoral nerve monitoring. It's really, really hard to get a false negative with reliable saphenous SSEPs. They don't, really, the studies show if you never have a problem, it's so rare for people to wake up without a deficit. And I have actually found that it's very sensitive and it's specific. And you really want to think about multimodality, correlate where you're at, but the saphenous SSEP automated monitoring is something you really need to pay attention to. The longer you do the surgery, the bigger the problem is. And this is just really just telling you that it's really difficult with saphenous SSEPs to wake up with a deficit that didn't show up in some way on the neuromonitoring. And I think it's a really, really great thing to follow. The other thing that's nice about neuromonitoring is if you remove the retractor, if your saphenous SSEP has dropped, then it's very, very good news when it comes back to normal, okay? So again, it'll return back to normal quickly and it'll give you an idea as to whether you're gonna have a problem or not. This is really a plug again for robotics and navigation, especially in the prone position. You've seen the pictures down there before of docking and the opportunities you have. The bottom picture there just shows you how hard it is to really angle the retractor with fluoro. You really need navigation. And the reality is, this is just a study. It was an AO study that I ran into with a database they have. The reality is, if you're not using navigation in some way in the countries that are in sort of
orangish there, you're really behind the times. Robot assistance is much, much less. So the reality is people have found navigation to be more helpful. The robot is still not as well used as the navigation piece. But the navigation piece, especially when you're talking about lateral, allows you to see the vessels, allows you to see the psoas muscle. Now, neuromonitoring gives you an idea of where the lumbar plexus is, and it allows you to work in that space very, very, very safely. And so I really think you need to do it. Again, prone, what do I like about the prone position? I didn't show this slide before. Surgical planning with coronal bend, being able to increase your correction for scoliosis, reduce abdominal issues, the anterior perineum falls forward, familiar, fast, easy, safe positioning, increased lordosis, and then simultaneous access and posterior plexus. All of those things make it better. So enabling technology, this is someone else's case. I asked someone, I don't remember who it was now, I said, hey, can you send me an expandable cage case, because I don't do it. But lateral expandable cages are an enabling technology for what people are doing. So the reality is it's very accessible through the lateral space. This is someone bilateral PCOs, which if you're prone, again, very, very easy. It's not a roadblock to do anything posteriorly. There's no reason you can't do lateral, flip the patient. I actually have in the past done just exactly what you saw before with a multi-level case, come back another day and see what's going on posteriorly. But expandable cages are great as an enabling technology along with navigation. And then it's sort of future things. We've already had talks about corpectomy. The reality is the corpectomy case are great cases to do for these people. Very easy access and look good when you get done. There's another case, which I think just looking at odd cases that people do, a spinal shortening case with a tethered cord. We have done a couple of these. If you have patients in your practice, as we have a big pediatric practice that have had a couple release of tethered cords, this is something that's really nice to be able to do, a spinal shortening. We usually do it at the T12 or L1 level because it's actually loaded. So you can very easily do a partial corpectomy, transpedicular corpectomy posteriorly, place pedicle screws, continue with the anterior corpectomy in the lateral approach simultaneously, posterior rods, and then compress through that area to be able to give yourself a really good chance for a spinal shortening case. And this is just the picture posteriorly, where you can see the rod in place. And you can see where we are. This is the lateral picture. This is the corpectomy we did in the green line, and then closing off the corpectomy at the end with a complete resection of the bone. So future directions, I think we're going to find other things to do with the lateral approach, corpectomies, and you're going to hear about a lot of deformity. And this is the procedure afterwards, where sort of bone sits on bone. Thoracic disc cases, again, prone thoracic disc cases. This one's especially good if you see the top screen. You can see the patient had both posterior and anterior compression. Doing this prone allows us to do the laminectomy posteriorly. It allows us to do a decompression, pedicle screw fixation, and do the anterior approach at the same time with a discectomy. The far right picture is the retractor with the discectomy in position there. And we already had a talk about removing the rib head and everything, which is easily done through a small incision. But as you start to look for things, this is not an uncommon finding where you think, oh, I've got to do a posterior surgery at the same time. So you're not supposed to put disclosures down, but my disclosures are really that I'd rather be here, and I'm not here to take away your surgery that you like and that you're married to, but I really want people to start thinking about patient-centric approach. Why am I here? What am I doing? What level am I at? Where am I operating? And I think you're going to find that each of these procedures will fit into your algorithm very, very well. Thank you. All right. Go ahead, yeah.
Hey, so outstanding work and great summary lecture. Speaking to the prone surgeon, is there a circumstance where you'd see going bilaterally, so patient is prone, you're doing a posterior part?
Yeah, it's kind of funny you asked that, because there's someone that I work with, and it's Roy Ashtori, who's up in San Francisco, and he has talked about going
bilaterally when he's got a scoliosis patient, really where he thought he couldn't get into one level from one side or it was difficult. So he has done bilateral approaches. I have, seriously. Yeah, I have never done a bilateral approach.
For the record, that's ridiculous.
Say that
I
again?
want this on tape. For the record, that is ridiculous. I really do not believe we should be supporting it.
Yeah, crazy. And I'm telling you,
It's getting out of hand.
that's what I'm saying. I have, okay. So what I was going to say is I have never done it. I don't recommend it, and I wouldn't do it. But if you guys want to do it, it's up to you. I see absolutely no reason to do it. I've never
Wow.
done it, don't plan on doing it, and wouldn't recommend it. Yeah.
Nope.
Any other questions? Yeah.
So, do you find your confidence in the saphenous SSEP allows you to spend more time when you need to?
Yes.
Because at least for me, I've triggered the alert probably 12 times in 200 levels of this, skewed early on, and I've always closed the retractor or just hurried up. Unfortunately, not had like a big problem with it, but it does help me to be more careful. Like I had a nerve plastered over the disc space a couple weeks ago, and I spent 30 minutes kind of painfully scraping it out of the way. But I felt okay because the SAF SSEPs were good. But I don't know if that's too much.
Yeah, so I think there's a lot of questions in there, right, that we sort of brushed over. Number one, the automated stuff, the alert comes up at 50%. That's because that's been the traditional number. There's absolutely no physiologic reason that 50% makes any difference compared to 75% or 25% as far as we know. That's what the neurophysiologist picked in the beginning, and so people went with that. Does it matter? The answer is, we know it matters, but we don't really know when, right? Nobody knows. Is 10 minutes at 50% the same as 1 minute at 75%? So none of those numbers are known. So I always caution people that these are done because of a long history with a different monitoring system and a different, neurophysiologist in the room. But you should pay attention to them. It's all we really have, but that number is not perfect. So if you're getting alert, you have to figure out how long is it into the case. The biggest problem that I've actually seen in my patients when I'm doing a prone is femoral nerve problems because of positioning. And that will come up on the saphenous SSEPs because it's part of the output of the lumbar plexus. So I find that to be the bigger problem.
You
But
usually see that bilaterally.
bilaterally usually. So you have to think about, when do I see it bilaterally? The other thing I would tell you is the neurophysiologists who are doing saphenous SSEP monitoring are not as helpful as they pretend to be. Now, why is that? Number one, it's a very, very small signal. It's very difficult for them to navigate and monitor that and see any change. Number two, they spend about 10 minutes averaging this. They don't have rolling averages when they do it. So they do it for 10 minutes, and then they do it for another 10 minutes because they want to make sure that you really have something. You're up to 20 minutes by that point, and you're done with a level almost certainly. So it's really a difficult thing to do. So I use the automated one for that specific reason. I will do something in the short term. If I'm almost done with a level, I'll just keep on going. If it happens quickly and it's bilaterally, probably femoral nerve, anesthesia, some problem. If it occurs pretty quickly, I will often reposition the retractor. I'll decrease my retraction time. I'll lower it down because remember, if you look at the studies, it shows venous hypertension is the initial problem, right? So venous hypertension and then relative ischemia because you don't get as good a blood flow because it backs up. And so you have a recovery time. So the sooner you do something, the better chance there's not going to be a problem. But I would tell you it sort of matters what you find, when, and how terrible it is. There's nothing worse than someone who has absolutely no experience looking at the automated saphenous SSEPs and tell you, oh, it's dropping. It's like, and that's a really frustrating situation. That's the only thing I don't like about it.
I think the coronal bending is very helpful, but I take that off as soon as the lateral body's in, because I think that probably.
I do coronal bending, the pads, tweaks the psoas, I loosen up the pads, I decrease the retractor. It just buys you some more time is what it does. I don't know. What were we going to say, yeah?
So if you go to PTP multi-level versus one level, where do you anchor your retractor? The top or the bottom of your exposure site? So in other words, if you do want to, let's say, for example, L2 to L5, you put your retractor, the anchor above?
Above. I'll put it above because I'm navigating and I made the mistake multiple times and I put it below and the arm seems to get in the way of it. So I always put it above. I don't know. What are you guys, Martin or Neil? Zach?
I mean, if you're using fluoro, I would put it closest to the hardest level.
Yeah.
So it's usually 4 or 5, I want the least motion. For you, because it's not in the way of the fluoro. But if you're nabbing, then you're gonna have to be.
Yeah. Any thoughts, Martin?
By anchor, do you mean the post?
Yeah, exactly.
The post, yeah.
I mean, for me, it's always to my left. You know, usually it's just closer for me to maneuver. And you know, to Bill's point, it's out of the way of the navigation because it's lower profile. If you ever find your retractor coming up and over, remember there's enough joints to flatten it.
Yeah.
Right? So, you know, if, you know, some companies make a short arm already, which is nice. Use a company that the arm is still long. Just remember, if it's coming up and over and dropping to your PTP, typically that joint on top you can flatten down against the patient's back, so that it makes room for the neck.
Yeah. All right.
All right.
Good, thanks.
I think. All right, we got the master, Dr. Chapman. Lumbar alignment and intradiscal osteotomy.
No master here. Honored to follow the original PTP, the prone-to-prone PTP surgeon, and my talk is here. And I'm the professional naysayer or the voice of consciousness, however you want to interpret that. I'm Jens Chapman. I get to work here, and I have a lot of fun, and it's an honor to speak in this meeting about the power of posterior. So herein, I concur with my preceding wonderful speaker, and considering deformity correction from the back and maybe beyond that, avoiding fusions. It's customary that we use conflict of interest declarations. And it's also customary to hear the lecturer say that there are no conflicts of interest in a reassuring fashion, but this is not the case here. I'm going to talk about something by a company called Extent and a company called Limiflex, with which I'm both deeply conflicted, and I'm going to point it out separately. There are a couple of other disclosures to make. One, and I want to credit the wonderful Dr. Neil Anand with the left-hand analogy, the Wolverine surgery versus KISS. I like KISS. I mean, you can think even less of me now, but I like simple, and you know what the acronym stands for. It's been going well for over 50 years. That's my age disclosure. And so posterior midline, again, we have these Wolverine spines that are all over now. And thank you, Neil, for this analogy. And I will, in the future, put your picture on there. So make sure that you are not the surgeon of these, but the inventor of this very appropriate acronym. When our maker gave us actually a beautiful access point, it's called the posterior midline. And this is also a debate about complex versus simple. My head is spinning about the various details that these masters like Martin leave the spacer just 2 millimeters out so you can navigate through it. I mean, this is amazing to see. And I'm a simpleton. It's very evident. I'm not intellectually capable enough to remember all these things. But it's also generational conflict. You see my receding hairline. And I'm from Gen O, so Gen Old versus the Gen Z people who show us what they can do, which is pretty darn cool. But the fact that you can do something does not necessarily translate into you should do this. And so the other aspect is a brutal one, and that's rigid versus flexible. Are we fusing too much? And the numbers are, in this country, steadily rising pretty dramatically. Now we have an aging population that's also more sick. But if you ask me, what is the incidence of adjacent segment disease next to a fusion? The answer is not 10% or 30%. And it does not matter if you've done perfect realignment or not. You can make it worse with misalignment. It is 100%. It's just a matter of definitions and how closely you're willing to look. And what thresholds to use to post-surgical magnification. So the point is that with better and better, cooler, less traumatic ways to do fusion surgery,
are we actually providing patients with a lasting result, or is this an annuity proposition? And I think we're way too focused on fusions. Again, this is a side effect of fusions, and I do a lot of fusions, as the industry representatives in this room here can attest to, but many of them are revision surgeries. Easily a third of my surgeries are revisions of previous fusion surgeries. So the final conflict is that of magical thinking versus reality. And again, if we apply reality, we should not be oversimplifying, exemplified on the right-hand side, but hopefully common sense of one of our founding fathers, Thomas Paine, is a prudent common ground to kind of go to. And if we think about spine surgery, there are three things that we all agree on. That is effective and lasting, if possible, decompression of compromised neural elements. Number two, meaningful realignment and stabilization of the spine. And number three, a solid fusion where we want to fuse the spine. I think those are all three reasonable tenets that we can all agree on. And again, if we achieve the ideal state, either with an open procedure, which is or can be pretty cool, or through a glass bottle hole, through really small things with a lot of technology around it, it's a matter of conjecture and interpretation of what your ideal goals are. But the three tenets should be fulfilled. And one problem that I have in this incisionally focused era is how long is the expected goal? I will rapidly concede that the less invasive surgeries lead to a fairly high patient satisfaction, not always, for the first 1 or 2 years. And after that, there's a pretty steep reality check. And that's, again, what I make a living off. So this is, again, a classic L4-5. This should be a no-brainer for all of us. Degenerative spondylolisthesis. This was assumed a Wolverine approach. Thank you again, Dr. Anand. And again, this is what I see in clinic. And this is just what Dr. Taylor said. There was no realignment done. I'm not sure where the hardware is. This is all navigated, percutaneous. There's not a real neural decompression in the foramina. It's just one of those things of, okay, somebody fulfilled the billing codes, and bingo, here we are, and now deal with the sequelae. So this is my proposition, what you can do with a single midline incision. No, this is not some major rape of the spine. It's a very focused, soft tissue-friendly incision and effective decompression, realignment, highly reliable fusion, even without BMP, and a very limited tech use. And yes, I love expandable cages. Thank you, companies, for making those. They are very good. So why are we doing these things, and do we really help patients when we hit them like this? I'm just not sure, but I actually, at the University of Munich, where I came from, trained as a general surgeon for the first 2 years. I love this anatomy. This is amazing. But do I really want to think about where the ureter is right now? Do I really want to scar the retroperitoneum for if this patient, God forbid, needs another retroperitoneal approach in the future? They need to have stents in their common iliac veins? Not really. So this is just, again, a fact of life, and I admire our colleagues who managed to navigate through all these tripwires. Yes, this is a real-life MRI, 3D print from an MRI from Perry Godolphius, who really did a beautiful job getting this decoded and put into print. So the neurologic sequelae have been much batted around, and there's probably about a 1% to 2% long-term neurology. I know in the masses, hands like Dr. Uribe, this does not happen, but these are actual published numbers that we came up with. And again, it's not a big surprise. And we're learning things that we've never heard of before, like the pseudohernia, that bulging abdomen, probably through a T11 or 12 injury. We've all learned intimidating things about the genitofemoral and the ilioinguinal neuropathies, rare things, but pre-disabling when you have patients come with weird scrotal pain after what should be a routine surgery. So briefly about fusions, again, we all learned how to do PSOs. This is a routine surgery for me, and feared because it was a pretty bloody surgery. And there was, again, always a neural or dural redundancy created during the shortening of the posterior column. And as an orthopedic surgeon, I actually have loved to have the thought of a neural balance, a neural tube balance, where there's no big folding, where you have a nicely properly tensioned dural tube, properly filled with CSF, with nicely falling off nerve roots present. So shortening the posterior column is a salvage procedure that I rarely do, but with so-called interdiscal osteotomies, which fulfills many of the principles that we've just heard lectured about through far lateral surgery. So you can actually achieve an extremely efficient deformity correction It's a bilateral, more or less expanded T-PLIF, if you so will, with strategically placed hardware after nice release is done. The nerve roots should not be injured, and you can ask Dr. Cameron Hogshead, who's doing a nice expanded study now on IDOs and results for an unfiltered status check. And again, I usually place 2 cages unless it's an eccentric coronal deformity reduction, and you can get a very nice reduction and a very controlled low doses restoration with full neural decompression. Now again, this is my current clinic. One of those cases has been revised. The other 2 are still sitting around, but these are all patients who've had L4, 5, or L5S1 fusions done in a variety of hospitals, not here. And they all start as a simple L4, 5 fusion, however it was done. But these are truly pre-catastrophes, and I'm not particularly looking forward to 1 or 2 of those. That's a fact. The real problem is the following. As we're aging and having more and more degenerative spines, this is just a case of which I'm sure our clinics are filled with them. Mine certainly are filled with these. Aging patients are very unhappy with their spine, and yes, the MRI will show us multiple areas of some decay. The X-ray shows a somewhat imperfect structural balance. There's some neurogenic claudication, and the question to all of us is, what would we do? And the problem is now that the first go-to thing is with the power of modern, phenomenal technology, fusions are done. I see a plethora, and I could show you lecture after lecture of L3 to 5 fusions that have expanded upwards and then downwards, are catawampas, and then get a posterior midline fusion. But this is what we see, and this is what we all know to be fusion disease. Was this really necessary? Well, this patient actually had severe neurologic problems from a dural erosion from one of those screws, so we took her back and did a nice IDO, corrected her. 1 or 2 level IDOs are very powerful. You can literally correct anything, 3 levels for sure, in terms of coronal and sagittal rebalancing. Like 3 or 4 months later, over the Christmas holidays, she came back and dislocated despite perfect proximal, meaning rostral junction, preservation, tapes, hooks, etc. No violation of midline structure. She dislocated. So this is pretty frustrating. Yes, we took her up to, I think, C7, and she actually did okay with that, but a year later, she passed away from medical problems. But in the end effect, she was subjected to what is the corollary of a polytrauma by being hit by a small semi surgically at enormous cost with a very debatable benefit. When in fact, if you look at the origins of this and go back to the origin story, it's probably a neural impingement that really bothered her most. And yes, her spine is imperfect, but in our signaling, and here I'm daring to speak in front of many distinguished neurosurgical colleagues, the majority of our pain signaling is less from a little bit of an instability or a minor deformity. It's more from neural impingement. Do I have a concurrence? Let's say, oh, I don't get any attention from anybody. Here, Dr. Uribe. Yes. Neural impingement, is that a primary signaling thing over a minor instability? Yes or no? What does this patient on the right-hand side, without knowing anything else, primarily going to be concerned about? Their nerves hurt, they can't walk. That's my hypothesis.
I wouldn't say that is instability unless you show me flexion extension.
I know, I'm giving you an incomplete set of cards. I'm just asking a very fundamental neurophysiologic question. If you have compromised nerves over a bit of degeneration or a bit of instability, where's the primary alarm signaling going to? I hypothesize it's neurologic over anything else. Debatable, we can talk about it. So can we do something lesser than fusion? I know it's an imperfect image, but neural impingement is there. The big question, the Hamletian question, is literally to fuse or not to fuse, and maybe reduce the need for fusions. I do think, and even if you do a fusion, that doing proper midline sparing decompressions with partial facetectomies and feminotomies is a very powerful surgery. And by the way, the time-honored full laminectomy in our paper by Mike Lee, done in my UW days, shows a 32% destabilizing effect. So this is a substantial sacrifice that we do. It's basically 20% worse than if we do midline sparing hemilaminotomies. The other question is, can we do something with posterior stabilization? I'm showing you 2 conflicting devices that do the exact opposite. One is an interlaminar spacer seen on the left. The other one is a tethering device on the right. I'm conflicted with both, just to be very clear. I'm standing here and telling you I don't know which one is better, but I'm just going to quickly extrapolate on that. When we look at patients, we all have learned angles and we've all been indoctrinated in the sagittal balance, which is correct, of course. But this is actually a far more complex thing. And The main problem with standard alignment programs is that there's something called the neural escape posture. These are not static things that we're measuring right now with our surgeon map or whatever system we use. These are actually flexible things that are frequently, not always, a product of either sarcopenia, deconditioning, orthopedic conditions like hip or knee arthritis, or neurologic escape postures, the spinal stenosis forward bent posture. We all know that we should know it at least. So there are multiple factors, I'm not going to read through all of those, that go into alignment beyond just the measurements. High discs, low discs, kyphotic angulation, vacuum discs, the severity slip. Yes, facet joint alignment, still not adequately categorized. Is there fluid, is there not fluid? Is it a sagittal, is it a coronal facet? Is it around 45 or 50 degrees or not? In conjunction with the disc height, this creates a dynamic environment for that particular space. The fluid sign is fascinating. We all know of it. We all have not really categorized it well. We have not also looked at facet tropism and dysmorphism or not. These are all factors that play a role in patients. So these are factors. When we actually added this up, and this has not been quantified yet, we actually come up with 15 things that play into a simple assessment of an L4-5 segment that have some role in what we do. So intuition, and maybe in the future, some machine learning tool will help us aid this. But again, these are some things I just am showing you very briefly that play into our assessment of these patients. Now, when we looked at stabilizing devices like the Limiflex, I'm conflicted. They actually did pretty well. This is a tethering device posteriorly. And so this is getting FDA approved. So here, a couple of cases. 74-year-old farmer, lives alone, BMI high, type 2 diabetes. Farmers are the best patients in the world, sorry. They are unbelievable, and they usually can't stand the thought of being in a hospital. This is a morphologically poor patient by all means. That patient wants to be back on the farm as soon as possible. I did an outpatient surgery with a Coflex device. Yes, I'm conflicted here, please note that. You can't ask for a happier patient. My clinic loves them also because these patients are actually very happy. Is this a perfect x-ray down here? Absolutely not. Have they been kyphogenic? Not really. Have patients been happy? Is this just enough stability maybe for some of those people? That's probably pretty reasonable to assume. This is a former professional model. She still comes to clinic looking like a million bucks. She is very active, very healthy, very health conscientious, very thin, very fit, and again, grade 1 spondy. It's run of a mill. Here we gave her, she was part of the FDA trials, a Limiflex, the opposite idea, completely happy. I think she's 3 years out now. You can't beat that. Is it a perfect x-ray? Absolutely not. Is it stable enough? It seems to be. This is a compression model posteriorly. This is a professional former skier, 2-time Olympic medal winner. I'm not going to disclose her thing. I take responsibility for this 2-level L3 to 5 fusion. I did this, not proud of it, but this was, I think, 15, 20 years ago. Actually, 20 years ago. Charlie Ray Cages, a brilliant surgeon. Friend of mine, I was very privileged to know him. And the only American I ever met who can speak perfect Swiss German without having any German ancestry. So she now has the expected transfer disease. Remember my paradigm? 100% incidence of adjacent segment disease. However you do it, it's an unphysiologic procedure we have to do or do by choice. So expected adjacent segment disease. She had a compression fracture higher up. She had very good bone density. I talked about 1-2 level fusions or T10 to pelvis, which I'd always talked about. She said, absolutely not. After several discussions, I did a 2-level interlaminar process spacer device as an outpatient. I think she's actually now heading towards 2 years. She's very happy, and she's back in full active life. She looks, again, amazing for 81. The textbook answer would have been a T10 to pelvis fusion probably in most hands. So final, degenerative scoliosis, had a previous laminotomy at L4-5, very unhappy, saw multiple, a very nice, very well-connected person, saw multiple surgeons. Everybody told us some degree of fusions, ranging from T9 to pelvis to L2 to pelvis, et cetera, et cetera. In the interest of time, I'm not going to poll the faculty here, but we talked extensively about it. She said she had absolutely no back pain. She had leg pain and weakness. She couldn't walk. Yes, we did a single level, very careful revision decompression and interlaminar spacer. The x-rays are not perfect. She's extremely happy. Yes, one more time, I'm heavily conflicted with this company. Is this a cure-all? This is a Again, another farmer walked out, this is not what I wanted to show. I wanted to show some negative examples. This is not a cure. This patient with rheumatoid arthritis, we did a decompression. She did very well. From a neurologic perspective, she still has back pain. Am I going to operate on her? Probably not, but I'm certainly following her with great interest. And she's happy that she doesn't have leg pain. She still has the same amount of back pain. So I'm not going to claim that I have the cure-all at all. If you look at larger publications, and they're heavily influenced from the Far East, complications are between 3 and 15%, and the remedy for a surgery that has failed here is a fusion surgery, which is probably okay if we did a less invasive surgery. This is, again, a longer-term follow-up of an 80-year-old radiologist who's amazingly fit. He's of Dutch origin. He's an ice skater. And after many discussions, I did a single-level Coflex device on him. And at age 85, he came back because he had a, quote, clicking sensation in his back. And here you see that his spondy has worsened. His MRI, you see on the top, is very reassuring, but he has a clearly progressive degenerative spondy here. I told him, do you want to have a fusion done? And he said, absolutely not, and walked out. So we're still in touch. We're still friends. So the point is, let's not have a dogma. Let's be a little bit more thoughtful. Posterior midline exposure is potent and strong. And here's a real life and almost live thing. And anybody who doubts this can walk down with me one floor and see this patient live. She's post-op day 1, and she's going to go home either this afternoon or tomorrow morning. Works in the beauty industry, mid-40s, female, BMI 39, totally healthy, severe left lower extremity pain, weakness, back pain. She does have what is probably a grade 2 degenerative spondy. She has an eccentric collapse. She has a pretty large disc herniation of foramen. She has, and we don't have the CT here, a eccentric, very dysmorphic facet joint anomaly. After many discussions, even I, who likes to preserve motion, decided on doing a fusion. The statistics, and Dr. Hogshead can back me up on this, under 3 hours surgery with an extensive splenic block, blood loss under 200 cc's, of course no dural tear. Length of stay so far 24 hours, hopefully home this evening or tomorrow morning. Leg pin is gone, 10 centimeter incision. And this was done through an intradiscal osteotomy via an ATA approach. I think acronyms are what it takes to sell a surgery. And for those who don't know what an ATA approach is, like a PTP, ATA is a tergo approach, from the back, Latin. So this is, again, my pitch. Reconsider fusions. Are fusions truly minimally invasive? I think not. This is a biomechanical legacy that will at some point in time have reverberations in the rest of the spinal column. Let's reconsider clear indications for fusions. A lot of these grade 1 degenerative spondies I see, I would truly try to either do a decompression or stabilization over a fusion. And they're not a cure-all. I tell patients 15% by 5 years, you'll have to have a revision surgery. Flawless execution of what we're doing, of course. So do consider decompressions plus minus stabilization surgeries for the lumbar spine. And I'm an avowed fan of motion preservation. I love laminoplasties. I love cervical and lumbar disc replacements. I think that makes far more sense for degenerative disease than fusions, if avoidable. With that, I close. Keep it simple. Thank you.
Yeah, and that was comprehensive. I'll go saying that has always been said, right? The young surgeon fuses, the middle-aged surgeon refuses, and the old surgeon refuses.
Well said. I'll quote you in addition to, I'll put that down in a quote, and in addition to the Wolverine spine. Thank you.
That's good. Neil, you're becoming very philosophical, man.
Yeah, what can I tell? We're getting old.
Like the latest pope, he used to say, the young guys run, the old guys know the pathway. You know, young guys run too crazy, but the guy who knows how the pathway is are the old guys. So, okay, so I'm just gonna give you probably just tips, you know, how I function when I do laterals. I wanna be learning by hitting the wall and having all these complications, and a little bit of a tour on what you can hit doing the lateral approach. It doesn't matter prone or lateral. As long as you get into the retroperitoneum, you're facing the same complications, you know. You just choose your poison, but no matter what, you're gonna be, you know, it's like you jump into the water, you know, You're gonna deal with the same sharks, the same things that are in the water, no matter how you go there with a wetsuit, swimming forward, backwards, the same thing. So this is basically what you can face on there, You face vessels, organs, and nerve structures, That's basically what you deal with. And the carpentry thing, that is probably the less complicated complications. So let's gonna go to most of these ones. Okay, so these ones are the no complications, which are the, what we call catastrophic injuries, that are a combination of the vascular injuries and the bowel injuries. That's like these complications should never happen during lateral. It's like when you do a lumbar disc and you get one of the iliac veins. Think that it should never happen. If you have a vascular complication during lateral, you're out of the normal. You lost your procedure. You got lost. You definitely, to me, that's like, it's a negligence, because you hit one of the big vessels. A couple of things happen. One is, if the vessels were in your way, you didn't look at the preoperative images. And then if the vessels were not in your way on the approach and you hit them, you were lost. Somehow you lose control of the case, yeah? So that's why it shouldn't happen. Same thing with the bowel, The bowel, there on the retroperitoneum, most of the time the colon is a retroperitoneal structure in some parts, but the colon is very predictable. It's a very mobile organ. If you hit the colon, also it's like a no complication. You shouldn't have a bowel complication of this stone, And I can tell you, it's all about be careful. I've been lucky. I'm not saying that I'm gonna have a vascular or bowel injury, but all of my experience with lateral, I never have a vascular injury or a bowel injury, I have everything else, you name it. But that complication, I never have it. I don't know, Dr. Pimenta, have you have a bowel or vascular injury? You never have it.
We had a ureter injury, not me, but a member of the staff that opened the LL, the tractor moved to the front and cut the ureter. But, and this shouldn't happen as well.
Yeah, so we made
I had a large colon.
Yeah. It shouldn't happen, The colon injury is a problem with the dissection, and the problem is, which is interesting, how we react to complications. Someone has a bowel injury, and I remember in your hospitals, when there is an infection, they come with these weird things, people has to walk backwards and they have to clean with the things, and hospital changed the entire thing because it's a reactive society, So when we have a bowel injury, then they decided oh no, you have to do the dissection with your eyes and you have to use these things. And to be honest, as long as you stay on the retroperitoneum and you go on the quadrilateral lumbaris and you go there, you don't need to see where the colon is, the colon moves away. But that's a complication that cannot happen, okay? So this is exactly what you need, no matter how you're going. Pre-Psoas, trans-Psoas, we have a really good illustrators at the Barrow, and this guy that is called Peter Lawrence is like, I call this guy, he's like the new, what's the name of this guy who used to be? Nether. He's like in the modern Nether. This guy is amazing. He spent a lot of his time drawing for Dr. Lawton, of the vascular malformation and that, but when we got them for us, he always come with an amazing drawing. This kid is like talented as much as, and it's so funny because they belong to the era of the new artists, everything is on the iPad, He had this program, he put layers. It's fascinating to see him working. So we asked him, listen, get us a really good drawing and show us everything that we can hit there. And this is basically everything that you can do. And you see there, you choose your poison. If you go pre-Psoas, you have to deal with a little bit different structure that you go trans-Psoas, but no matter what, we end up on the same place, Both of them, we have risk of vascular injuries and everything else that is there, yeah? So this is actually, most of these ones are complications of mine. As you see here, it goes pseudo-hernias, subsidence, psoas hematomas, nerve injuries. So through the years, and then I'm gonna ask you, you're gonna ask me, a lot of people ask me why I don't use plates. you will see a lot of answers why, Plates is like a complicated thing, and we learn a lot, and when I get to the place, I will show you what, and hopefully you guys walk away from the plates, because we learn so much. You see this guy? You see the little guy in here? We invented a fracture, this one. It's called the coronal fracture of the vertebrae. That thing didn't exist. It has to be on the neck, like a tear. I don't know, you guys probably you do traumas a lot. You remember this patient that come with a teardrop, fractures on the neck, that vertebra split, and he has this little teardrop on the front. It's basically similar to this one, but on the lumbar spine that never happened. This is not even a fracture dislocation. This is weird. We created with the plates. So we're gonna go later on that. And then, the good thing is this is something that happens really good with lateral. That didn't happen with the T-leaf, didn't happen with the A-leaf, didn't happen with the PLEAF, didn't happen with everything. Because this procedure started late, Pimenta make it in the early 2000s, and then he published the field paper with Taylor in 2006. That was the first paper in the literature, in the American literature. I call the mafia literature, in the American literature, was published in 2006. And Pimenta was able to publish because Taylor helped him out, and we put it on it's not the way?
No. He's never forgiven me because
The surgery was called Letra. It was not X, it was Letra, the name of the surgery before, yeah?
of course he was Oscar.
Oscar, yeah.
Put their name
Is the
first.
most, is the most,
Never forgiven me for that. It was his only paper he'd ever written. His only paper.
people ask, who's
Never read anything
Oscar?
else.
Who's
That's it.
Oscar?
That's it.
People ask, who's Oscar?
Oh, the X-Lift paper, right.
So that was 2006. And after that, this procedure, the lateral procedure, has been scrutinized so much. And the funny thing is that when I started doing lateral around 2006, and I started having complications and that, I remember asking Pimenta, Taylor, Neil, everybody about the complications. Sometimes we answer, sometimes not, and we start doing that. But what I did is, and actually for the young guys in here, I built my career publishing complications. And this is showing in here, this is a bunch of complications that we've done. But if you look at my complications on lateral, most of them are complications. I publish pseudo hernia, rhabdomyolysis, plate fractures, subsidence, you name it, But this is what makes this surgery so good, because it was an effort of people honest. Every time there was a complication, we were talking about it. We let the people know, and then we find a way to avoid it. And we just keep going. Something that did not happen with the axial lift. Remember, Neil? The axial lift, we couldn't. We were trying to work with the company and make it like, listen, we're not getting lordosis, we're not getting fusion. They were like ignoring. No, let's do 2 levels. Let's do 2, you remember? And Lou, Neil, you pioneered, you were champion a lot of the axial lift. I don't know what happened with the axial lift.
And killed the company. And killed the company too.
I did 60 of them. I did 60 axial lifts. Actually, I didn't have like the colon injury, but obviously I had a lot of zooarthrosis and no lordosis for sure, So everybody here, you guys did axial lift also, yeah?
I did about 80 of them, and I showed the radiolucencies around the screws.
They didn't listen. You did axial lifts, bro? You didn't do anyone. What about you, Jens? You didn't do?
Took him out.
What about you?
Absolutely.
We did a lot of axial lifts. Oh my God.
The company got really angry. You go and tell them, and they'd be like, "What are you talking about? It's your problem. Everyone else is fine except for you."
It is the greatest example, that we can laugh how much you want, the greatest example of Scott's parabola. Everybody throws that graph up there. It has never really happened, but this one went all the way through. It reached the peak and then came down and completely crashed and burned. It's a true example of how technology can come in. We all use it, jump on the bandwagon. Those of us do it, complications happen. But then you're right, at the end of the day, you have to call it out and it has to go. And it's gone.
And it's interesting because the approach, it makes sense. You get into 5-1, very minimal invasive that. And I always say, if this procedure was in the hands of Pat Miles or one of the guys who are really honest, I bet that still will be around, with some indications, some modifications or something still be around. It's just, but it's interesting. But let's keep going about these ones, okay? So this is watch this one. So every time we do, you as a lateral surgeon, you ask Chapman about this MRI. Chapman, what you see in this MRI? Watch that. She's gonna tell you, what you see there? I'm gonna show you differences, in between.
This one's.
Dr. Sharma, what
So
you
I'm
see in
seeing
that
a
MRI?
sagittal
Read to me that MRI.
I'm
Read to
giving
me
you a
that
sagittal
MRI.
T2 MRI. I'm getting a axial T2 MRI scan. I see some spondylosis concentrated between L3 to S1, end-stage non-reactive spondylosis L5S1, lateral recess stenosis L3-4 and L4-5, presumably.
Okay, there you go. That's how a spine surgeon lives at that. I'm gonna ask you how a lateral surgeon read this MRI. Nima, can you read that MRI? Watch Nima Allen reading that MRI. Get the microphone. Okay, what's the difference, okay? This is very interesting.
I was going to read it the same way as Dr. Chapman, but if you want me to read it differently, I will.
No, just read it.
Yeah, so I agree with all the assessment about L3 response spondylosis, discite loss at L4-5. I also see the psoas slightly transposed anteriorly. The vessels are well beyond the vertebral body, anterior vertebral body line. And I see some fluid in the joints. I think it's going to respond to indirect decompression.
There you go. You see that? So he's seeing more things that
I have a conflict of interest.
He
I did
looks
that
at
1
more
year fellowship.
things than Dr. Chapman looked like. When you're a lateral surgeon, first, you have to look, is this a transitional level or not? What is the psoas? Are the psoas in a good position that I can go transpsoas or lateral? Second, where are the vessels? Are the vessels anterior or in my way? Third, how are the joints? Can I have these lock joints where I don't have indirect decompression? How is the disc height? If there is something that I can regain height and I can do the compression indirect. So you see, it's very interesting how once you start doing lateral surgery, you start looking for different things. And this is your job. You start doing lateral, you have to look at this because you can prevent a lot of complications just by looking at the MRI on the clinic. And I'm glad, I'm proud of you, Nima, seeing like you didn't lose time.
Tell him I did a fellowship with you.
Okay, so now let me show you, for example, so that case was since looked like that. Okay, let's start with this one. I look at the x-ray of this patient. Okay, again, I'm gonna keep pushing Dr. Chapman. Dr. Chapman, what you're seeing here?
Now I know where this is going, a high riding iliac crest. Oh my gosh. Maybe I'll send the patient to Dr. Chapman for assessment of an interlaminar stabilization and decompression.
There you go. So see, life is easier for Dr. Chapman. Nima, what do you see on that x-ray?
All right, let's see if this works again. So I see autofusion L5S1. This is not a perfect lateral. There's two different shadows of the crest. One seems to be higher than the other. Some spondylosis at L4-5, tiny spondylosis at L3-4.
Okay. So is this a high crest or not a high crest?
Oblique crest.
It's a low.
Okay, so this is a rule of thumb. You didn't learn that part, okay? This is a rule of thumb. When you look at the lateral x-rays and the crest is higher than the peak of L4 or that level, you start dealing with a little high crest, And the high crest doesn't really mean anything. You always can go with angle instruments. The high crest, what it tells you is like, watch out, this may be a patient with a transitional anatomy. So what it does, this one is throws you on the MRI right away, and this is what you need to do, yeah? Because it's not like, oh, I just cannot get in there. I mean, you can get it anywhere, you just break the guy, you go, whatever. The question is what is behind that? And this is what you can see sometime, So you see here, this is the classic, what we call, the Mickey Mouse. Yeah, so you need to get used to that when you're a lateral surgeon, where are the ears of the Mickey Mouse, yeah? So this is important because when you have Mickey Mouse ears, you know that the plexus can be more anterior, yeah? But then, the next question for you, Pimenta, watch this. Watch a master doing this. Pimenta, will you do lateral on this case? Absolutely. There you go. I will do it, 100%. Why, Nima? Why we tackle this case, having a transitional psoas?
Because you can retract it posteriorly.
Oh, it's easier. It's an easier answer. because the vessels are not on the way, you know?
Okay, fair.
As long as the vessel not on the way, the patient deserves a shot, you know, unless it's something very weird, you know? So these cases, for example, this case, I will tackle it also, you know? You just go anterior, you know, you go kneel strict, you know, you go there on the front, you move here, not correct, Neil? Would you get scared on this one? Nah, you know?
You can do this, because only the aorta is split. The IVC is still lateral to the aorta, or medial, or whatever, to the aorta, so you can do it. The one you need to worry about, I will do 2 cuts below this though, because the IVC is gonna sneak underneath the left common iliac. If it does, I wouldn't do it.
Yeah.
You take 1 millimeter cut down below that, it starts sneaking below it.
Yeah. Okay, now let's go to the next one. Take a look at this one. This one is very interesting, okay? This one has because when you look at the that much slope on L4, on L5, you know also this patient is having, you know, the pelvic incidence is gonna be higher, something is running here. This is another possible transitional level. Why? You see it's like a 5-6. And take a look at this one. This one is more interesting, okay? You see where the psoas of this one were the vessels? So why? So when you have this patient in the clinic, you start like this, okay? Where is the lumbar plexus? Somewhere around here, you know? He's taking a lot of my thing. Okay, next step, where are the freaking vessels? Right. Boom. Do I have a shot in here? Well, it's a tough one, yeah? So this one, I wouldn't do it, you know? Because you're looking here, it's a totally different than this one, yeah? You see the vessels on this one? Take a look at the vessels on that one. This is really taking off. The psoas is way far. I don't know, Neil, will you give a shot in here?
No.
There you go. So see, Neil is a pre-psoas guy. The thing is that even the pre-psoas corridor is scary. So this is what you do in the clinic. Your only job is this, find out this. This patient to me is an A-leaf. To Chapman is a T-leaf, yeah? You do T-leaves a lot, more than, yeah, this will be a T-leaf, yeah? So for Chapman it's easy. He said, these guys are stupid. I don't even look at that, you know? I don't need that thing, you know? Why they spending too much time talking about shit that I not even look at, yeah? Isn't that right? That's what you're thinking right now. In German, I don't know how you say bullshit in German. How you say
Nicht
bullshit in German?
operieren, don't operate. That's what I'd say here.
That's funny. Okay, so that's very important, okay? Okay, so now the side of the approach. And this is something, you know, Neil and we always discuss convex, concave, you know. And I think, to be honest, it's not a perfect choice. Neil has a really good way doing on the convex side. You like convex, correct? I love concave because what I show you, but
I only go left, so it doesn't matter what it is.
No?
Only left, doesn't matter what it is.
Yeah, but you know, because it's an O-leafer. Because it's an O-leafer. You look at my notes, it's so funny, we published a paper or not? We look at all my laterals since I started my tenure at BNI, 8 years. 60% of them are right side. Why? Who knows what? But it's right side. You know, I don't know who's putting that paper. It was not you putting it? Somebody's putting that paper. So very interesting. I do more right side approach than the left side. That's one of the issues with the O-leafers. The O-leafers, the right is complicated. Have you done a right O-leaf? I'm sure that you done it.
You should never do a pre-psoas from the right if someone's doing it.
Okay, there you go. And
Do
he's the
not
king of the
ever do
pre-psoas.
it. 2, you absolutely can correct it if there's concave or convex. It makes no difference
Seems like the
whatsoever.
O-leafer don't do that. For us, transpsoas, we just, whatever, we just go by this. Watch. So this is the same case, okay? Look at the X-ray. So he has a previous surgery, you have to ask the patient, hey, listen, how you have diverticulitis, you have any color resection? That's another, you know, free avoidance of bowel injuries, you know, or kidneys. Have you, sometimes, how many times I have to yell at the fellow? I get into a room, I talk to the patient, he's like, yeah, I had this kidney removed. I say, you kidding me? You never told me that the patient has no, you know, patient with a nephrectomy, you got that retroperitoneum, it's like you're getting through a jungle, you know? Why are you gonna, you know, boil yourself when you have a virgin side on the other one, you know? So make sure that you have no previous surgery. To me, that's the first one, that's the deal breaker. Whatever is the previous surgery, I go from the other side, no matter what. Okay, second is the iliac crest, you know? So why the iliac crest? Because the iliac crest normally, you know, gets in your way. If you find a way that one is higher than the other one, you can choose the lower one is better, okay? How is the end plate, the angle of the end plate. So in this case, to me, 4-5, I will go easier from that one. Just imagine going from the other side, yeah? So that's what tell me the side to me. What is the end plate angle? And they go from there. So most of the time, put me in the concave side. It's not because I say I like the concave. I just like whoever give me a shot to 4-5, I build from there, you know? Neil, how you do 4-5 when you have like this on the convex?
Left, pre-Psoas, you absolutely get in, provided the vessels are.
Because you go
It's a very, very different technique. If you're going trans, you're not going with that. If you're going, it's very hard to explain it. If you're going trans-psoas, absolutely that's in the way. But if you go in front of the psoas, the iliac crest dips. You actually have room to get in there, provided the vessels are going to let you get in. It's never a problem. We don't look at the crest anymore. It's very hard for any trans-psoas person to understand because you're going orthogonal. We are not going orthogonal, so you can access it.
Yeah.
Very easy.
Okay, that's good. That's a good point. But you know, for us trans-psoas guys, I just follow 4-5. Whatever give me a shot, then I obviously look at the MRI and that. But then at the end, this is important, you know, and I was furious with these guys. You know, there is a I call the dissidents group of the invasive guys. So it's you know, when we build all the lateral invasive, yeah, there was one big core that was like the big players were like Bill Taylor, Pimenta, Bill Smith, Frank Phillips. They were like the starters. They say there was an NFL team, they were the starters, you know. And then there was a tear down that wanted to be there, and they couldn't, you know, they were trying to get in there, and they never made it but they were good guys. So these guys, they, you know, like in life, you have to come with your own thing to see you can make it. So these guys end up saying like that retraction time doesn't matter on lateral. And you know, you see, we have a big discussion on social media the other day. But to be honest, I can tell you, for you to have a good results on this surgery, it's a combination of controlling variables. One is make sure that you are in front of the lumbar plexus. You don't want to be behind it because you don't want to move the plexus when it does. Second, you don't want to retract this nerve forever, you know? If you're a neurosurgeon, you understand why the time is important. When we do like a posterior fossa, when the neurovascular decompressions, if you retract the trigeminal nerve, the facial nerve for a while, the patient is gonna wake up with a deficit. So it's not like time doesn't matter. Obviously, times matter. If you retract the femoral nerve for 2 hours, the patient is gonna have to wake up with just put yourself. I put you the Saturday night palsy. Get drunk, sleep in your arm. How you wake up in the morning. You know, 6 months we are able to do this, yeah? Why? Because you were doing too long pressure on the arm. If you were not drunk, you just moved, you wake up, hey, it's getting numb, you know what's happening, yeah? So it's the same thing. I mean, this is so funny. Everything that we do is common sense, you know? As much as scientific is medicine, it's a lot of common sense, yeah? So, and then obviously the amount of retractor. If you open the retractor like this, great, you see everything, but for the patient it's horrible. So you just need to open the retractor enough that you can put the cage and do your job, yeah? So just work with a smaller footprint that you can do. If you open the retractor, let's say here, you open the retractor more, what are you gonna do here? You're gonna start massaging the segmentary arteries, dealing with things. If you're in L5, for example, I never seen the iliolumbar vein in my life. I never seen it. You know, and every time you do an A-lift at 4-5, the access surgeon has to deal with that vein most of the time, yeah? It's like I ligate and move it. To be honest, I never seen it. I don't know, have you seen it, Nima? I never seen it. Have you seen it, Neil?
On A-lift.
Yeah, but in the A-lift, but not on laterals, you know, when we do it. Why? Because we just go, the iliolumbar is never at the disc space of 4-5, you know, normally it's between, you know? So.
Okay, well, be careful. That again depends on that selection, right? Back to that vascular anatomy. There are guys who try to do a 4-5 when it's already bifurcated. The iliolumbar vein will come out 1 inch below the bifurcation of the left common iliac. So think it's already bifurcated, and someone thinks they can get in, they'll get the iliolumbar vein. It's there. It's very close. Yeah. Because the iliolumbar vein is coming out. So you have to watch that bifurcation. Yeah. It's 1 inch below the bifurcation.
Yeah, and I forget something also to tell you. When you look at the MRI pre-op, look at the sagittal, because unfortunately, somebody mentioned another meeting, why in America the MRI doesn't include the coronal view? They never include that thing. They always put the sagittal. Always find out where the segmentaris goes, and I'm gonna show you because it's one of the complications that I show you. You have to see where are them, okay? So now how I choose lateral, I'm probably gonna go fast over this because we've been talking all day about this. Okay, when I go lateral, in my own practice, in my own experience, probably because I've done a lot of laterals and not as many as prone, so I'm very facile on lateral. This is what I use, lateral position. Basically, these cases, standalone, morbid obese patient. I hate to work with a 160 retractor. It's too much, you're like miles away in prone with that. Nothing better than a morbid obese patient on lateral position. The worst case scenarios are 140, 350-pounder people, 140 retractor, But you did a 300-pounder in prone. What is this length of the retractor? 170? I don't know. You guys have 170s? 180. What's the largest? And people, the young guys that they don't know lateral, they don't have a problem doing it, This is interesting, Again, common sense. We're like animals. Whatever they put you to do it, do get used to, and then you make it work, So young guys that they start lateral on prone, they do better than that. So it's interesting. But in my own book, this is how I play. And then when I go prone, in these situations, yeah? Basically, when I need indirect decompression, when I have a straightforward spondys 1, grade 2, that's beautiful because you just save time, And when you have an adjacent segment failure, to me, that's the best application of as long as you don't go standalone, So it's a really good application of prone. Okay, so let's go to the complication again, okay? So we already talked about some of them. Now we're gonna give you examples of really bad ones, okay? So take a look at this one. Look at the vessels in here. The camera is not the best, but look on the left. Look in here. This is deformity case. These vessels start going into the concavity, And that's why a lot of deformity MIS surgeons, they like to go on the convexity. The good news is that these vessels are not attached to the vertebra, There is a plane. So as long as you understand that you always go from posterior, the axis lateral to anterior, you don't deal with that. But you have to be aware, don't forget, the vessels goes on the concave side. This is what I was talking to a guy. This is my complication. You see this? This is a contralateral psoas hematoma. And I got this. This was an interesting case. I did this case. Case was nice. They didn't have nothing. The patient went home and she kept calling the office complaining of contralateral thigh pain. I'm like, oh, it happens, this patient is so annoying, didn't alone. She started going to the ER, and one of the ER trips, she was start getting now weaker on the contralateral side. She got the MRI, had this hematoma. So I was like, how in the heck you get this on the contralateral side? So in this case, I just want you guys to look careful. This patient, this is a coronal MRI. If you look at the segmentaries, these segmentaries were actually running at the disc level. When I opened this patient contralateral, when they came back, whatever, I drained the hematoma. It was like a, green, like a chronic subdural hematoma type of that blood. At the end, start, bleeding a lot. I just get a Bobby and, like a bipolar and stop it. But that was the segmentary. So it was running at the disc level. This one I learned really bad. Like, you have to look where the segmentaries are, okay? This is another one in here. I just want to here. This is a courtesy from my good friend, Devrin, and I show it a lot. Let's do it from here. Just put it from here, okay? This case is an ACR, And in this one, with the ACR, we used to dissect the anterior longitudinal ligament. You see on the right of your screen is the dissector all the way on the ALL. So the right of the screen is the anterior, posterior is on the left of the screen. So it's already a dissector through and through to the anterior longitudinal ligament. And then what we do is we cut with a knife following the little groove on the dissector, yeah? And then the ALL get released and then you do your hyperlordotic implants, yeah? So you see here, showing that you're just gonna make the cut and sometimes this thing can happen, okay? You see here, cut, boom, Then you have the big blood. Wow. The good thing is this. Is this a big vessel, Pimenta? No. If you hit a real vessel, that retractor will fill out in a second. This case was just flow seal, hold, Patient did good, no problem. Obviously, you had to do a CTA post-op. That's a board question. CTA post-op. Make sure that you don't have a pseudoaneurysm or something. If everything is good, you leave it alone, But this case is very clear. It was probably, who knows, a aberrant segment, who knows, a branch of something, but it was not. But things can happen, and you have to be careful. Don't forget, every time you do laterals, no matter what, you keep your blood in the room or close by. You need to know where your things are, and you cannot crazy start calling vascular surgeon, because you call them, the first thing that they do is they open up this guy through and through. They make holes, and now they make real holes on the vessels. And then they end up doing the same thing. They just put pressure on it, which is funny, And don't forget, the people, all these guys with the Da Vinci, when they do the GI and the GU guys, when they have a vascular injury with the Da Vinci, you know what they do? They just park one of the arms like this on the vessel, and they wait. And most of them, they get away with that. So a lot of the vessel injuries can be handled, just not to panic, You just pack it, wait. Ask the anesthesiologist if the patient is stable, make sure that it's not bleeding to the abdomen. If the patient is stable, wait 10 minutes, close the retractor, wait, take it out, it's dry, just call it, Not right, Mil?
Yeah, one was saying that actually those vessels, there are a lot of patients have transverse vessels across the disc. It's part of the anterior longitudinal venous plexus. It's there. It actually goes across. Some are more than others. That'll bleed. Just to a bipolar, like you just said, most of them are venous, they stop. Very rarely it's ever arterial. You can have arterial also going transverse, connecting the segmentals. It's very rare. It goes across the disc. But you can see it. If you see it, just take it. Usually just take it. I've only taken it twice. You see it. When you do pre-Psoas, you see it. But it's there. Some people have it.
And sometimes it's happening. I'm having this near-death experience. Everything comes to your mind. You know how it is. You guys are surgeons. Everything, you just, in that minute, in that second, everything goes up and down in your body. You're like, fuck, the world comes to an end. All of you guys have this feeling, because we always have something like that. And you're like, I just can't believe it. And now it's me, I'm the one having this. So anyway, so the second one, this is very important on lateral, because if you rely on direct decompression, subsidence is your worst enemy. And it's not a very complicated complication, but actually damage your outcomes. Why? Because the patient, only lasts 6 weeks good, because after 6 weeks, they call back with the same radiculopathy and a lot of pain, and you end up doing laminectomies, So how you prevent subsidence? So subsidence is a combination of it's a multifactorial condition. One is bone density. You don't want to fuse someone. It's another thing. You're a lateral surgeon. You must better know exactly what is your bone density, You need to figure it out because you're doing osteoporotic patient. Don't mess around with indirect decompression, because you're going to lose it, So bone density is very important. Okay, what is the preoperative disc height? And this is a big, big deal. This case that you see there, I like to put it, it's not my case, because these cages are what, Medtronic cages? I think they're Medtronic cages. Is it correct, Neil? That's the Medtronic peak cages.
All
I think they're
Medtronic, 0
Medtronic.
degrees.
Looks like. So anyway, it doesn't matter, the Medtronic or whatever, but the problem is, you see they subside. You know why they subside? They oversize the implants. That implants are at least 14, 12 or 14 millimeters height. And the thing is this, if you start, take a look at that yellow and the green line that I put there. If you start with a space that is 4 millimeters, 8 cage, you are really giving 100% restoration of this height. You don't need to do that. You ask me what are the sizes of the cages that I use. Most of them are 10 and 8 on the invasive numbers. On the Alpha Tech days are 6 and 4. But what you have to do is on the posterior one, you don't want to gain more than double than what you have. So it's very important to know where you started. And it's not the one that you measure in the OR. It's the one that you measure pre-op, like on the X-ray pre-op, because the patient is standing. So that's why a lot of people can do really good with small cages. And then in the long term, it's good for you because it will not subside, 12 and 14 cages looks beautiful on intra-op, but then, you will pay your dues. And at some point, I was telling these guys on the industry, you guys should take the 14 cages and the 12 cages out of the trays, just for a special occasion. Maybe that way you educate the surgeons on that. And the problem is all of us, we come from the T-leaf world and PLIF world, where the higher you put the freaking cages, the better, yeah? And what are the height of the T-leaf cages? 12, 10, 12, Dr. Chapman, what is your cages lately? They're becoming really, it doesn't matter because they're doing direct decompression, What is the height of a T-leaf cage that you guys use?
17 to 19 millimeters.
You see that, yeah? So when you migrate from T-leafer to a lateral, you say, I have to keep using the same, similar height. So, and the problem is you complete the cages, you're gonna get subsidence, yeah? Okay, the other one is the implant preparation also is super important, That's one of the problems with navigation, when you're doing navigation, what you see is not what you have, because unless you do a real-time always spin on the first level, the second level, who knows what's gonna happen. So you have to be very careful. I learned from the Olive guy, from the navigation guys, and I've been using it because I'm doing more navigation. I've learned from the Paul Park. You have to have this feeling that you be very gentle with the end place. I don't know, Martin, you do that. You get into this space because what you see in the navigation is not, you have to work gentle because the end plates are sacred. If you violate the end plates, it doesn't matter what case you put, it will have subsidence, And I can tell you, subsidence is one of the worst. And then, obviously, as I just mentioned, the width and the height. The wider the implant, the less chances of subsidence. But the problem is sometimes you don't have a good shot. Pimenta we used to put 26 on everybody. I'm using more 22 cages. I don't know, what sizes are you using lately? Neil, what are you using? 22s?
18.
18, see that? What are you using?
For 19 years.
Yeah, I use 22s. What about you, Pimenta, nowadays? Yeah, no 26 anymore?
Well, if you do supplementation posture, you don't need the
Yeah.
26. The idea of the
Exactly.
cage was for step
Yeah, what are you using, Nima? What are you using?
22.
22s. What about you, Nima?
2022.
Yeah, 22s.
2 weeks ago, I put an 18 time.
Yeah, I use 18 when I have like a transitional level. I'm working too much anterior. The numbers on the monitor are very low. I need to, move out, then I go smaller. But I'm trying to put a 22. And then obviously, pedicle screws are something that helps you against subsidence. Yeah. Why? Because they share the load. So when you do a standalones, you know that you're putting way more risk of subsidence, So in standalone, you have to be extra careful on everything else, That's the good thing of the pedicle screw. They just share the load, it just decrease the load on that, okay? This is a good example of subsidence. You see, this is a nightmare. You see how we go. This one is like oversized. You're kidding me, So it's crazy, Then this is the ideal thing, You should put something clean and nice and don't bother that, okay? So this is a good case because I want you to see it. This is an old image, it was from Bill Smith. Someone gave it to me as a gift before he retired. But this is very interesting. So this is when we were trying to learn at the beginning lateral. You get an ALL, and the problem is when you cut the ALL and you don't know that you cut it, or at that time when you cut it and you know what's going on, you're trying to think that with the pedicle screw you get safe. And this case was very clear. You see what happened, This cage vomit, it went into the peritoneum very easily, So this is the only time that you should use something attached to the cages, Every time you put a cage and the cage goes so easy, I promise you have an ALL rupture. Like you showed today, ALL and unintentional ACR. That cases you have to have a cage with ears, or a plate attached to the cage. Otherwise, you're taking a lot of risk. This cage can go, and then it's a nightmare. Revising that thing, I can imagine. It's a torture, yeah. So you see here, when you do ACRs, you hold the cages with that, Okay, why we don't like plates? Because of this, I saw you that coronal fracture. This is a nightmare, that coronal fracture is a nightmare, and the answer is because between the cage and the screw, this area, that's a raising stress area, and then it split the vertebrae in half. That's what happened with the plates, and that's why, to be honest, I'm trying every time I can. I don't use it. We have some techniques to prevent it, like using here. Make sure that you're bicortical, that you were straight, a bunch of things. But to be honest, since I left the plates, I like it because I don't need to babysit this thing anymore, I just make sure that the cage has to pass the midline, because the cage likes to go to the less resistant pathway that is the insertion. Yeah, you see here, even with the screw, they come out, yeah? So you see this one. This one has the screws and everything, still the cage come out, So it's not like it's 100% your guarantee, okay? The next one, this is a very good one, Pseudo hernia, it happens a lot. When you're working at L1, L2 thoracolumbar junction, this thing happens a lot. Patients hate it. Unfortunately, it's only a cosmetic thing, and nothing. And they end up in general surgeons and this and that, and this is really doesn't matter, A lot of patients recover after 1 year and a half or something, but it happens, okay? So I'm gonna show you here on this little video how you prevent that pseudo hernias, okay? And that pseudo hernias happens is at the time of your dissection of the abdominal wall, And you see here, you have this small, and the interesting thing is it doesn't matter where you are. You can be doing 4-5 and you can have the pseudo hernias because the abdominal wall is innervated by 3 nerves, the ilioinguinal, the iliohypogastric, or the subcostal nerve. And most of the time, one of them is the one who really deals with. If you injure that one, then you have the deficit. You see here, it's just showing how you start dissecting, first. We're trying to make an example in here how you make a good dissection. So you have the external oblique first. You can follow on the insert each muscle. So you see, once you get to external, you go to internal oblique. Then that white thing is the transverse fascia. You see how you poke through it, and then you see fat again. Then that's your retroperitoneum, yeah? So you do that all the time, I promise you. If you find a nerve, you move around, and then you don't have the injury. So that's very important. Make sure that you don't do that. You don't want to go with the bobby and get through it, or very, yes, sir.
What about when you do lateral retropleural for thoracic disc at like a low thoracic? How do you? Because that doesn't involve like the same kind of
the subcostal
blunt dissection.
The subcostal.
But do you do?
That one, no, that one you find the nerves and you move it, but then the pseudo hernias on that cases is because of you retracted the nerve for too long. Sometimes you even burn the nerve,
Okay.
And it happens a lot unfortunately on the thoracic disc happens a lot. Patients, you have to consent them, you may have this. Okay, now the mothership of the complication of lateral. This is our flagship complication, the lumbar plexus injury to close this talk. So this is the unique complication on lateral, the one that really block all the adoption of lateral. If we didn't have femoral nerve injuries, every surgeon will do lateral. I promise you, everybody will do it, So few of them, they were afraid of the colon, but this is the unique complication. So what's this case? This is a cortesis of one of my friends, but I like it because I follow this patient so close and I learn too much. I'm gonna show you what you see. So this is a patient, they decided to do 4-5. You see perfect psoas, perfect vessels, everything was good on this guy, yeah? This guy wake up with a horrible lumbar plexus injury. And this guy was a taekwondo, whatever, karate teacher, very loose shape, you will see on the videos, and he was so frustrated. So that's what he did, he put a lateral cage, as he put up a cage, and then he fixed it with screws, Doesn't look too posterior, doesn't look too anterior, doesn't look too bad. This was the CT after that, because once he got the deficit, he did a CT, he did everything on it. So this is the CT, doesn't look too bad, to be honest. The cage is in a good position, the screws are okay. I don't know, you find any problem there, Neil, or I don't find a problem there, yeah?
I mean, you're not gonna see it here.
Yeah, so the question is why this patient wake up? I was like, so the patient was sent to me, like, listen, can you help us out? Well, what can we do with this patient? So I said, well, let me see the MRI post-op. And you're looking here, the answer is basically right there. You see the answer in here, yeah? This guy actually never went transpsoas. Watch, this is the track. This was an early MRI after the deficit. The track is from here. So basically he went probably behind the plexus, behind the femoral nerve, and he moved forward, If we were going transpsoas, anterior to the plexus will be here or through here, something else, but not through here, yeah? So that's probably what happened on this guy. And I'm gonna show you, you see here, it looks very clear, the difference. You see what the cage is and what is the hyperintensity. So I think that was the answer on this one. So in that case is, instead of being there in front of the femoral nerve, you see what that dissector is? This guy was probably right here, And he opened the retractor. Just imagine the deficit. You open the retractor against everything, you know? It's hard to become clean out of that one, yeah? So sometimes you get in here, this is a hard one to get between the exiting root and behind the femoral nerve. That's another good deficit. So don't forget, you want to be anterior, and that's why it's so important to have a good directionality. You want to be like that, you know, in front of the femoral nerve, no matter what technique you use, but you always have to be in front of the plexus. And this is the guy, this is the deficit that he has, but I want to show you videos, okay? This is the first video at 4 months post-op, so see what happened when I saw the guy. So the guy came, I was like, okay, do some hip flexion. He can do some hip flexion, the psoas was okay. And then I said, okay, try to extend the right knee. So the left one, very good. And take a look. So it's nothing on the adduction, also on the right. Take a look. The right side has nothing. You see that? Even obturator was affected in here. So it has no abduction of the right leg and no knee extension on that. That's a 4 months, okay? Then 9 months, you come back, okay? Take a look on 5 months, what happened. And this is something for you guys if you have this deficit, because you're gonna have a deficit no matter what. Take a look how good it is right now. The hip flexion is good, but still, you know, good hip flexion. Now, left knee extension, nothing on the right. You see that? He's trying, nothing. But now he has some obturator. You see the atrophy of the quad, but he gets some obturator. Now he's showing his sensory deficit. It's classic, watch. Exactly, it's like an anatomy book. The trajectory of all the femoral nerve sensory branches. You see that? The saphenous nerve, all the way there, in the cap of the knee, all the anterior, that. You know, this is like when you're doing SSCPs right now, the safe up thing, it's perfect. You know, this is how you stimulate it, okay? So at 9 months, he recovered some obturator. The hip was really good, but nothing on the femoral nerve. And what's this? This is against most of what we learned from Dr. Klein and all these people that teach us about peripheral nerve injuries. What this? 14 months is when you say, like, listen, you don't recover by the first year, you don't recover anymore. Take a look at this guy at 14 months. This is very encouraging. You see that? What's that? Magic. Now the guy, full knee extension, yeah? So he recovered everything, obturator. He just, you know, the neuropraxia is almost gone. You see that? So it took 14 months for this guy to really get the function back. Now still say how the numbness is. He still have the numbness. You see that? And then it's a little bit smaller, but still had the number. But at least the motor function came back really good. So this was sort of really bad neuropraxia, and it happens there, okay? One more before you guys fall asleep. This is another deficit. This is a mine one. This is from me. So you see this guy, I was trying to do, this one was like a multi-level, so I was trying to do an ACR and 4-5, all these things. So I did the ACR in 4-5. You see, this is the case. I was like, I'm gonna do a 4-5 ACR and multiple levels and that. And then I did the 4-5 ACR as a first stage, and then I was going, you know, later on the next level. So this guy, I put the cage, I cut the ligament, the surgery was actually good. And this is the immediately post-op MRI. This is the post-op MRI. I don't see, you know, like I was not posterior like the other guy. It seemed like I was going through the psoas. And you're looking here, and then this guy, then this is the second level that was okay. And then watch this guy. Why 8 weeks post-op? What is the initial one? Okay, watch. This is when he was still in the hospital. The video is not the best quality, but I want you to see. Okay? So this is this guy. Take a look how he was that. They were saying like, can you extend the right knee? And then.
Can you do it with your left leg? Left leg, sure.
Can do anything.
And then straight it out?
Left,
Okay.
right,
Nothing.
left. And then he's showing the numbness, you know? Exactly like the other patient. Same trajectory, femoral nerve, and with the knee, you see with the classic patient is like I just cannot move it, and then they walk the toes and they trying to extend the knee with you, you know, that what he was doing on there, you know? And this is horrible, you know, when you're a lateral surgeon, like, oh my God, I did everything right, what did I do wrong? And then take a look at this one was great. This one was a less The neuropraxia was less. It was just demyelinization. Yeah.
2 months ago. On your right leg, can you flex your hip?
Yes. Okay, so is that what the leg affected?
Now can you straight out your leg?
Yes. Okay, take a look. Nice, you improve at 6 weeks. This one was just neuropraxia, that's demyelinization of the nerve, and in 6 weeks, normally the myelin comes back, different than the other guy. The other one was deeper. So you have to learn, all these things. So this is basically the aftermath, No matter what, when you do these cases, you need to learn this. Where are these nerves? Where are the distribution? You have to be honest with your exam and see what the problem is, And then how did you injure the nerve? Did you hit it with the cup or was just a retraction? When it's indirect, that is just retraction and that, there is a lot of potential for recovery. But if you hit it with the cup or with something, forget it, man. You're done. It's like a stab wound injury. It did not get better, yeah? And then you always have to do an MRI on this patient immediately because you have to rule out this, Sometimes there is something that you can fix, like a hematoma, you still can go and evacuate it. So you cannot let this guy go home without the MRI. You do an MRI, make sure that you have something that you can see, And then everybody has to have an EMG at 6 weeks post-op. Don't do it right away, you're gonna get nothing. At 6 weeks post-op, you will have some changes, And you can discriminate if it is neuropraxia, axonotomesis, or neurotomesis. So at 6 weeks, you can have an idea how bad was the injury for real, yeah? If it hasn't recovered. Again, this is the different injuries, One injury is just this one, like the second patient, just a myelin disruption. When another injury is this one, the nerve gets ruptured, but still there is something connecting. And the last one is the whole thing out, which this one will never recover, So you need to learn which one is it. And very important for medical legal reasons, because you need to be able to consent the patient and say, you will get better, you will not get better. So we put this paper together with Vivas and our neurophysiologists. I recommend you to read this paper because it's like the manual. What you can do when you have a deficit, what you tell the patient and what you don't tell them, It's a really important paper, I was thinking it was having more impact. The lawyers love it, But to be honest, it's very good because it has all the examples, when to do and not to do. And at the end, don't forget, it's all about controlling these variables. Time, direction, and direction. You do that, I promise you can have a really good ride. Okay, guys, I don't bother you more, so thank you for your attention. Any questions or something?
Yeah, I wanted to ask about.
Yes, sir.
What Dr. Iman talked about. I saw this before recently too, basically a longitudinal, it looked like an iliolumbar vessel that was running straight through the psoas muscle over the disc space. A couple consecutive levels. Actually, I had planned a multilevel lateral perk and changed it to an open because I had seen that. Is that something that's safe to approach from a trans-psoas approach? I just worried about not seeing it and evulsing it or something. I mean, it's a good sized vessel. It's the size of an iliolumbar. It just was in the psoas.
Yeah, the iliolumbar is a big vein.
But
The iliolumbar is very big.
It's a big vein, and
the
iliolumbar is a connector vein. It's a big one.
What level did you see it?
That should be something else.
Psoas, mid-body.
No, maybe, no, but don't forget.
It's not rotational form because usually
It was a scoliosis.
When you have rotational deformity and you think that you are straight perpendicular, but you are angled from.
But it was running perpendicular to the segment.
But Zach, there are patients who do have transverse vessels connecting the segmentals. It's anterior longitudinal venous plexus. It's well described, it's there. But iliolumbar specific only for 4-5. It can't be anywhere else.
It's the wrong word, but there's a long.
Yeah, it's a transverse vessel. It actually connects. It connects. It's anterior longitudinal venous plexus that does exist. Not a lot of people have it, but yes, that's why sometimes you can get a hematoma. You get psoas hematomas. You do get some bleeding. You can use a bipolar. Just take a bipolar down and take it down. I've seen it.
Still approach that trans-psoas, because I got some differing opinions. Basically, some people say, yeah, just.
I'm gonna let the trans-psoas kings answer that. Well, I don't do trans-psoas.
Depending on the size, it's a big blue thing. If it's a big blue thing and you can dissect it and isolate it, you burn it and keep going, it's a vessel at the end. The thing is, don't forget, the venous, this is a vein, there is nothing more inconsistent than the venous anatomy, and veins show everywhere, So that's why it's so important, make sure that you always, what I will do in that case, I will look at the MRI right away, make sure there is some flow void or something that I didn't miss on that, where is it coming from or something. But the best way is to abort it, you're safe, you never know, but make sure, normally the big vessel, when you see it on the A-leaf or whatever, it's big blues, man. These
But if you
things are
see
like-
it's just bipolar,
These things are
if you,
dark and
let's
huge,
say theoretically you get it.
These vessels are
You'll still
huge.
be able to pack it in bipolar. It doesn't go anywhere. It doesn't retract, it just goes around like this. You'll be able to get a bipolar and get it clean.
Yeah.
Same in case you do.
A vein that you can see in the middle of the retractor, one side to the other one, that's an easy to bipolar, because normally that veins end up nothing. Like veins are.
My concern was not seeing it on the way in and then tearing it when I opened my retractor.
Yeah, no, obviously, yeah, you're right. No, but no, you cannot burn it and cut it. That's a problem. That happens a lot when we do thoracic discs. I always deal with segmentary vessels. It's better when they're too much in your way, I cut them right away. But that ones come like this. They always come like this. Segmentaries always come like this, looking for the foramens. But this one, who knows? There's a lot of things that can happen there. That's what I always say. I'm so happy that I do the dissection blunt, because I don't want to see what is there. It's so scary. When you do that thing open, oh my God, everything looks big, everything looks scary, everything looks like the colon, everything looks like the kidney, I prefer not to see them,
I love the psoas because presumably there's not vessels inside.
Yeah, the
So
psoas is safe, it's a
you can
muscle.
See a vessel running right through it.
Yeah. And who knows, maybe something, who knows? There's a lot of anatomical variations, So.
All right, guys, let's keep moving along. So we're gonna have Martin Pham now tell us how not to have any of these complications and go do Olaf.
All right, thanks. So when and how to utilize pops on the screen. Yeah, Ben will figure it out.
Personalized approach to thoracic is not an algorithm, okay? So don't think it's an algorithm, just like a framework. I know, I hate the algorithm. It's not an algorithm. It's like an urgent neurological deficit, and you go posterior.
Oh, that's what it is. All right. Just needed your magic fingers. All right. So I'm going to talk about OLIF, when and how to utilize the OLIF. And for a conference like this, I always like to put things in perspective, right? This is a picture from the Untouchables. And when we talk about either OLIF, XLIF, prone, transpsoas, lateral ALIF, they're all sort of part of the same family, right? All part of the same team here, I think. And especially when we're here at a lateral course. And again, to put it in perspective, oftentimes I'll discuss, well, when you have interbodies, you can do anterior, you can do posterior, or you can do all of these things in lateral. And then all of those things in lateral are really just cousins of each other, and there are nuances between them. But ultimately, like Juan said, you end up in the same space. It's just the nuances of how you get there. So for the OLIF, it was originally branded as an oblique lateral interbody fusion. This is the Medtronic trademark. Over time, it's also known as oblique lumbar interbody fusion, anterior to psoas approach, ATP, pre-psoas approach. Ultimately, in reality, it is an oblique anterior psoas approach, right? And I make that distinction because initially when I was learning it and when it was done probably a little bit ago, you have this diagram where you measure the distance from the vessels to the psoas, right? And people mistakenly thought that this was the corridor, right? But this is not the corridor. The corridor is through the anterior psoas. So if you take some of those fibers, that's okay, because what makes the difference is you're not going directly transpsoas and you're much further away from the lumbar plexus. And so in that way, I always just take a look at where that cage is gonna go, wherever that anterior cage is, that's essentially where I dock my first dilator. And so when you take a look at some of these diagrams that you may see from the brochures, as close as you can get is pretty much the ideal, especially when you're at 4-5. You want to hug that crest as close as you can get. And so although this cone is possible, right, depending on where you're going, this is still going to get you the best trajectory for your approach, even if you're not directly trans-psoas orthogonally anymore. And again, you take a look at something like this in the brochure, I'm like, I don't want to do an open surgery like this. But OLIF surgery is still very small, right? So although the initial descriptions, you can put in like a renal vein retractor and open everything up, these are getting smaller. And in a modern sense, this is still a minimally invasive surgery. Now, the title of this talk is when and how to utilize the OLIF, so when and how, but I do want to spend a few slides on why, right? And so for my few slides on why, the reasons why I do OLIF are, one, you get consistent and dependable access to L4-5, right? Essentially every level, like Neil said, and pretty much everyone says, we don't really look at the crest anymore. And for an OLIF, I never look at the crest because I'm always in front of it, right? And so in that way, it doesn't matter. The second reason, it's the single position ability to do a 5-1 lateral ALIF. So I still am in lateral decubitus because if I have to do 5-1, I can put in a lateral ALIF cage. And we know that ALIF cages are the king of interbodies. And so that's certainly a preference. And then as I showed in my prior case, this also allows me to do 1-to-1 in a single stage. So if I'm doing multiple interbodies, I'm not doing an ALIF and then doing lateral and then doing prone. It's all in lateral position. And so for these reasons, the OLIF, although if you look at it as a single interbody, you can do lots of different options. This is an avenue to do things like 4-5 at every level, single position at 5-1, and then MIS deformity from 1-to-1. And so that means that, although we've been talking about single levels at 4-5, that also means that I can do a 3-to-1, where I'm doing, interbodies at 3-4-4-5 and a lateral ALIF at 5-1, and then naturally the case I showed earlier, where I'm doing 1-to-1. And so this is why I stay in lateral decubitus with the OLIF as the main workhorse of much of what I do. Now, when to do the OLIF, and this was actually touched upon pretty briefly, but it's all about patient selection. L1 to 4, you can do, anytime, right? Any lateral position you want, that's totally fine. But at 4-5, you do want to confirm the vessel anatomy on MRI. And really what this involves is identifying those great vessels and that vessel to psoas distance. So here's an example, right? You have vein, artery, artery, and then here's that vessel to psoas distance. And the thing is, at the OLIF approach, it's still through an oblique anterior psoas fiber corridor, but the reasons why you have that distance is you want to give yourself some room for error in case it's your first time or you're just unsure of where you are. Right, same thing here. You have vein, artery, that anterior distance between the vessel and the psoas. Right, this is the trajectory. Very safe corridor. Another example, right? You have vein, artery, artery, and then this is, essentially where I would put that first pin on the retractor. Where you start to get, into potential issues is say something like this. You have your vein, your artery. You start to have that bifurcation and say, this is your trajectory for the oblique approach, but what if you're a little bit off, right? And so this is where you start to get into an area where if this is your first few cases, you may not necessarily want to do it. I still did this case. The artery is a thick-walled vessel. You put your finger in there, you feel it, you put your retractor behind that, but still something to consider. Again, something like this, and this is what Neil had referred to. You have the two veins, you have the artery. This is technically your corridor, but what if you're off and now the vein is behind the artery, right? So here, even if you feel the artery, if you injure that vein, it would be a very, very bad day for you in that particular case. And then the last example here, again, you have the vein at the bifurcation, you have the artery, right? Here's your approach, but if you're a little bit off, then this is what you see. Now, again, I did this case still, and this is what it looks like, right? So when you're coming down on a vessel, I shallow dock, and then I open. And again, by this time, I'd been doing OLIS for like probably a year or two already, so I was comfortable. But in this way, this is what the vein looks like, but the disc is right behind the psoas there. So the vein is seen, it's protected, I push that psoas back, you can see the disc space, and then you do your discectomy. So all of this is still possible, but naturally, you sort of have to be all in on OLIF to be comfortable in doing this. And for me, I dislike doing T-lifts enough where I would rather do this because this is the cage that I get, right? So I'm not as talented as Dr. Chapman, but through a lateral approach, this is the cage I was able to do while still protecting that vessel anatomy as long as you're aware of what you're looking at. So again, ultimately, for patient selection, it's all about the vessel anatomy. Again, L1 to 4, you can do it any time. The vessels are so far away. But at 4 or 5, especially if you're starting out, just give yourself some room. And this is the corridor, essentially, for what an OLIF approach would be, as opposed to, say, something more direct through a direct transpsoas approach. So how do you do this? Again, it's always nice to talk through a case. So here's a 61-year-old female coming in, back pain, right leg pain. She can only stand for a few minutes before she has her symptoms, failed conservative measures, neuro intact. And you can see here, the 4-5 spondy. For the people who go direct, right, here's the crest. But again, I don't look at the crest anymore unless there's a transitional anatomy where that's buried deep far down. Here's her MRI, and naturally you can see here the top-down stenosis on her right side. So for her, 61-year-old coming in with the degen spondy, and my plan, again, single position 4-5 OLIF. And this is the positioning. So she's positioned, again, for me on a flat Jackson, back all the way to the edge of the table again. It's a robot-assisted case, so I do have navigation for the procedure. And this is how I think about, in terms of that approach, right? Here's the vein, here's the artery, here's the psoas, right? Here's that anterior blood vessel, the psoas distance. And again, this is not where you go, right? When they used to call it anterior to psoas, people would think you go anterior to the psoas, but this doesn't make sense, right? The actual approach is essentially, I draw where I want that cage to be, and then that's where I dock my first dilator, and then everything else is pushed back posteriorly. So the tractor goes here, and then that psoas is reflected posteriorly, and you just work all underneath the psoas to get in that cage. Naturally, you always want to look at the vein on the other side to make sure that the vessels are clear. And this is what that view is like, right? So you can see here the psoas is being pushed posteriorly. You have L4, you have L5, and then you do your discectomy, right? And again, as you can see, the discectomy goes from the front corner, and then I will cut all the way back posteriorly behind that psoas as far as I need to go to have a very wide annulotomy. And how I do this, I mentioned this earlier, my residents always know, KCP, KCT, those are the 6 instruments I use, knife, cop, pituitary, keratin, curettes, and you go straight to a trial. And again, here's that thoracoscopy showing the cage going from an AP, and then from the lateral. And once that goes in, you can see as the retractor comes out, sort of the healthy appearing psoas muscle as it comes on out, right? So you can see the psoas was initially pushed posteriorly, and then it comes just right back out, back into position. And then, of course, you have the final X-ray, small incision, like all lateral surgeries are, small incision posteriorly, and then, again, good correction from her spondy. So ultimately, this is the idea, right? So as opposed to coming directly orthogonal, you are slightly oblique. The analogy that everyone always uses, I use this as well, think of an ACDF, right? ACDF, we do that like day in, day out. It's an oblique approach to the cervical spine. The OLIF is the same. And again, it's not anterior to the psoas per se in that space. It's not directly lateral, but you are going at the anterior psoas to get to that space. So in conclusion, when you do it, you want to always check the MRI for the great vessel anatomy. How you do it, I aim for that anterior psoas border, right, wherever you place your cage. And then why I do it, you get all the L4-5 levels. I can do single position with a 5-1 lateral ALIF, and then I can do MIS deformity in that single first stage, going from top down. Ultimately, you're at a lateral course, so the benefits are you get to hear and choose on however way you want to access the lateral spine. There are a variety of ways to get there. For me, I chose the OLIF for the reasons that I mentioned, and you really just got to choose what makes the most sense for you, get very good at it, and then learn all the pros and cons. And for me, of course, that was the oblique anterior approach. So, thank you. All right, I guess we can move on to the next one.
Thanks, Martin. As most surgeons are transfers, there'll be no further questions. They'll have,
I actually want to ask, is it hard to learn that anti-Psoas approach? Like in terms of, I feel like I have to be a little bit of like a vascular surgeon, a little bit of like, you know what I mean?
what's the question, Nima?
I'm asking what's the learning curve, learning the anti-Psoas approach? Because I feel like you're dealing with the vessels, you're dealing with the psoas. I'm a little bit scared to take that corridor, to be honest with you. Dealing with the aorta and all that.
I mean, I think the direct trans-psoas approach, the XLIF, I think was a procedure in the spine that was designed very well. It's probably the most straightforward approach, because when I think about it, you know, when I teach, say, ACDF, right, to resident, it's so many steps. You come on down the neck, watch out for the esophagus, watch out for the carotid, you know, you get down the longest, watch out for the sympathetic chain, don't bovie in it. And then you think about the XLIF and you've really narrowed it down to about 6 steps, and it's done very well. I don't think anything can ever compare to the simplicity and beauty of the direct trans-psoas approach. That being said, if you think about the initial way on how you learned how to do an ACDF, that's exactly what the OLIF is. There are certain things that are just slightly different. And really, it's just at 4-5, right? If you're doing anything higher up, it's the same. I just stand in front of the patient. Up at 4-5, even if I dock at the anterior 25%, I look directly down, and all my instruments are straight up and down. So the learning curve is really just if you're doing 4-5, but it's not difficult. You know, it can never be as simple, I think, as a direct trans-psoas, but you probably add, instead of 6 steps, it's maybe 8 or 9. You're just thinking of slightly different things, and you're just still making sure you're going ceiling to floor, but the learning curve is not hard. And, you know, all of my residents know how to approach.
I think the analogy to
Yeah.
Are you breaking the contralateral annulus with all of your instruments?
Correct. So these instruments are 20 and 25 degree angled. So I'll use angled instruments at 4-5 because I'm in front of the crust. So that is, as the instrument goes in, it's essentially this shape. It comes on down and there's a 20 to 25 degree angle, and I will break the contralateral annulus just like in a direct trans-psoas approach. Yeah.
You got a great correction there.
Yeah. And again, so the principles, I mean, to that point, the principles are still the same. You show this, no one would be able to tell if this was a direct lateral decubitus, OLIF, or PTP. And that's sort of the idea. And the principles of opening up the contralateral annulus, getting good coverage, you know, and getting the correction are all 100% the same. It's just on, you know, how you get there and the number of people you can get there, say at 4-5. I've never used sort of those up and down angled instruments for the iliac crust, right? Because I'm always in front. So it's really, I use angle tools for the front. If you're doing direct trans-psoas, then you may be using sort of the up and down angles to do the same thing.
But you're basically anterior docking, so I wonder if it's more the cage placement or the positioning.
Yeah.
You know, cage placement we know is really important.
Yeah.
So
Yeah.
that's what you want to put it.
Yeah. Yes.
If you're doing a long construct, what do you position the patient on the operative table in the lateral position? More anterior, more posterior, in the middle?
Yes, I mean, so for the positioning, if I'm doing a single position, then I will put them all the way to the back of the bed. So that means when I'm standing, I mean, technically they are slightly further away from me, but I haven't found it too much of an issue, I think.
I don't know, I cancel my lab.
Correct. Yeah, and so in this particular case, the patient is positioned all the way to the back. Now, I will say, you know, this isn't necessarily a single position lateral talk, but the screws that go in, they are always slightly straighter than prone, right? When you look at my screws, they're probably maybe 15 to 18 degrees, right, at max, versus, say, 20 degrees. And so many of those screws will just look straighter due to the limitations of this. And the real thing there is just because they're coming in straighter, you just want to avoid the facet joint at the UIV because it's much easier to accidentally hit it or grab it. But other than that, that's how I mitigate that. I have tried to, you know, just get in that steepest angle, say 20, 25 degree, and it just really is difficult. And I think about, am I really getting a lot of benefit as long as I avoid that cranial joint?
You did that T10 to pelvis single position?
No.
Oh, thank God.
No. The single position was just the 3-to-1. This was just showing an example of why naturally why I do lower.
All right.
So how many centimeters would you like to make your lateral decisions for those screws?
Since I do it robot assisted, I just go where the robot goes at that point. Yeah. I think historically, the teaching, at least prone, is about 4 centimeters off midline, right? Because that's where the joints will be. The times where I've done it navigated, like we do have a trauma hospital that just has navigation and not robotics. In that case, I'll still just use the navigation, and I'll just figure out where it's the most intuitive.
Well, to answer your question, I totally stop. When you use the robot, which I do for a single position, your incision's all over the damn place. So I'd much rather mark it, I'll make my incision, and then use a robot to go down. So it's a clean, beautiful incision. Otherwise, all of it, one here, one there, one there. It looks like so much of now the patient up.
Yeah,
So I've
and-
totally changed from the change it.
Yeah, for that, I'll typically mark, say the cranial and caudal screws,
Just mark it.
and then I'll split the difference, right? Because it all fits in through the same incision. Sometimes I'll pair them, if it's like, say, a 2-to-1 or something like that, but.
Because I usually mark the incision ahead of time before centimeters from the line.
You want, you want to ask if Louise is there?
One incision is like for one side and the other.
Yeah.
Louise, you ready there in the lab? Louise? Dr. Pimento, calling Dr. Pimento. There he is. Okay, now it's coming up on the main screen.
Okay, can you see me? Can you hear
We
me?
can see you on the side screen and hear you, but not on the main screen. It's coming up, coming up. There you are. All right, take it away.
Okay. Can you hear? Well?
Yeah, we can.
Okay. As you know, my name is Luis Pimenta. I have here my good friend
Colin
Colton, and a Brazilian that is helping me to do the procedure. I have a cadaver that has been used in both sides. One side was 4-5, another side was 3-4 on the other side. So I'm doing 2-3 in this case. Do we have image? The image is okay, is okay, I understand. So what I do here, I use the marker tools. Can you give me so here, I see the lateral X-ray. And I'm in L2-3. Can you come a little bit more posterior, more higher? Okay, again, and again. So here I am in over 2-3 on this level. So I mark here the 50-yard line, and then I mark more posteriorly the posterior foraminal point here. And then I extend the line that shows me the direction of the disc. So I think this helps with the retractor to align the retractor in direction of the disc. I forgot to say that I have my cadaver with the head on the right, the legs, if had legs, on the left.
That's opposite.
The head is on your left.
No, it's not. Here's the crest. Come on, touch here. No, you are right, yeah. So here the ribs, here the crest, good that I was corrected. And here I touch and make sure that I can feel the step. And this is the point where the quadratus comes. The quadratus is a muscle that attached to the crest. So, and that point is the best point, safest point to arrive in the retroperitoneal space. So what I do a skin incision, not super small,
and which I did already, preparing for the case to make the case. No, yeah, I will mimic what I did. Basically, I have a line here and another line here, and I do my skin incision from, at least from line to line. Then I do subcutaneous dissection pickup. I do subcutaneous dissection up and down, like we do for cervical, and a little bit anterior. And then I do subcutaneous dissection with the bulvi in real cases. And I go here carefully, but going in direction to this point here, that the border, the lateral border of the quadridos. Once I'm there, I have my finger on the border of the quadridos. I take Metzenbaum. I hold the Metzenbaum. There's a head here. I hold a Metzenbaum 3 fingers from the tip. Follow my left finger. I go posterior, close to the border of the quadridos, and I poke to the retroperitoneal space and open this aggressively. So I'm much more posterior with my left finger, and I reach the posterior aspect of the quadridos in the retroperitoneal space, and the first thing that I find, I can touch the psoas, and I can do all the windshield movements. I can touch the ribs from below, and I can touch the crest from below, knowing that I'm in the retroperitoneal space. Once I have my left finger, and I did a lot of this dissection, the next thing that I do, I hold the retractor with my thumb up, and I use, of course, neural monitoring here. And then I use this parallel to the ground. And through this line that I draw here on the 50-yard line, and then I go against my finger that is already inside the retroperitoneal space, and then I deploy this into the vertebral body and hold this to check where I am. X-ray now, lateral X-ray. I'm very below that X-ray. I'm close but not Can you see X-rays from where you are?
Yes. We can see here.
I know. Okay, X-ray. And X-ray. And X-ray. Small movements, because here everything is amplified. I am over the disc, slightly more posterior would be better. It's very easy to move because of osteophytes. That's why navigation makes sense in case of the first dilator. Oh my God. It's close but not perfect. X-ray. That looks better, at least. So I'm in the disc, X-ray. Not so sure.
Doesn't matter. So I will take the ball here, dilate. I'm more anterior than posterior. In 4-5, I like being more anterior than posterior. In 2-3, I don't care. But then when I place my second dilator, I have my finger again inside the retroperitoneal space that helps to go safe to the psoas muscle, and then do several rotations. And the third one. Can you give me an AP X-ray, make sure that the guide wire is in the disc? AP, please. So in case I'm not sure that the guide wire went to the disc, I go AP and take a shot. Yeah, as I thought, it's not really in the disc. Can you give me something to take the? Yeah. Yes. Can you count the disc? 5, 4, 3, 2, 3, right? Yeah. Okay. So I will try to hold steady here. X-ray. So let's start over. So when you fail, you take everything but the guide wire. In case I can preserve the guide wire, I will go with the finger inside again, place my first dilator. Against my finger again. My finger guides me to the psoas muscle. Come lateral again. Looks better, hopefully is in the disc. X-ray. X-ray. Yeah, looks better now. Can I have the second and the third? So also the second goes against my finger. My finger goes around the dilator to make sure that I don't grab bowel or vessel. And I do the same with the third, using neuromonitoring all the time. And then I see how long I should choose my dilators. In this case is 120. And my finger inside helps to get can you help me with this? To cross the fascia, and then I fix. You can see that the retractor is in a single piece. No, not yet. Good, now. Can you open a little bit? Yeah. So the idea is to follow the line. Yes, close now. So follow the line that I draw. So I will open front and back along the disc. So now, lateral X-ray, please. And I use this tool here to make sure that my retractor will be perpendicular to the disc. We have markers. You can see the two little holes in AP. Now in lateral, you see the triangles. You cannot see the V's, and you see that my retractor is from inferior to posterior. What I do, I hold here. With my left hand, I loose the arm, and I move carefully my retractor up, X-ray, or maybe down. Yeah, that's better, X-ray and X-ray. So the triangles are okay, but still, okay, now I see the V. I hope you can see the V's and the triangles. Looks like I'm a little off of the disc. Can you give me AP X-ray? Again, I don't, it's too much, right?
Do you want to walk the retractor posterior?
I will.
Okay.
Of course. See that my retractor is very anterior, and is the guide wire is correct, so I can work with this. But so I will, first of all, because it's more anterior, what I do, and I want you to look what I'm doing, so I compress the anterior, and then I turn the anterior backwards. 1, 2, 3 clicks probably would be good. A lateral X-ray again. Yeah, so what I have to do here, can you hold I will move very carefully, a little bit angled, X-ray, yeah. Hold this. Yeah, now I'm better over the disc, kind of. And I still, can I have a pen field? So when I'm not sure how anterior I am, I use a pen field on my anterior blade, and take an X-ray, AP X-ray. I feel the ground here, but looks like I'm on the slope. So can you give me a AP X-ray? Yeah, not too bad. X-ray. An X-ray. Okay, so I feel the ground. I will place the lights and use my anterior shim first, because I'm very anterior. Can you raise the table? Yeah, take this. Not sure that we will use this correctly. No, I think it's not filming anything here, is it? It's not upside down? It's not. Is not turned?
Pull it out. Oh. This way?
Move your hand.
I think it's right there.
Yeah,
Yes, that way.
Lab, that's awesome.
yeah, but first I have to place the shim. So I use this shim here, that's a sharp shim in the anterior after I touch the disc. So pay attention that this X-ray. I don't think I'm there yet. So I'm probably more anterior than I thought. I will move backwards. My full retractor, probably.
Do you want the table up more so you can see?
Yeah.
We raise the bed up more.
We're maxed out.
Okay.
Posterior.
Can I check lateral first? Yeah, I will need to change direction here. X-ray. X-ray. An X-ray.
It's mine. Put on everybody's head.
X-ray.
Oh, yeah, I'm seeing my alcohol levels dropping.
An X-ray. Okay.
Rod, what are you doing? What's happening?
Problem is I have a guide wire there.
You need to get a flight back, so let's go tomorrow.
So I have the triangles aligned. I barely can see if I'm there or not. Can I give an AP X-ray? Yeah, I knew it. Yeah, why not? So the shim also is another tool that can help me realign the retractor. So I use my anterior shim X-ray with the AP image. And then what I do, with the shim, I angled X-ray, an X-ray. I find the disc, and then I go inside the disc. Hopefully I'm not too anterior. I'm afraid that I am.
Check a lateral.
Lateral. Yeah, I'm over the disc. Can I open the retractor posteriorly? So I will open more than usually I do in this case. So I open 8 clicks for 22. I open 2 clicks. Can I have a section? I don't think it's doing anything. 2 clicks, ball probe. 2 clicks, ball probe. 2 clicks, ball probe, 6. 2 clicks, ball probe, 8. X-ray. So now I can see the disc from anterior to posterior. Can you bring the table up? Yeah.
So one lesson that what's happening here is in the OR, make sure that before you start, make sure that you see where the table is before you start, because you need to make the table up much more than here. So in this case here, I will turn for my comfort. I know that my retractor is already perpendicular. Can you do the,
You want to rotate before the shift?
more? A little bit more. Can you move the arm? Okay, do a little bit more. So here, give me the suction tube again.
Would you take it? You would?
So can I have so this is, I have the one that is, I have a shim that works with like a pen field that dissect the psoas muscle away. So I clean the disc this way. Not sure that you can see what I'm doing here with this, but I am cleaning the disc, and then I move this light from here to here. Can you help me with this? And then I attach to the posterior blade and go into the disc. And then I take this out. Why the image is not showing? Or maybe this is, can you do this a little bit more angled?
They're gonna move it.
Okay. Can you try to show inside? I don't think
You don't want this, Vision?
No, it's not showing yet.
It's hard to line it up before I didn't know.
Yeah, you have to come as inferior as possible. Yeah, that's better. So you see that, you can see the white tissue there, that is the disc. And then what I have to do here is the discectomy. Can you give me the knife? Yeah, that's pretty good.
So Dr. Pimenta, that looks pretty good. If you don't mind, I think we're gonna go to the next talk, but if you want to finish doing the discectomy, then we'll come back in.
Yeah, this will be discectomy. I don't
Yeah.
think I need to show
No,
discectomy.
I think you're fine. I
I
think,
just want,
yeah,
if you give me 2 minutes,
Sure.
I will do something that is interesting. I will go to the other side and show the retroperitoneal space that probably you never heard this before. I will do a shark bite. Let's finish my role then here, right?
is it going to be as big as want?
Okay, that finished my thing, because can you do this or later after the next talk?
Maybe we'll do it after the next talk.
Okay.
Luis. Great. Thank you so much. That was great. Okay, so our next speaker is Dr. Neil Anand, and he's going to talk about doing deformity surgery and doing minimally invasive approaches for deformity correction. So He's going to show some interesting cases.
Actually, what I'm going to talk about is something called very boring. It's called the pre-Psoas lateral approach. You guys are going to get so bored with all this trans-Psoas talk right now. I don't know what I'm even doing here. But, and if you take it from there and see, I think I've given this talk many times. My apologies if, can I go full screen on this? How do I do this? Corina, can I?
You're good.
Oh, I can't do it. Can I have full here? Can I have full on my thing? Anyway, I think the key for me is it's not about lateral oblique trans. Can I make it full screen here?
No.
Okay, got it. I've always said this for years, it's not about how you go there. I think it's important. For me, it has been a huge transition of 23 years, God knows, maybe 24 years of lateral, where I've gone through everything. Did trans-Psoas, did the oblique one, did pre-Psoas and everything. And eventually for me, the transition has been to try to stay pre-Psoas. And I will differ with Martin a little bit. It truly is pre-Psoas. It's not even in the anterior part of the psoas. And hopefully you can show some anatomy to get there. It's identifying the vessels, knowing where the vessels are, try not to retract it, and place it anteriorly and use areolar planes. To me, that's the definition of MIS. So we're trying to stay as minimally invasive as possible and not dissect or move anything. And then, as that, like Martin said, there is lateral position for all the levels from 5-1 up. That'll help you do that if you do that. And you can manipulate the entire anterior column whichever way you want, which I think is the key to corrective deformity. And with all these patients we've treated circumferentially MIS without a single osteotomy and not even a facet resection. And the whole question is, yes, can we do this without osteotomies, without tissue degeneration and devascularization? It's not about an incision. It's about preserving the muscles and everything else to keep it going, which to me is what makes it MIS. And it's purely done with ligamentotaxis. It creates a harmonious physiological reconstruction without any osteotomies whatsoever. Basically, you're literally stretching the tube out and creating a ligamentotaxic correction of your deformity. It's a protocol we published in 2008. I'm glad to see a lot of people following it. And it's pretty much what has become the multi-levels. You do first, stage it 2 to 3 years later, 2 days later, sorry, you do the posterior. But today, if it's only 4 levels or less, I'll do it the same day. Healthy patients, so on, get it done the same day. The entire technique in its totality has been completely published now. It's a segmental interbody muscle-preserving ligamentotaxis-enabled reduction. This is all in the ISAS journal. It's in detail. Anyone wants to read, please read it. It's all there with enough and lots of pictures of how we at least go about this. Every patient gets all this. Everyone gets an X-ray, actually will not operate unless they have it. And every single one of these has significant relevance to how we plan the surgery. To me, it's not about numbers. It's not about degrees. It's all pathoanatomic in the way I make my decision of how I'm approaching these patients. To that extent, the paper we put through the ISSG on deformity criteria, the complexity of the deformity, and I really urge everyone look at it. What it'll do is at least make you look at things you should be looking at so that you know how hard or easy this case is going to be. So everything's falling in that green zone, you're gonna be fine. You're probably okay starting that case off. It's gonna be relatively okay. Obviously, you need to have some training. The yellow, watch it. Now, yellow is where you better have some experience. Now, I don't know what that is. Is it 2 cases for you or 25 cases for you? You have to make that decision how comfortable you are to start tackling these. But be prepared, it's gonna be a little tougher. Once it gets into that orange-red zone, it's a really hard case. It'll be good for you to get somebody to help you out. Things start going awry, things are rotated, you start getting disoriented, and a lot of things can go off. This is where problems happen. It's good to have somebody who's around who's really tackled it, or at least plan it out for you till you get that experience, and really red, you should not be doing it, period. And in the MRI, we talk about all the things that we look at in terms of when we make that decision. A lot was talked about the vessels, we'll talk back. MRI for me, besides all the things we see, because we're doing lateral, a large central disc herniation, watch it, it will not reduce. If any, it'll get bigger as you go lateral. You'll actually push this material into it, and it'll get worse than nose in your large central disc. And obviously sequestrated disc you can't take out. And I can't take out laterally, so you're gonna go in the back to take that out if that is the case. We talked about the iridating psoas, and we'll get back to that. CD is critical. I actually really will not do it 3 times we have missed a facet fusion, not seen on X-ray, not seen on MRI, and you need a CT scan. Can you imagine the fallacy of doing lateral and the facets fused in the back? It's actually fused. We're not talking of grade 3 gnarly facets. They actually can absolutely be opened up. This is truly fused. So you should look at it, make sure that's not the case, and work above and below. At least look at that CT scan. Watch those osteophytes and determine for yourself, can you break it or you can't do it? Like the simple osteophyte, like is here in this corner, that can be broken. With a well-placed osteotome, you can crack it and you can move it. And again, you got to judge for yourself where that is, where that complexity criteria is going up now, right? And trying to correct these things. It becomes a little more complex case. But look at this facet, rock solid fused on this side. So that's not opening up. If you do that, you go up or down. So you at least watch that before you get in there. Bone density is super critical for me. I've said this for years. We should not be operating elective surgery on osteoporotics, period. And I can go on record for it. There is no reason. We should be treating them. We should get them involved, and we should be operating. This is elective surgery. We're not talking of trauma, tumors, cancer, paralysis, none of that. Elective spine surgery. We should treat them. We have a very strong protocol on that. They go on PTH analogs, and all that's been published. We've shown this 13 years later of the benefits of that, and Hounsfield units increasing 85% of patients. The protocol, so 1 year of it, they get it. So it really works and is very effective. We talked about all these approaches. I choose to do pre-Psoas. To me, it's been my choice to go to. It is, as I said, different from what Martin said. Actually, we really stay pre-Psoas. I've always called it the ACD of lumbar spine, probably the last 8 years. And it truly is an ACD of the lumbar spine. Let's see why. We do an ACDF every single day with the carotid. We don't dissect the carotid. We don't look at it. We know where it is. We feel it. We get down there. I've also said this. We don't measure the distance between the carotid and the esophagus and trachea. If you did that, you'll never operate. You're actually going down there and creating an areolar plane to open it. Similarly, there is an areolar plane between the aorta and the psoas. You can actually create it. It moves. The aorta is not stuck. It actually moves 3 to 5 millimeters. So measuring the distance between the two has never actually made much sense to me other than knowing it's there or not there. But you are creating an areolar plane there, and you can get to that point. So we talked about, to me, this is the most critical part of looking at the bifurcation. That's at 3-4, and we've gone through this many times. But I talk about 4-5, that IVC left common iliac vein would sneak underneath the left common iliac artery. And that's 1 millimeter down, is completely gone. And that's what you need to watch. Go at least 3 to 5 cuts up and down. That is an absolute no-no, for me at least, for a pre-Psoas or a lateral approach. That'll be an A-lift for me. So, and that's clearly, obviously, a segmented thing. And 5-1 clearly is that. So, what is this case? 5-1 I can go. There's nothing there. I got enough room at 5-1 to go in the pre-Psoas plane to do my pre-Psoas approach, and I don't have to be anywhere near the psoas. We'll get in a minute to what that pre-Psoas is and how you know you're there. So the single position, there's 5-1 at the bottom, there's 3-4, 4-5 in between, and 1-2, 2-3 on the top. There's a routine for us, the way we go about it. That's a 5-1 exposure. We'll go down there, and if you're just doing 5-1, you just literally, this video has been played many times. I'll go fast over it. It's on YouTube. You guys can see it. It's basically go down as a regular A-lift, except your vascular surgeon needs to be comfortable doing an approach in the lateral position. In fact, I think the restraining factor is the vascular surgeon, unless you are comfortable doing it. And not many vascular surgeons are comfortable doing it. But once they get you there, it pretty much is a lot like how you do a regular A-lift. And I promise you it takes only a case or two for us to reorient ourselves. So you're looking straight rather than looking down when you do your A-lift. The instruments are the same, the device is the same, you don't need fancy tools, you don't need anything. It's the same A-lift. Nothing changes. So you don't need to create a whole new set of genre unless you want to start a new company. There's no reason for that. You can do the same thing to get to where you are. So once you get down there, it gets, and then pretty much the next thing is, obviously the ureter is right there. You can see it, it reflects with the peritoneum. You'll see it go with the peritoneum, just like anything else, and then ultimately you mobilize. You don't even have to mobilize anything, which is why it's really MIS. All you do is take the middle sacral, a retractor on the left common iliac, one of the bifurcation, and the right common iliac's already fallen down. and you're staring at the disc just like you normally do in an ALIF, except you're staring straight in front of you rather than below you when you do supine ALIF. So it's just a little matter of orientation back. You may take a few x-rays first to get used to it, and after that, it's a regular ALIF that you do. Choose how you want to do it, your incision, annulotomy, cobs, the same things, same instruments I've used for ALIF all my life. I use the same instruments here. There's nothing more fancy or different, really it's not. It's just your orientation. And I agree, some people find it a little hard, but it honestly is not that difficult. We do way more difficult surgery, and this we can easily do if we turn ourselves around to that. Iliac discectomy looks like it, and you put your prosthesis in and you move on. So I'm going to go past that. Now, if you're doing 4 or 5, and that same patient, what's interesting is you can just go up to that other incision and go and do that, and use that retroperitoneal access you have with your finger, like Louis always been showing you. Bring your finger in, and you can actually get into the 4, 5 space and drop it. But let's say you're doing 4, 5 by itself. This is for 2, 3, 3, 4, 4, 5. By the way, it's always on the left. You want to be on the aortic side. You don't want to be pre-Psoas on the IVC side. It'll be a very, very bad idea. That's why it's always left. And you'll be able to get any deformity from the left side. The crest does not come in the way as long as you plan the vessels. That's the most important one. But if it's already bifurcated way up, your crest will be in the way. That should be an ALIF. That should not be a pre-Psoas anyway. This approach, I think we've all seen, go down all 3 layers, you pop through all 3 of them. To me, I only use just fingers. I don't use one single tool. There's nothing, no Bowie. The Bowie is just up to the external oblique fascia. The moment that's done, it's fingers for me all the way. I just personally don't like sharp things. I stay away from it like general surgeons do. And I mean, everyone does what they're happy with, I guess. And then you reach for the iliac crest. I actually reach for the inside of the iliac crest before I pop through the transversalis. That's a really safe method I've found. You can push that transversalis all the way to the iliac crest, and then you pop through it. It's very, very safe. There's nothing there. Then you sweep the inside of the iliac crest, come around, everything we've talked about it, go under the rib. But please feel that. I've actually had residents be totally in subcutaneous tissue. There's a big patient, they're in the fat. They're never in the retroperitoneal space. You're actually out of it. So you have to feel the inside of the crest, come over. The next big thing, and this is where people run in trouble, is when you go down in the pre-Psoas approach, there's a tendency to go behind the psoas and pull it forward. A lot of people do that. Don't do that. You can feel the psoas. It's like a filet mignon. You go down, you can feel it there. And you just crawl your way slowly to the front of the psoas, moving everything over. And you will feel the front of the psoas. Next time we ever go there, you'll absolutely feel it. Every single time. And if it's a smaller patient, you'll feel the aorta. Just like you feel the carotid and ACDF. You'll clearly feel the aorta. You don't need to do any more than that. You're now in front of the psoas. Your finger then stays there, right? And before you go to the tube, oops, go back. Okay, so let me get here to show you one small thing here. So my finger now is right on the aorta, if you will, just like you do your carotid, in front of the psoas, and my retractor goes right over my finger. So that retractor is now holding all the anterior contents. The second retractor is over the psoas. That's the next thing. People retract the psoas. There's no reason to. The psoas is not anatomically attached to the front of the vertebral body. It has some spicules. Its main attachments are transverse process and posterior body. So it will roll out of the way. We did thoraco-abdominal approaches with shark bites for years. Never did we go through the psoas. And Jan says, you'll talk about it. And I had to go back to what we did. We just rolled the psoas back, and it was fine. We never had these issues. So it does roll back. The psoas will move. You're on top of it there, and then you'll see it. And then you can use sponge stick or whatever to clean the fat, and you'll very soon see the entire. There's the frontal. You can see it right there. You're absolutely in front of the psoas, and you'll see the disc. I'll get you next view there. And so when you put your first probe there, you're under direct vision. Here's what I meant by nothing should be crossing your disc. You can see it. And in case you see those veins, you can take a bipolar it, and go right there in front of the disc. Put your probe in. At that point, obviously take your X-ray, and that'll be the next one, right? So at this point, you can see the entire psoas. They're not going through a psoas muscle at all. You're actually in front of it now. There is a great landmark for the front of the psoas, which is called the psoas minor tendon. 85% of people have it. It's under the psoas and in front of it. The psoas minor tendon does not have anything, no vessels, no nerves in it. Now, if it's a very big psoas, then you can do what Martin talked about, go behind that tendon, which is the beautiful spot to go in a big psoas that you're having a hard time getting there. But that's a psoas minor, it's a psoas minor tendon. You'll see a nice white tendon there, it's below. It's a beautiful landmark for you to know. You can feel it, you can see it, it is there. So you know you're in front of the psoas. And then you just drop your thing down, all your retractors come out, you open it up. I've always used a 2-bladed retractor. I always want my third blade where I want it to be. I don't want my third blade, because that is very crucial for me to see the ALL. Well, I like to see the ALL and know exactly where it is, so you can place your thing. So now that you're going there, you'll see it. So that's all in front of the psoas, right? There's your disc right there. And if you go to the next one now, I'll go there. Come on, there we go. That should be better. There you go. So you can see that disc up there. This is the third retractor I talked about. I like seeing the ALL. Then I know exactly where I am, because the annulotomy for me is critical. It's just behind the ALL to place the prosthesis or spacer, if you will, in the anterior third of the vertebral body. I can anatomically see that. I'm not depending on any X-ray. I'm looking at it there. I can see it, and it's clean in the disc, and there's nothing else there. So you drop this retractor exactly where it should be, so you're not constrained, and then you do an annulotomy just behind that. So that's where it'll go. And then usually, like I like your KCP and KCT, I like that. Same order, I think we all have that same order. Carbs go in, things go in, you prepare the disc. The other thing I like is at all times, I can see the ALL. I know where it is. And I want to be just behind that. You're seeing it at all times. It's complete vision. So you know what's happening. You have complete control. I don't use box cutters. I've said this for years. I will not use rotary shavers. They're all scrapers to preserve that end plate. I think we've all talked about it. Preserving the end plate is the most important thing ever. Don't let that go. And then you put your device in. I think pretty much you guys have seen all this. I don't need to go through all that. And then, but on X-ray things, this is really critical for me. And I've said this forever. It's mobilize, 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 release, 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 move, move, move. That vertebral body has to move. If you didn't make it move and you didn't release it, you're not correcting deformity. It is not a spacer that gives you the space. You have to release it, and the spacer fills the space. If for 3 seconds, any one of you are thinking an expandable cage is going to move that vertebral body, you're sadly mistaken. You will blow that end plate if you've not released it. So all the expandable cage is going to do is fill the space you created. So take your time filling that space. Let it move. And I can promise you, it moves, you will get your deformity corrected, you'll get your lordosis, and you'll get indirect reduction. And if you did not get any one of these, you failed to mobilize a disc. It's that simple. If you take your time to do it, it's going to come. And it works every single time. And when you correct the deformity. Now, the cage is usually placed anteriorly, and we've shown that. This is now if you want to do 1-2. And this is the subcostal, subdiaphragmatic approach to 1-2 without taking any rib out. This is all published again in full detail. So if you're doing the 5-1 and you got the 3-4-4-5 incision, you can use that for the 1-2 and reach under the ribs, slowly push the diaphragm up. And what you're doing is actually pushing the costal attachment of the diaphragm. The diaphragm has 3 attachments: sternal, vertebral, that's the crucial of the diaphragm we call, and then the costal attachment. The costal is very thin. It goes obliquely under 10, 11, 12 ribs. And you can actually push it from the retroperitoneal space and sometimes even detach that. And that's okay. It's not a big deal. And then you come in at that costal attachment and into retroperitoneal space at 1-2, and you do not need to take a rib out. We actually last year showed this in the cadaver. And so that would be if you already had the other incisions. If you didn't have the other incisions, same thing. Mark your 1-2 where you want to go. Make your incision of 1 inch, 1.5 inches right where 1-2 is. Create a subacute flap and reach down to go below the 12th rib. And the subcostal area pop into the retroperitoneal space, just like we did everywhere else. Take your finger, enter the retroperitoneal space, go under the rib now, and then sweep up, pushing the diaphragm up the same way. Now you got your finger coming subcostal and up, and then from here you can drop the L1-2 and lead it right down to your L1-2 space. It's very, very safe. The only thing you have to worry about is you push everything anteriorly. everything moves. The kidney, all that moves away in the retroperitoneal space. So this whole idea of measuring things on MRI has never always bothered me. These things move. You use your finger, you make planes there, they're around. So you can ballot them anterior, make sure nothing is there, drop your probe down. I usually drop it right between my two fingers. My finger's under the rib, I drop it right down. So it's completely protected from both sides, and that's all you gotta watch there, obviously. So at the end of the day, I think what we're doing is this. I've said this many times. Think of a crumpled tube sock with blocks, you're stretching it out. The blocks have to line up. That's ligamentotaxis. Take it 2 steps further. There's a concept I've said many times. Nobody is born crooked unless they have neuromuscular deformity or congenital. Even scoliotic patients do not have a flat back. Their discs are normal at 20 and 22. What happens when you get 50, 60, 70? The discs collapse, they degenerate, you start getting spondylolisthesis, spinal stenosis, lateral listhesis, more deformity, all the problems start. Basic concept, if you put that disc back to where they were when they were 20 years old, you corrected everything on the spot. You don't need to cut anything for that. You just stretch it out and bring that disc back. So not only do they get back their height, you're regaining the anterior column that they lost, which corrects their deformity at the same time, and that is all that simpler technique you've talked about. Lordosis, a concept I've never understood why we can't get lordosis in lateral. For years we've had no problem, and we published all this. You place it anteriorly on the anterior column with a proper release, you will get brilliant lordosis. You stuff a cage in, you're not gonna get it. It's just very simple. You have to work at it to get the lordosis. You go in and release that disc and it moves, and then you place it in the anterior third. It is not the device creating the lordosis. I'm going to say one more time. It is a release that's creating it because that body wants to be lordotic. That's how you were born. Whoever you were, that's how your disc was. And now you release that annulus, you release that ligament, you released it and stretched it to bring it back to where they are. It's not complicated. We make it complicated. All we're doing is bringing it back. So that's called soft tissue tensioning or bringing it back to where they're supposed to be. We also looked at this when we looked at staging. Because we staged them, we could see that. We were getting most of our lordosis, 96% in the lateral approach. We were getting a sagittal balance already by just putting the cages and devices or whatever you want to call it. It's a coronal correction, 50% that came with the rods as you derotated, translated, and corrected. So your laterals, yes, give you fantastic balance. This idea of getting flat back, I'm going to disagree ever. And you can see time and time again, this is an AP, pre-op, post-stage 1, and then post-stage 2. And you can see all the correction there. But the bigger thing is this, look at that lateral, pre-op, post-stage 1. Look at the thoracic kyphosis. You don't believe in ligamentotaxis, look at that unwind. From 10 degrees, it came back to 35 degrees. Why? Because you rebalanced the body. You gave the lordosis she lost, it recreated compensatory thoracic kyphosis, which she should have, and everything opened up. And you look at that CT and MRI, it looks like the most rigid curve on earth. And that's the problem with me, with these rigid curves. They're not rigid. They don't move because they're hurting. As long as they're not fused, you can bring them back to where they are sequentially and dramatically. There's another patient, Power Cs, you can see that. Work the fractional curve. That's the key, to bring it back to where they need to be and realign that. Look at that thoracic curve. That thoracolumbar kyphosis that corrected. Without a single osteotomy, the body comes back to where it needs to be. There's another one, massive one. I've shown all these before. Obviously at ALIF at 4.5 and 5.1, gets a walk. She's 3 to 4 years out now. And I know her well because she's my neighbor. And they all correct themselves as they get in there. And you leave that proximal thoracic curve. So what you've done is you've got segmental balance, regional balance, and global balance. They are not coming here for thoracic curve. These people live with scoliosis. That's not their problem. Their problem is pain and degeneration as they move. And that's sort of 4 years out now. And then, this is in MIS today, what we do today. The only opening she had was a decancellation osteotomy at the apex of a thoracic kyphosis. But she had a scoliosis long-lasting, along with osteoporosis, with a collapse thing. On PTH analogs, treated and gone all the way to and now T4, PA, L1, PA, all that you can calculate and get back to where they are and what they need to do. And here's all the calculations. So at the end of the day, it's purely ligamentotaxis, pre-psoas, manipulate the anterior column. It's going to come back to where it is It's more philosophy and principles and nexus than technique. It's not a company and it's not a device. And you can use any device you want. As long as you release this and put that in, you can use any retractor you want. And no company likes me for that, but that is true. The interbody is just a spacer that's holding the release that you got. That's really critical concept in life. And that's what's going to give it to you and keep it where it is. I think there you go. You can come see us. Come see us at a fellowship. Welcome to see us, and thank you.
Neil.
Yes.
You're a wonderful lecturer and you're an excellent surgeon. I've seen some of your patients. They're really very grateful. Here's my question to you. So for instance, that L4-5 case that you showed, what's wrong with an ADR, an L4-5 lumbar disc replacement? Why is this a patient, a fusion patient? There's no central stenosis, no foraminal stenosis, no major instability.
I showed or somebody else?
You showed an L4-5. It doesn't matter, but what's wrong?
I love it. Okay, let's go
What's
back.
wrong with single or two-level lumbar disc replacements compared to a fusion?
Absolutely agree. I do that all the time.
Okay.
But that was a big deformity. No. I'm very much in favor of it.
Okay,
I think
just
disc
wanted to-
replacements are phenomenal.
Yeah.
I've done disc replacements in scoliosis, which I will not show. And when it gets ready in long term, I'll show it. No, I think it's a game changer. I'm with you. I completely agree.
I just wanted to make sure that,
Completely agree.
pursuant to my lecture, that disc replacement or motion preservation for lumbar disc degeneration, appropriate circumstances, if done appropriately, has a real role.
Fantastic operation.
Great,
I
okay.
completely agree, but not in the setting of deformity or instability. Clearly not.
Yes.
That's a different patient. Not for deformity or instability, no, absolutely not.
No, I think this replacement has,
It's okay, Dr. Uribe, someday we'll have a meeting on that one, no problem. Someday, but I won't show it till I get the long-term results. Done quite a few of them. But I agree, I mean, that's no point, but I think the discussion most, it doesn't matter how we approach it. Lateral's gone so far forward now, and I think it's more principles for me and not devices and companies and techniques and tools and retractors. None of them got anything to do with it. It's about principles of how you release, mobilize, get the spine to where it needs to be, and then use your own natural patient-specific correction. They line up to where they need to go. Anyway. All right. Any other questions?
That was great, Neil. Thank you.
Thank you.
And then our last speaker, and then we're going to have one demo. So Dr. Pimenta, who is going to discuss OLIF, lateral, prone. So it's been another awesome course, and can't wait to see what Dr. Pimenta is going to talk about.
well, I will talk very shortly about kind of comparing the three different approaches, right? Mostly more important is that I will compare, these my disclosures. So lateral procedure has been well published, right, during all these years, and everybody knows indications. You can see them here. What are the indications? These are the cases, indications here, fractures, tumor, trauma, infections. You can see more and more, and deformity. So lateral procedure in lateral is limiting by posterior aspect. Doing the posterior aspect in lateral brings some difficulties like multi-level pedicle screws. Even with navigation, if you need to take the facets, if you need a direct compression, if you need a posterior osteotomy, it is really very difficult to do this in the same position. And also you rely in direct compression that not always is the best. When you place a patient in prone, the advantage is basically what you heard here all the day. The psoas comes back, the plexus also slightly more posterior. We have better access to 1, 2, and 4, 5. We have about 75% of spondylolisthesis reduction, and the access anterior and posterior at the same time sometimes is easier. It's a real better procedure because you can work posterior, go anterior, and finish posterior without having to flip the patient. What are the risks? And basically, the literature shows that the complications, bowel and vessel mainly, are very similar between lateral and PTP. When you compare this, bowel and major incidence, you see that the numbers are quite similar. We have seen that when we talk about vascular injuries, the difference is this paper here that is actually a systematic review only shows 2.5% of vascular incidence. Other than that is a very similar results. We have also heard and published that in OLIF you have neighbors. Usually I say, and we saw the videos from Neil, that you arrive over the vessels, you work on the side of the vessels, and from that you dissect the psoas backwards, which means that you work very close to some neighbors, that one day the neighbor can come and visit you and you have to be prepared. Which I mean that we work close to the nerve, close to the ureter, the bowel, and the sympathetic chain. And it's no surprise that should have a little bit more complications in this area here. We have some papers that we publish on complications on prone lateral. We have one that is a multi-center survey, 1,900 cases between 32 surgeons, and the rate of complications actually is vascular and bowel very low. Still neurological complications not so low, and this is because we included the learning curve cases, different from Juan's paper done years ago that he excluded the first learning curves in this study. But anyway, we did also a study on the retroperitoneal space. I was prepared. I took so long my failed demonstration that I couldn't show you the open aspect of the retroperitoneal space. The distance from the quadratus to the bowel basically is 3 times more space in prone compared to lateral. So this is important about showing the risk that we face is how we avoid that, right? So how we avoid hitting the bowel basically is learning where is the bowel. And you see that we did a study in cadavers that we place guide wires before cutting anything on the direction of the 50-yard line. And you can see here the quadratus and here the retroperitoneal space, and the distance from the quadratus to the bowel was measured in lateral and in prone. And we found that in the prone position, this distance, because of gravity, is much bigger and easier to prevent bowel injuries. Again, controlling where your first dilator goes to the psoas and being able to touch the psoas is very important. Why I'm against OLIF, because I don't like to, first of all, OLIF was developed because Medtronic didn't have a good neuromonitoring, so they decided to go anterior to the psoas, which has been done forever, so for more than 50 years. The deformity surgeons would do this in an open fashion, like a shark bite procedure, and dissecting the psoas backwards. But although they don't use neuromonitoring, they report neurological complications because the plexus is pushed back. So once the plexus moves, the nerve may suffer depending on how close you are, how much you distract the plexus. We learned this and we try to avoid. So the best way to understand the complications and the rate of complications is learning how to avoid that. So we have to think on all these complications, why they use shorter cages, why they end with a cage oblique to the contralateral side frequently. You see the olive frequently goes oblique to the contralateral, frequent goes to the, not so frequent, but they go in direction to the contralateral foramen and has more risk to have some other neurological problems contralateral. Anyway, this is short, but I try to be very concise. And any questions?
Any questions for Dr. Pimenta? I just have one, Dr. Pimenta, is that, you know, when you were doing that discectomy, I think for me, it's always like the most important thing about doing lateral is I do think understanding the planes, and, you know, people didn't see it very well, but you're very careful, and you taught me about getting into the retroperitoneum. Can you just talk for 1 second about those moves? Because it was kind of hard to see a little bit.
Usually when they do single incision,
Yeah.
you go through 3 layers of muscle, right?
Mhm.
Oblique external, oblique internal, they have different directions. So you know that you go from one to the other because
Right.
the fibers change directions. But then you use dilator, retractors until you cross the transverse fascia, and then you see, when you go straight, you see the peritoneum in front of you. When I go more posterior, close to the quadratus, I can be aggressive because never the peritoneum will be posterior close to the quadratus. That's why I think this is safer, not only because of that, because during the procedure, the full procedure, I keep my finger inside the retroperitoneal space and I guide everything that goes to the psoas with my left finger. So I can go around the dilators and the retractor and make sure that I avoid 100% grabbing a bowel or vessels.
Yeah, I think that's a really important point, especially if you're just starting lateral, is understanding the relationship of the muscles, the retroperitoneum, and then how you get into it. Because I remember when you taught me, we were doing 2 incisions.
Yes,
remember?
Exactly.
And sweeping everything and then guiding it down.
Time, so
Yeah.
from the beginning.
Yeah, so I think that's an important point. And I think we saw, you know, Neil was doing it with O-lifts, but I think because you don't have the same, it's a smaller incision. Yeah, that's perfect. I actually love that. Yeah.
Yeah, so that's the best way to be safe. So you go close to the quadratus, even if it's a Japanese that is super slim, has a small triangle of fat in front of the quadratus.
Omar.
I got a question for you. At the end, when you close your incision, how many layers do you close? Do you try to close every layer or just one big layer? Yeah.
That's a good question. I try to close the only fascia that really matters is a transverse fascia. If you can stitch the transverse fascia, great. But I can tell you it's hard and dangerous. In my hands, I just do 1 stitch on the muscles I do 2 or 3 stitches, but I don't go as deep as the transverse fascia because it's really a risk that you grab a piece of bowel together.
Yeah, I just wanted to add on Dr. Skuyen's comment there. It is quite daunting when you first start doing prone transpsoas because the distance is greater, especially in obese patients. And so your technique, which Dr. Taylor has a modification that's very similar of using the Perk incision, poking through lateral to the TP. But the same thing is that it helped me be very confident because you're looking at this sometimes 180 millimeter passageway and you're saying, well, how sure are you that there's nothing in between? I have to be, 100% sure. And your technique there is very reassuring because the tip of that dilator is never touching anything other than your right index fingertip, your left index fingertip, or the psoas. So it's always at a known spot all the way there. And if you feel...
I'm used to say that people are afraid of big patients. I always say that big patients means more fat, which means also bigger retroperitoneal space, makes it safer. More difficult because of the length of the retractor, but on the other side, it's very easy to reach the retroperitoneal space, and when you go posterior, sometimes the full hand goes under the skin for the first fascia incision, and then you work in direction to your finger again to the psoas muscle. It's always controlling the tip of everything that you drop to the psoas.
And because this is being done blindly, if you feel something soft and squishy between your fingertips, you can always just rub your fingertips together. And if it's fat, it'll just efface.
Yeah, and
if
it
it's
doesn't
foul.
change if you use navigation, looks safe, but you don't know, right? You don't know what the soft tissue, what's happening. You only know the direction to the bone, the disc, etc. Thank you.
Great. Thanks, Luis. And then just to kind of close out, we're going to go to the lab. I'm not sure if Neil's ready yet, but I thought maybe discussing sort of the thoracolumbar junction and how to manage the diaphragm, especially on deformity cases. I know Neil talked about that, but I think it's an important point and something that's not well taught. And especially if you're going to do lateral, I think, you have to understand the relationship of the diaphragm to the peritoneum to the chest. So hopefully, I think Neil's in there with Cameron. We can get a little bit of, and I think, some of the thoracic stuff and some of the anatomical stuff we talked about before. And then we'll finish up our 11th course. So how are we doing in the lab? Oh, okay. All right. Okay. Okay, 5 more minutes, they said. So maybe what we'll do is, why don't we take a 2-minute break. Did we have a break already, Corey, or should we keep going? Take a little break? Okay, we'll take a break. Let Dr. Anand do a masterful exposure, and then we'll be back.
Better, yeah.
Uh-huh.
Sorry.
No, no worries. We are good. I think I'm on the mic.
Check yours too. All right, good.
Ready? Ben, is it looking good? Okay. Okay, we're ready? All right, Neil.
Hey, hello there. I can
We're
hear
ready.
you.
We're ready to go. Who is that?
All
Good
right, let's
looking.
go.
Who's the good looking guy next to you? Is that Mark Kramer?
Obviously, I'm Neil Anand, and we got Mark. Mark indeed, who will help me out. And since we got Uncle Bernie between us and some cocktails, I'm hoping Uncle Bernie will behave, and we can all
Nice.
go home soon. All right. So basically, I marked a few things here. You can see here's the iliac crest. The leg is to my right. The head is to my left. Iliac crest is marked out here. Can you see that on the camera? Then I marked out the 12th rib, 11th rib, 10th rib. I don't know if you can see that. And then this is the X-ray there. This would be the middle of the L1-2 disc. That's all I want to know. My incision is right on it, right on where the L1-2 is. That will be the incision. And we'll go down and do the subcostal, subdiaphragmatic approach to 1-2 without any rib resection. As I said before, it's all finger for me. I can feel the rib below me. Now all I'm gonna do is, if I had a Bowie here, create a subcutaneous plane. Get a pickup. I can take a meds, it's okay, if it's faster. You just create this plane here with the Bowie, usually I'll do that. Create like a subcute plane here to head down towards the 12th rib from where I'm gonna enter the retroperitoneal space. So I can feel it right there. I literally can feel, can you guys see up there?
Yeah.
So I'll do my best to show. How do I show this? So here, can you see, here's the 12th rib. I think you guys can see it. 12th
Yeah,
rib here.
we can see it nicely.
11th rib here. My L1-2 centered right at the center of this incision, made the incision, did a subcutaneous plane to the bottom of the 11th and 12th rib. Once I get there, I now want to enter the retroperitoneal space, right subcostal, below that rib. You can enter the same way as we entered everything else. All day we've been talking about entering the retroperitoneal space, right? It's exactly the same thing we'll be doing, except I'm going to do it with my finger. And usually in the human body, as we all know, is much easier than a cadaver, but we'll do it here without any meds, because as I said, I don't like it, and I'm good at getting in there. It's all opening up, it is. And I'm in. I'm in, I can feel the inside of the iliac crest there. I can feel the underside of the rib right here. So basically, I'm in the retroperitoneal space now. Now I'm feeling down, and I can feel the psoas. Even though it's rudimentary, you can feel always a muscle going around there, and you'll feel the vertebral body. So as long as you move everything anterior, which I'm doing now, everything's moved out. Like, Bill Taylor said, you can't see it, but you know when you're in there. That's a retroperitoneal space. You absolutely know you're in there. It's a very wide open space with nothing there in your hand. So what I'll do is take the first probe. Remember, we had it centered here, right? So we can do one more time center to know the entry. We can take one more X-ray to know exactly where to be. Give me a shot there. You get there. So things moved a little bit there. One more there. So it's around there. I know where I need to be. So pretty much I can bring my probe in here. My finger goes in retroperitoneal space. The finger goes like this, literally. One's posterior and one's anterior. And I usually drop my probe right between the two and then guide it all the way down. So my finger's gonna go in there. It's underneath the rib right now. And literally I'm gonna pop right in. Now when you pop in, you don't pop straight. You pop in like this. So you pop into the retroperitoneal space. And what it does is it goes just past the costal margin of the diaphragm. The best way to look at the costal margin is probably, it's sitting like this, literally. And imagine that's your ribs right here. It's a very thin attachment. My finger's already here pushing it. I may have even have knocked the attachment off already. But essentially, I want my probe to come like this, in and into the retroperitoneal space. This being the retropleural space, this being the retroperitoneal space. And you want to pop in. Once you pop in, then you straighten it out, and you go straight to L1-2. So you will be, let's go back here, my finger back in there, feel it, and you just got to pop in through this. So now I'm popping right in there, and I'm in. I'm totally in the retroperitoneal space now. But obviously now I'm going to L3-4, L4-5, way down, right? So now I straighten out in the retroperitoneal space. My fingers are protecting everything and guide this thing all the way down to L1-2, and I can actually feel the disc there. Hopefully that is the right disc. And then you take your X-ray at that point, and hopefully we're on the right spot. All right, can I have something to hold this?
Neil, do you ever, have you ever dropped the lung when you're doing this?
No, not for this at all, no. I don't need holes. Okay, give me a Coke or something. X-ray. Beautiful. We are right where we want it to be. I could feel it. If anything, I'm going to go a touch posterior. So I'm going to go there. Can I have a Coke or something to hold it? Yeah. So literally it drops right to where you want it to drop. X-ray again, please. And that's what happened. Diaphragm, X-ray there. We got to where we want to go, but now we lost. There we go. We'll get it. Try that. Bingo. And that. There. It's there. I got it. And again. It's slipping. There you go. Oh, give me that. Hold on. That's what happens. My finger needs to be there. There we go. It's so much easier when you put your finger and feel it, and there you are. Okay. That's got to be right. There you go. Got Coke ring in. Done. Try that. Bingo. Now, get me the, one more time. I'm dead where I need to be. I totally could feel the disc, so I know I'm there. Now, usually I put a guide wire in. Do you have a guide wire here? Let's tap a guide wire in. Usually I have a probe that drops right into the disc space, but let's drop this guide wire in. Ah, shit, moved. Excuse me. Go ahead, someone tap this in. Not just tap the artery, pick up. Tap that, yeah, you go. There you go. There you go, there you go. Go somewhere, don't worry. Okay. Give me a shot. That's fine. In fact, I purposely did this, believe it or not. I don't care where that wire is. This is purely a guide for me to know where to go. And you'll see what I mean by that. My second dilator went in now. This goes in there, my finger's always there. Just goes right down, same way, right down between the ribs, next one. There's absolutely nothing between me and the spine right now. What do we have? We got a retractor? Like a 120 or something?
Like a 120, yeah.
All right, the other thing I wanted to show, so that's the approach down to the disc. What I did want to show, the other thing was this retractor that J&J MedTech has. Quite interesting in that they have this beautiful light source that goes down with a camera. Oh, my finger strapped there, there we go. There's a camera that actually goes on it. Before we go anywhere, just give me one shot. Very good, don't worry, I'll adjust that next. Stay right where you are now. Go ahead, connect the retractor. To me, literally, this is just a placeholder. That guide wire is a placeholder for me to place my retractor in the vicinity of where I need to be. And it is there right now. We'll just lock it for now, and we will go to the AP view, please. If you can flip that over, go to the AP view and let just the rest on that. So they have a pretty good light source with a camera, which is the only other thing I think is worth showing. I really don't think we need to do a corpectomy or discectomy. You've seen enough today, I think. It's really the approach that's the critical part, which hopefully carried forward to you guys there. There you go. It's way up there. He's going to center it for me. Can you center it? But I'll show you how I correct that in a minute. A little bit more. Okay. Can I open this? Give me the... Or how do you open it? No, you're good, you're good. I just want to open the retractor. Go ahead. These two? Yep. Now, it usually is pretty tight between the ribs, so it'll start choking up on you. I'm gonna let you do it, go ahead. You do it, open it, and then toe both of them for me. It's better to toe it on both, that's enough, toe it here. It's better to toe it because under the rib it works better, that's it, that's enough. Give me a shot, x-ray, beautiful. You saw that wire meant nothing right now? The wire, didn't matter where my wire was. My retractor is dead where I need to be. That's all that matters. So all these things come out. The wire can stay where it is. We take these out. Now he's going to give us a light source. We're going to look down this, and we're basically going to do our L1-2. Yes, the x-ray needs to be adjusted. Yes, it's oblique. All the true lateral purists I know are looking at that. I'll get there in a minute. I just wanted to emphasize the approach really more than anything else. You want to get one more? So this light source has a camera at the bottom of it that will allow you to see, as you can see there. Are they seeing that? Yeah. You guys are seeing that? Okay.
Yeah.
So this is the television light source with a camera, so you can see everything there. So here's my wire. You have a suction there at all? So I'm sure you guys have heard of you have something narrow? You heard of television, which was there on T-lift all the time. Now it's also here in, obviously now it's also here for the lateral. So this time, remember I had a lateral before? I know I'm in the anterior third about of the disc space in the sagittal plane, AP plane. I'm good, I don't need that. Doesn't, not bothering me at all. Leave it alone. Just for completion, I never have a third blade. You can see how it comes in the way. You just need one up and one down, and you can do your entire job. Well, he's going to take the third blade out. Here we go. Awesome. Then we can see that disc, and then literally it's a discectomy like we've been doing all day long on every cadaver so far, except my disc is going to be just below. Give me your number 4 Penfield. Do we have a longer, thinner sucker and not a big one like this? Like a thin, long sucker? That's just too big for this hole. My disc should be right here. Here's the cruise of the diaphragm. If I just get one more, I can show it. And you can know, oh, this won't work. There's no room for it. It's too big. It's too big for getting in see. Nobody can see anything if you do that. Sure. Yeah, give me something that thin. There you go. It also, I believe, we are too short.
You can actually see it pretty well, Neil, with the intelligent camera, yeah.
No, it's a beautiful camera.
Yeah, it looks good.
I just wanted a thin sucker so you guys could really see. I can barely reach down here. The other thing is you can also operate looking at the screen. And over time, I've got comfortable operating looking at the screen. Here's the disc, by the way.
Nice.
I got a lot of cruise of the diaphragm, but short of that, the disc is right there. I think you'll start to see the disc very soon. Yeah. It's basically go between the cruise of the diaphragm, and I am there. That's disc. We can take an x-ray if you want x-ray there. You know, I'm right on the disc there. So now I know that's disc. And now you do your annulotomy and do your discectomy. If you want me to do that, I'll do it. So if this was a corpectomy now, I would actually take a small piece of rib, only because it allowed me to extend this retractor to the disc above and this particular disc, and let's say we're taking the body in between. And usually if that's the case, I look at both discs, do the discectomy first on either end, and then go and take the bone in between, and the rib we got can be used as a graft, or a spacer, or whatever you want to use. It's whatever you want, but they're basically the disc. You have a knife?
Yeah, we're working on one right now.
We have one, it's not the 15 blade, unfortunately.
Okay.
It's fine.
We're waiting on a knife. All right, either way, let me play around some more. Here we go. Ooh, that's a long blade. Okay, here we go. That should be the disc. There you go, I'm right in it.
So Neil, you don't use navigation, you use fluoroscopy?
Nope, I use fluoro all the time. Like I said, to me, I very strongly believe in the integrity of the end plate. I have a hard enough time keeping it intact, even with fluoro, in the deformities we've been doing. So I think till we sort that out, X-ray here, this just tells me I'm in the disc. I mean, I can go ahead if you want, or we can maybe pass some questions, or rest Uncle Bernie here and relax over some cocktails. But seriously, right now it's just a discectomy. We all know.
Yeah, no, I think this is great, Neil. Great way to.
I think the camera,
end the course.
the camera, I think was another thing I really wanted to say. It's really cool, these guys, what they've done. And you guys can see the monitor, right?
Yeah.
So if you're used to it, you can just look at the monitor, and the magnification is ridiculous. So we could literally go in. At this point, honestly, I can take my wire out, right? I don't need the wire anymore. So the wire was just a channel or a conduit for me to go down. You got a carb or something, small carb, we'll pop that in. Go ahead. Ooh, that's a big one. Small one. There you go. This is my usual routine. I have small carb, big carb, rasp, chisel if needed. There you go. X-ray. Little mallet. There you go. And again, bingo. There you go. X-ray. There we go, beautiful. I did want to make another point. There was talk about resecting or going across the annulus on the opposite side. Personally, for me, I would strongly say, please do not. We can talk offline, why I say it. I usually will go all the way to the end here. X-ray there. I'll go all the way to the end, but not through. To the lateral border of the pedicle, assuming that's a good X-ray, by the way. We do need to correct the rotation in there, but take it assuming that's a lateral border of the pedicle. At this point, I'll just sort of twist and rotate and stretch that annulus. Rather than cut it, I do not want to go on the opposite side. I want to just stretch it, stretch it, stretch it, and we'll keep now dilating it as we go up. Now we'll take the bigger carb next, so this will come out now. Take the bigger carb and just keep working away like everything else. So that is only the other small point, at least. For me, I do now. I think it's important, but that's okay. I mean, we all have our own techniques, I guess. Give me the large carb. That's a pretty large carb. There we go.
Wow.
Mallet. And there, X-ray. Yep. So usually now here I have a dilator or like a spade that goes in. It's 6 millimeters. I like that a lot. It works really well in collapsed discs. And I usually use that and drop it right in. But you can see the whole disc is opening up the, what do you have? What do you have next? Your trial?
Rasp or box
Give me a rasp. You go with the rasp. There you go.
Yeah.
There is a box cutter here, which I will totally put it away. I told you guys I will not use a box cutter. There you go. It's a rasp. There you go. And then once you get used to it, you don't need to take 100 X-rays. I don't need X-rays now. You know, I know where I am. This is my plane. You guys can see there where you are. And the only thing I want to do now is to know how deep I went. So give me another mallet again. Give me an X-ray there. There I'm pretty much where I want to be. That's it. I don't want to do any more. And now you got all this out. Now I usually take a dilator, whatever, 6 or 8 or whatever we have. And like I said, work, work, release, release, move, move. To me, that's really, really important. All in double and triple time, keep repeating myself. And you will see this move. You need some dilator, they're running to get some dilators, but right now it's all the same thing, right? Pituitary and all the usual things we do every day.
That's great, Neil.
All right. Yeah, I think we stop now, right?
Yeah, that looks awesome. Thank you so much. What a great way to end the.
Anytime, guys. Very good.
course.
Thank you.
So-
Oh, we're good, we're good. You're all right. They got me a dilator, so we're gonna go for that. Here we go. You're being very efficient today. There we go. Bang, bang, let's go.
So with that, I think, we're going to conclude our course and want to thank all the amazing faculty that we had this year. And
There you go. There's some
Dr. Anand is going to try to fire
There
in
we
the
go.
last cage.
All right. Good
So hope to see you guys next year.
All right.
And thanks again for
Good.
everyone
All good, man.
and all our
Thank you.
industry
Oh, thank you,
sponsors
guys.
as well.
There you go. Anytime. Oh,
Great.
cool. Go for
Awesome. Thanks, Neil. Good stuff.
All right.
No, of course, and these are always great courses, and more for me to learn. You can tell my experience, but it's, that's how I got started.
Yeah.
Yeah, thanks, thanks for having me, Rod.
Yeah, of course.
Awesome, had an awesome time, great time.
Yeah.
with this week at SSF video?
I don't know what that is.
You don't know what that is? Well, you probably haven't. If you have like 5 minutes, I will go around and grab my camera.
Yeah, sure.
So we do these every week.
Thank you.
Yeah. So you're in town usually 2 weeks on.
So 1 week on, 1 week off. 1 week on. Yeah. So, I'll let you know next time.
Yeah, let's definitely, let's
talk tomorrow.
Yeah, and then,
when you get
I
back
have
in-
a script where
Oh,
it's
and
just
that's actually
happening
Monday,
that
I'm
week
going
at
to
SSF.
Robotics.
Oh, that's cool.
I'm gonna go in front of,
You down? Yeah, okay, good. Cool, let me go grab my
Have you heard
camera.
of
I'm sitting
CDL?
in the lab right now.
CDL,
Convert
it's
their
like
signal.
an accelerator.
Yeah. So I'll be right back.
Yeah, so they're out of Calgary, they also do Seattle as well.
Okay.
And so I did that one, and I made it through many rounds, even in front of like VCs and investors. Coach, went to the next level. Yeah, man, trying to raise the funds to get through the EA. I kind of self-funded the whole project.
Wow. That's awesome.
It's an interesting journey, but it's one that's reproducible for a lot of us surgeons who are interested in it.
That's cool. I definitely, I would love to, I'd love to talk to you some more about it. See how I can help. Yeah, appreciate that. Yeah, honestly, and like I said, anytime.
Yeah, no,
you
I
want
know.
something.
Yeah, sure, I mean, I definitely keep doing it.
Yeah. All right, man. Okay, Omar. Okay. Yeah, great to finally hook up. Yeah. Did you guys meet Mark?
Yeah.
Okay.